Good morning and welcome. We will begin our day. If we could have everyone, if there's not a seat, we don't want people standing in the back. We will have staff available to call you in when it's your time to testify if you're waiting in the hall. But we can't have people standing in the back of the room. So please find a seat or wait in the hall and we'll call you when it's time to speak. So with that, I'd ask Senator Abard to lead us in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good morning, all. We've got a very busy day today. And out of respect for our time and respect for the fact that this committee is racing against the calendar, so we have to finish all of our work, at least all of our hearings today. We will be limiting speech from the public to 3 minutes, and I would ask, or 2 minutes, 2 minutes, and I'd ask you to keep your comments to the point on topic. And please be mindful, if the point has already been made, we will have already heard it. So I would also ask, if you're just reading a letter, you can submit the letter and we will get that as well. So with that, I want to recognize, open the hearing on Senate Bill 246. And I'm going to recognize the prime sponsor, Senator Ricciardi. I'm going to open the hearing.
Good morning, Chairman Rochford and members of the committee. Thank you for your time today. For the record, I am Denise Ricciardi. I represent District 9, which is 13 beautiful towns from Bedford to Hinsdale. I'm so excited to be here and sponsor Senate Bill 246, which we are affectionately calling Momnibus 2.0. This critical legislation will impact moms, babies, and families across New Hampshire. A little bit of history. Momnibus 2.0 builds off the success of Momnibus 1.0. Momnibus 1.0 was a bill I co-sponsored 2 years ago with Senator Whitley, which began the work of improving services for moms so that New Hampshire families can be healthy and strong. We had unanimous support in the Senate, and it passed in the biannual budget with broad bipartisan support and was signed by Governor Sununu. We are already seeing the positive effects of the legislation, with many more moms able to get the postpartum care they need. Momnibus 2.0 improves maternal mental health. It expands family supports, it strengthens workforce protections, and it offers support to moms across New Hampshire. Senate Bill 246, this bill is comprehensive, and there are several experts behind me who will talk in more depth to each piece of the legislation, but I would like to give you an overview of the bill. It improves maternal mental health screening. It addresses barriers to accessing mental health care. We do this by allowing providers to bill for maternal depression screeners on their baby's insurance, Medicaid, or commercial insurance. Sometimes moms only have 6 weeks postpartum follow-up visits, but they see the pediatrician with the baby a lot more. This is a much better time to screen for postpartum depression. The bill gives resources to providers so they feel prepared to address maternal mental health with their patients. We do this by creating a provider-to-provider consult line. We actually have one for pediatric mental health, and this will fill a huge gap in maternal health. This bill provides emergency labor and delivery training to EMS providers in rural communities. This is a great existing program that fills a gap in areas of the state like the North Country and in the Rochester area, where labor and delivery units have closed. I believe we've had 11 close in our state. It studies opportunities to support independent birth centers. We are now down to just 3 independent birth centers, since several have recently closed. These centers provide choices to moms and are crucial to remain open as labor and delivery units close. This bill starts the ball rolling on what a perinatal peer-to-peer support system would look like. We have peer-to-peer mental and substance use programs, and there are programs across the country that do this for moms too. We want to start this in New Hampshire. It ensures moms can attend postpartum appointments and parents can bring their babies to their pediatric appointments. Right now, moms can leave work to attend their prenatal appointments, but this extends it to postpartum appointments and a limited number of pediatric appointments too. This is crucial for health of the babies to take their appointments in their first year of life. It expands access to critical home visits for new moms in the first year of their baby's life. These visits catch early issues on and be a huge support for our moms. We did a lot of work with stakeholders, and we have consulted and had many, many hours of conversations with moms, OBGYNs, pediatricians, nurses, commercial carriers, businesses, human resource folks, the Department of Insurance, Safety, and Health and Human Services. We've made changes to the language and sections of the bill to make sure that the bill pleases everyone. So please look at the amendment that reflects all those changes. You should have that before you. I'll address a little bit of it right now, if that's okay. While there are some minor tweaks in language and effective dates, the major substantive changes to the bill include eliminating fertility appointment job security, eliminating PFML job security, adding pediatric appointments with careful limits, moving the study of independent birth centers from insurance to Health and Human Services. Again, we have a lot of people behind me that can answer many of your questions, but in closing, I am very proud that Momnibus 2.0 has bipartisan support again, because making sure moms and babies have the support they need is something everyone can get behind. Supporting our moms and families is a shared value across our state and across parties. And I'm extremely proud to be introducing this legislation with my friend and colleague, Senator Apprentice, who shares my dedication to this bill. We're working together with senators, representatives, Republicans, and Democrats, and we are very excited to support moms. This is a shared value for the state of New Hampshire, and thank you for listening to my testimony this morning.
Thank you very much. Senator Apprentice, unless there's questions for Senator Ricciardi. Senator Apprentice.
Thank you, Chair Rochford, and thank you, Senator Ricciardi, for the introduction and for laying out the structure of the bill. I'm going to take a 30,000-foot view and come right down to the ground, and I will do it in an expedient and articulate manner. So here's what we know. New Hampshire, when moms thrive and their babies are thriving, the New Hampshire families are thriving. Our workforce, our public education, our communities all feel this. And our communities are the bedrock. You know, our 235 cities and towns are the bedrock of the great state of New Hampshire. But we know that not all moms' birthing journeys and, being in that postpartum state is the same. There's great joy, but it can be followed by serious mental health issues. And we talk throughout this legislation about postpartum depression. What we know is that in not just New Hampshire, but in northern New England and across the nation, that the rise in maternal mortality has been primarily linked to mental health issues, as well as substance abuse. With Momnibus 1.0, which is about two years old, we set the groundwork for where we are today. Okay, so we extended Medicaid so that these new moms had health care from 60 days. It was at 60 days. Now it's at 3. It's a full year's worth of health care in order for them to have comprehensive, consistent treatment and to get well. Putting them in the position to be the thriving, joyful member of their community and managing their postpartum mental health and potentially substance abuse issues. We know that medical issues, mental health issues, and substance abuse issues don't stop at 60 days. But Momnibus 1.0 put that in place. So now with 2.0, this is a comprehensive wraparound approach because we've had the time over these 2 years to look at the places where this is working well and look at some of the gaps where we can bring folks together. And you're going to hear a conversation today, and Senator Ricciardi laid it out and talking about connections for, call centers, the ability to call somebody to get assistance when you have questions about postpartum depression, because not all obstetrical care providers, as good as they all are, not all of them are specialists in that area. So we needed to bring some resources to that, bring some peer-to-peer resources for postpartum care between moms as well. But I want to focus in, as we're looking again at this systems approach, breaking down the silos and connecting healthcare all together around our families. The two areas that I just want to quickly focus on as I come down for my landing is that we have two sections here that are it's all important to me, but funding emergency medical services education, and as well as looking at what's happening with our independent birthing centers, identifying barriers and working to break down those barriers. Here's why. And Senator Ricciardi also stated this. In the last 20 years, 11 labor and delivery units have closed in the state of New Hampshire. Okay, and it is primarily in rural areas, in Senator Rochford's district, but also one of the most recent closures is in Senator Birdsall's district over in Parkland. So this is a statewide issue where we're seeing less and less places for moms to go and deliver their babies. Now, most laboring and delivering happens without any type of complication. But the further you are away from a hospital and a place to deliver your baby, if you should have one of these complications, it's important for us to double down on the education we provide for EMS providers so that they know they are up to date and well prepared to manage these critical emergencies that could impact the life of not just a mother, but a baby. That's why we were looking to reinvest in additional training for emergency medical services, our wonderful paramedics and EMTs. And then lastly, as I mentioned, the number of birthing centers closing, we're down to 3 birthing centers. We saw one of the most active ones in Concord close within the last 2 years. But we have to seriously look at what is causing this and look to turn that around, because this is an alternative for women who choose to give birth outside of the hospital. And we saw during COVID, where once these two groups were maybe not as much together, that they came together, so deliveries inside hospitals and independent centers started approaching things in a much more collaborative manner. But we can't have any more of these centers close. We need to study the reasons why, and we need to be able to address those. So whether you're in Colebrook, whether you're in Keene, or whether you're in that's the Monadnock region, any part of the state, you have a place where you can safely deliver your baby. And if you should have a complication on the way, the emergency medical technicians will be well prepared to take care of you. So in support of prosperous and inclusive communities and thriving New Hampshire families, I hope you'll support myself, Senator Ricciardi, and our other great co-sponsors in bringing Momnibus 2.0 over the finish line. Thank you very much. I'm happy to take any questions. I do have to go introduce a bill over in ED&A, so I'm going to scoot, but if you have questions for me, I'll take them first.
Any
okay?
questions?
Good job.
No, thank you very much.
Okay, thank you. All right, let's see, I'll be back.
Representative Boschman.
My voice is loud. Thank you, Mr. Chair, and thank you to the committee. I'm just setting my stopwatch so that I watch the time. My name is Paige Boschman. I am a representative, and I represent Hillsborough 3, Nashua's Ward 4. I am also a nurse. I am a maternal child health nurse of the last 15 years, and I am certified in perinatal mental health through the only certifying board in the country. I have built several perinatal mental health programs, and peri means around. So that means pregnancy and postpartum. I've built one in a large hospital system where I triaged over 100 women that first year. I have also built in-app coaching programs focusing on pregnancy and postpartum mental health. and have thus talked to hundreds of women. Before I go further, I want to give you a little idea of the prevalence of maternal mental health. We know that about 20% of all pregnant people will develop a perinatal mental health condition, such as depression and anxiety. Now, to give you some reference, I'm sure many people have heard about gestational diabetes or high blood pressure during pregnancy. The numbers change year to year, but they hover around 2 to 10%. So when we're talking about the prevalence of mental health, that's up to 20%. But how much do you hear about diabetes testing and getting your blood pressure taken? We have almost no screening for perinatal mental health, and yet it's the most common complication of pregnancy, and in fact is the number one cause of pregnancy-related deaths in this country, and that's per the CDC in 2022. So this is a crisis. I'd like to tell you a little bit about some of the moms that I've worked with. A single mom with 5 children who did not get caught. Her depression did not get caught until she was so severe that at about 6 months postpartum, she had to take 3 months off of work. She was completely dysfunctional. That was too late for her to get that help. That significantly impacted her family. Do you want me to wrap up?
You wrap it, you finish up, you can be.
I'll finish up. I have countless examples that I can give you, but what we do know is that we need to catch these people because only about under 50% of them actually get diagnosed and only about 10 receive treatment. We've got to do that so that we can improve the health of moms, babies, and families in New Hampshire. Thank you.
Great, thank you. Any questions for the representative? Thank you, Representative, for coming in.
Thank you very much.
All right. Dr. Heather Martin.
Good morning, everyone. I'm back again. Been a couple years. My name's Heather Martin. I'm not a doctor.
I apologize.
That's okay. I am back again to talk about Momnibus 2.0 being one of the best, most comprehensive bills for maternal mental health, especially. I work at Dartmouth Health Pediatrics in Manchester. I am the first ever maternal mental health navigator, not only within the Dartmouth system, but across the US. I am the first ever embedded in pediatrics. Why that is because maternal mental health is such a huge issue, and pediatrics is the place that we can help and support moms. So part of this bill talks about screening in pediatrics. Part of this bill also talks about peer support. That is what moms want. They want other moms to talk to. They want other moms experiencing the same things. If we have a peer support army here in our state, what a difference that would make in our maternal mortality. We need this support network for our moms. My sister, 15 years ago, had suffered from postpartum psychosis. I had spoken this story to you 2 years ago, and it was right around the time that Lindsay Clancy in Massachusetts had taken the lives of her 3 children and tried to take her own life, right? We talked about that 2 years ago. These things are still happening. Our moms are getting diagnosed way too late. And then we don't have the proper support to support them. We need a psychiatry access line where OBs, pediatricians, primary care can call to get a consult about what to do when a mom is suffering. We don't have that here in New Hampshire. We do, however, have, it's in creation right now with my wonderful, can I finish real quick?
Yep, wrap it up, please.
The governor last year, we approached him about this issue. He said, what can we do? I said, we need a center, we need a hub, a resource center to help moms. So anybody that can access resources for moms for mental health. He gave us some funding for that. We're working on that. And you know what? You want to see the response from all providers, anybody doing this work. They can't wait for this to start. We need more help, guys. Momnibus 2.0 will do that for our moms. Thank you so much.
Thank you. Any questions? Thank you very much.
Thank you.
Oh, we've got one question. I'm sorry.
Yes.
Sorry, when will that be up and running?
We're in the stages right now. We're getting a website, probably within the next month or two. And you're going to have access to a navigator that can help moms navigate the resources. Anything that they need, we're going to be able to close that gap. It won't be a hot potato. That's what we're dealing with. OBs aren't sure. Primary care, we have wonderful OBs and they're trying their best, but they need something to have that support for them.
Do you?
Yeah.
Do you know if ARPA funds were used for this?
Yes, yes,
Okay.
yes,
Thank-
they were. Yep, they
Thank you.
recognized it and it's such an amazing, I'm so grateful.
Great, thank you. Okay, Dr. Danielle Albashies. Good morning.
Good morning. Thank you for allowing me to speak. My name is Dr. Danielle Albushies. I've been an OBGYN for over 20 years in this great state of New Hampshire. And what I'd like to do is just give some practical experience to all the important tenets of this Momnibus 2.0. So we all know New Hampshire is one of the highest rates of depression and anxiety for moms in the country. And so one thing that excites me about this bill is the peer-to-peer consult line. For example, a patient comes in to my office and I've established that she has postpartum depression. I feel equipped to start a medication. I know my local resources for some counseling. Should a patient be outside that small box where she's already on medication or where she has complex behavioral health issues, has substance use disorder, I don't know where to turn. Many patients live far away from my office. They're having to drive farther to get to their obstetrician, who's their primary go-to person. I don't know where to turn when these women are outside my local comfort zone. So seeing something like this peer-to-peer consult line is very exciting for me. Another thing we see when my group delivers about 1,200 babies a year, we see a lot of women. So we're always trying to advocate for them. They're lonely, they are experiencing isolation and loneliness. They want peer-to-peer support groups. For example, our group came up with a list of places that women can go, and quickly that list is out to date. A patient comes back and says that group isn't on anymore, things like that. And so seeing that there's going to be resources for perinatal peer support for new moms, especially potentially in person, is a game changer so that we have live access to help our women efficiently and promptly. The home visit excites me very much, to extend access to home visits. So we want to extend home visits certainly to maternal mental health, but it's more than that even. We're seeing so much, for example, rates of high blood pressure. We need women to have these home visits so that they're not coming in promptly, bringing in their loved ones and babies to the office with complex logistical issues. So those three things specifically, it all excites me, but those three things specifically excite me.
Great, thank you. Any questions?
Just one.
Yeah.
Doctor, you mentioned that New Hampshire is the highest, if I heard you correctly, the highest postpartum in the country?
One of the highest, yeah.
And the cause of that would be?
Yeah, and I think that's multifactorial. I think our state, like many states, faces the same issues with, whether it's isolation, loneliness. There's so many things that I may not be the best person to speak on that about. But I can certainly get back to you on that statistic. Thank you. Mm-hmm.
I just have a quick question, kind of unrelated, but are there any indicating factors pre-birth, preterm, that would give any idea whether somebody's going to be more apt to experience postpartum depression that you can identify ahead of time?
Mm-hmm. So our patients who have pre-existing anxiety and depression, even if they've chosen not to embrace or need counseling or medical therapy, are certainly at higher risk. So yes, there are higher risk situations. Again, many factors that would go into that. We have excellent screening tools to identify women in the hospital. So all our patients, for example, at Elliott Hospital and most birthing centers, are getting screened for postpartum depression before they leave the hospital. So there's validated and excellent tools to help identify. So we're good at that. We just now need, with Momnibus 2.0, to really do good work after the identification happens.
Great, thank you. Hey, Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. Do you see more postpartum depression, first birth, multiple births, or is it consistent?
I would say it's consistent, again, anecdotally from what I see. I wouldn't say that it's specifically an issue of first-time
Okay,
moms. Yeah.
great, thank you.
Great. Thank you very much.
Thank you for your time.
Allison Palmer. Yeah.
Good morning. My name is Allison Palmer. I have been a nurse for nearly 30 years in high-risk labor and delivery. I'm also a specialized nurse practitioner in women's health and reproductive psychiatry. But it was my own experience with perinatal depression and anxiety that has shaped my passion for doing the perinatal mental health work that I'm here to speak about. My baby did not sleep for much of his first year. And during this time, he was very difficult to console. I was often irritable, anxious, overwhelmed. And despite being a married medical professional with access to care, I felt alone, ashamed, and uncertain where to turn. If I, as an educated provider, felt this way, how many mothers without resources now are suffering in silence? So I created for others what I needed for myself. I started a support group and standardized screening practices 18 years ago when bringing clinical attention to this issue was an uphill battle, and it still is. Yet, look at the colleagues and legislators that are here together today. This is progress, and this is why we need you to support the evidence-based and innovative approaches that are going on across the nation in other states. I know we can bring this to New Hampshire. Over 50% of psychiatric patients are women. Over 80% of women will have at least one pregnancy, and 50% of these are unplanned. Psychiatrists in training are not required to have education about the management of psychiatric illness during pregnancy or through the first year after birth. OBs often feel that psychiatry or perinatal mental health falls under the jurisdiction of psychiatry. Psychiatrists will often see a pregnant woman, postpartum woman who's breastfeeding and say, oh, this is not my area of expertise. I might just take her off all of the medications because it's not safe, which is not evidence-based, by the way. And then we have 40% of childbearing people experience perinatal depression, and they will go to their pediatrician because they'll prioritize their child's care over their own. And it may be the baby's PD who is identifying this, but they are not necessarily the mother's provider. So this hot potato effect leaves mothers in a fragmented system with no clear path to care at an incredibly vulnerable time for suicide and overdose. So we need two things to change this reality. Perinatal Psychiatry Access Line is a cost-effective statewide consultation service where OBs, PCPs, and pediatricians can receive real-time guidance from reproductive psychiatrists on screening, treatment, and prescribing when needed. This ensures mothers get appropriate care quickly and safely. 2, certified perinatal peer support. Lived experience matters. When you are going through a challenging time, it helps to connect with someone who has been there, done that, and come out the other side. Pair that human connection with additional knowledge, skills, and resources to support that person getting the care and treatment they need to be well. This is where the magic happens. The New Hampshire Mom Hub, recently contracted with New Hampshire DHHS, will offer a central access point to guide both patients and clinicians.
If you could
in
wrap
navigating
up your
support.
comments, that would be great.
Yeah.
Thank you. All right, are there any questions? Seeing none, thank you very much. Yeah, you can leave that. If you've got notes here that you'd like to leave with us, we'd be happy to distribute them to the committee. Okay. Let's see, Janet Perkins Howland.
Good morning. Thank you, Mr. Chair and the whole committee. My name is Janet Perkins Howland. I've been an OB in New Hampshire since 1998, mostly at Wentworth Douglas, but also doing some locums OB up in the North Country. And I'm an enthusiastic supporter of Omnibus 2.0. And I think one of the best parts about it is just the awareness that it brings to the issue. I think that despite people thinking they know, they're kind of unaware of what's going on with pregnancy and postpartum care in our state and in our country, especially the maternal mortality related to postpartum depression and anxiety. So postpartum rates are unfortunately so high that it's become synonymous with postpartum. So like, oh, I had postpartum and it was really bad. C.S. Lewis said, I've learned now that while those who speak about one's miseries usually hurt, those who keep silent hurt more. So in our office, up to 50% of our patients miss their 6-week appointment. We want all of our patients to come in for their 6-week check, but unfortunately, some of the most vulnerable ones, the ones that had to go back to work or had transportation issues, do not show up. So the components of this bill, including screening and home visitation and psychiatric care providers, can literally be life-saving. About rural challenges in EMS, I do some, as I mentioned, locums work up in the North Country, and a mother once told me that she needed a sled and a snowmobile to get to the hospital for her delivery. I have personally conducted EMS trainings, and these guys are these individuals are great. They're eager to learn, and they really appreciate the extra training. About employee protection, just this week, a patient told me that she didn't want to have a C-section because she'd only received 4 weeks of recovery time after giving birth, and she couldn't afford to take more time off and recover from a C-section. In fact, she hadn't even informed her employer that she was pregnant due to fear of reprisal. So in summary, we're experiencing a declining birth rate in New Hampshire, and we need to do everything we can to support mothers and families instead of making it more difficult. And I'll end there, even though I didn't finish my comments.
And if you do have comments you want to leave with us,
Yes,
please
that'd be
do.
great.
We'll make sure that everyone gets a copy of that.
Okay, should I just?
Are there any
leave?
questions? No, thank you for coming in. All right. I know there was a group of folks that needed to get out to see patients. Is there anyone else here that has to see patients this morning that needs to leave? All right. Very good. Thank you very much. Sophia Fontaine.
Hello, my
morning.
name is Sophia Fontaine. I am a preschool teacher and daycare provider, and I've been working in childcare for 5 years. In the time that I've been in the field of childcare, I have worked with all sorts of families and mothers and all sorts of different experiences. But one thing that I can say is that maternal health is family health. When the mothers are struggling, the children are struggling, the family is struggling. Maternal depression and anxiety can lead to increased behavioral challenges, cognitive delays, and diminished academic performance in children later in life. And one of the things that we see very frequently in childcare is that the mothers don't want to explain what they are feeling. They feel alone. They feel like they can't turn to anyone, not their providers, not the people who provide for their children. So I'm in full support of this bill, increasing access to maternal care to help families as a whole, not just mothers. Thank you.
Right, any questions for Sophia? Thank you. Thank you for coming in. Let's see. Jessica Crowley. Good morning.
Good morning. I'm Jessica Crowley from Hampton, and I'm here to share my personal story as a mom. I'll start by painting a picture of how my journey to parenthood began. There I was at my first exciting ultrasound, 13 weeks pregnant, already in love with the child growing inside me, when I learned something was very wrong. I was told I would have to wait for additional test results to come back before learning whether or not my baby would have a shot at life. That day, and in the 10 days of waiting for the test results, did any mental health professional check in with me to see how I was doing? No one did. Eventually, I learned that we were blessed with the better of the two very scary diagnoses. So then when my baby was born, I spent the next 5 weeks by her bedside in the NICU, alone, day in and day out. since my husband had to be back at work within days of her birth and her surgery. During that time, did any one mental health professional check in with me to see how that lonely, scared mom was doing? Not one for 5 long weeks. Sure, the kind NICU nurses asked how I was, but I was not their patient. When they asked how I was, I said fine, but I was not fine. How could I have been fine? I was watching my infant struggle to survive without even being able to hold her. I have a degree in psychology, but I was not able to diagnose myself and my signs of postpartum depression. I wasn't able to even realize it until years later once the mom fog had faded. All I cared about at that time was my baby surviving another day. Nothing else mattered. This is one of the many ways moms put everyone else first. The world shows us we must. I'll try to wrap up quickly. My journey to motherhood was vastly different than I imagined it would be. When I was a little girl, I dreamed of being a mom of 2. But the reality is that I felt abandoned and betrayed by the same society that told me my greatest value as a woman was becoming a mom. This bill would have helped me when I was that lonely, scared new mom, and I know it will help New Hampshire families and communities moving forward. We're not asking for a lot. We're asking for you to care about us and our families enough to give us some basic protections once we begin the parenting journey. Passing this bill will be one small way to show us that we matter to you.
Yeah.
Please show New Hampshire's moms that we matter to you. Thank you.
Thank you, Jessica. Mackenzie Nicholson.
Good morning. Thank you, Chair Rochford.
If you could turn your microphone on, thank you.
Thank you. 10 years, and it still gets me every time. Thank you for having me today. My name is Mackenzie Nicholson. I'm the Senior Director of Moms Rising in New Hampshire. Moms Rising is a grassroots organization comprised of thousands of moms across the Granite State. I couldn't have said it better than the speaker before me, so I'm just going to drop a letter off to you all. There's a list here of 77 comments from people across the Granite State who support Momnibus 2.0, and I'd urge you to take a look just because we know that when moms have access to the support they need, our New Hampshire economy thrives, our families thrive, and we all do better. So thank you so much for your support, and we ask you to pass Senate Bill 246.
Thank you very much. Michelle Heaton and DJ Betancourt.
Thank you, Mr. Chairman, members of the committee. For the record, my name is DJ Betancourt. I am the Commissioner of the New Hampshire Insurance Department. Joining me this morning is Michelle Heaton, the head of our Life and Health Division. We are here this morning in support of this legislation. I'm not going to be repetitive to what has been said. I think there's been some phenomenal testimony heard thus far. But I would add my appreciation for the collaboration throughout this process with the sponsors, with the stakeholders, with the various departments involved with this legislation. I'll tell you something you probably already know. Kate Lippman is an absolute rock star for you guys. She did a lot of great work to bring all of the stakeholders together, take in the various amendments, and get you to a nice, refined product. As you've heard me say many times before, as Commissioner, one of my top priorities, if not my top priority, is mental health. And I think one of the areas that really is in serious need of a close look is in postpartum mental health for women and for moms. I think it's an area that is really in need of some careful examination. I think this legislation advances that. I will also say that this legislation will supplement a lot of the work that the department is currently doing. We're very excited about the opportunity to draw down some federal funding for a women's health grant. Again, that's going to help supplement what the legislation is trying to achieve. I noted that the mental health parity piece of this original proposal was removed, but I want you to know that we as a department are going to continue that work. And as a result of this process, we've been able to form some phenomenal partnerships and relationships with different stakeholders that we're going to bring into that conversation to help advance that work. So again, Mr. Chairman, we are here in support of this important proposal. It works practically, and it supports, as I've said, the work that the legislature has done, the Department of Health and Human Services has done, and we have done as a department over the last several years to advance New Hampshire's mental health system. Thank you.
Great, thank you. Any questions? No? Oh, Senator Bertzel.
Thank you. Thank you for taking my question. There's no fiscal, we just got an amendment as well, so there's no fiscal note. Are you participating in it, or was it just HHS?
So I think as a result of the changes, what we would have to analyze is fairly minimal at this point, but I'll defer to Michelle.
We had drafted an initial fiscal note off of the original version of the bill. There's been some pretty substantial changes in wording that will bring down the fiscal impact. Based on the amendment that I just briefly reviewed, it would be fairly minimal fiscal impact for insurance. A lot of these services are already covered, and it's just clarifying some of that language. So we don't anticipate a large increase in premiums or anything like that from our perspective. But we will be drafting a new fiscal note once the amendment is in, and we're requested to do so.
But it won't be scary, Senator, I promise.
Any other questions? Thank you very much.
Thank you.
Representative Kutab. Saw her in here earlier. I don't know if she's out in the hall. We're going to give her a minute. I think she's probably out in the hall. Okay, good. I was going to do the same thing.
We need some elevator music.
She's not out there? Okay. Let's, Holly Stevens.
Good morning. Thank you for the opportunity to testify today. My name is Holly Stevens, and I'm the Director of Public Policy at NAMI New Hampshire, the National Alliance on Mental Illness. On behalf of NAMI New Hampshire, I am here today to speak in support of Senate Bill 246. You've heard a lot about the mental health of moms, as well as you just heard about the impacts, some of the impacts that it can have on the children. But I also did want to bring up, I tried to cross out things as we went along so I don't repeat anything that you've heard. But I did want to mention that there's also a documented link between postpartum depression and higher rates of depression in children during later on in their teen years. And also, it's critical that moms receive mental health screenings and treatment for postpartum to reduce maternal deaths, negative outcomes for the kids. And one way to encourage that is by waiving the copays, because moms will always put their kids in front of themselves. And if they're tight on funds, they're going to forego those important screenings and appointments in order to save money on the copays. And additionally, I wanted to touch on the fact that NAMI New Hampshire has seen firsthand the benefits of peers on treatment with mental health disorders. Through the Fast Forward program, NAMI New Hampshire provides family peer support to parents of children experiencing behavioral health crises. Families who have gone through the program attest to the importance of having peers involved in their treatment. Likewise, peer support for moms experiencing postpartum mental health symptoms could be key in reducing maternal mortality and rates in New Hampshire, as these moms would have the support of someone who has had similar experiences and can share that experience and how they were able to work through the symptoms and also navigate the system. So for those reasons, we do support this bill, and I'm happy to take any questions that you might
Great,
have.
thank you. Are there any questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. Would you be able to identify children that often suffer from depression when their moms are in postpartum? Is there an age that relates to it, where you see that most?
What I will do for you, Senator Long, is there is a notation, there's a footnote notation of where I took that from. I will read that article further and get that information from you and give it to the committee, whether there's identifiable information of what age those kids are when they develop
Super.
depression.
Thank you.
Senator Birdsall.
Thank you. I'm not sure you can answer the question or someone that has come up before, but listening to Jessica Crowley's testimony in the fact that when she was having concerns about the baby in utero and no one came to ask if she was okay, how would someone be notified to contact her and walk her through her concerns?
Well, I think that that's why it's so important to have those screenings done at the doctor's offices. Because if the doctor is able to detect something, they're able to then provide some resources. Because, like you said, a mom who is just alone with their depression or their anxiety, they may not know that these resources exist. I think the hub that you heard about will help if there's promotion around it as well. But I don't know as much about those resources as others may.
Thank you.
Thank you. Any other questions? Senator Ebert.
Thank you. But kind of piggybacking off of what Senator Birdsall just asked, so does this bill provide that care for somebody who's pregnant and suffering?
I believe that the bill provides for those screenings to be done both during pregnancy as well as postpartum in order to detect depression or anxiety when it arises.
Thank you.
Any further questions? Thank you very much.
Thank you so much.
John Reynolds.
Thank you, Mr. Chair and members of the committee. Appreciate the opportunity to testify today. My name is John Reynolds. I'm the State Director for the National Federation of Independent Business in New Hampshire. We represent more than 1,700 small employers across the state. Our members are in every sector, and they're generally very small, with the vast majority being fewer than 50 employees. We don't disagree with the goals of the bill. Our members want their employees to be happy and healthy, and we appreciate the changes that Senator Ricciardi has made in the proposed amendment, but we still have some outstanding concerns with the leave mandate in Section 9. First of which is the applicability threshold, which is set at 20 or more employees, which is a departure from other substantial employment regulations like the Affordable Care Act, which sets the distinction between large and small at 50 employees, and the Federal Family and Medical Leave Act, which also sets the distinction at 50 employees. The FMLA is particularly notable because the federal government has left the threshold at 50 employees because they found the cost of compliance with leave mandates grow significantly once you get below that level of 50 employees. It's also notable because large employers in the state probably already have time tracking systems to handle this type of leave, whereas small employers may or may not, particularly for part-time employees, likely do not track time or offer time in this fashion. We're also concerned with some of the ambiguity in the language. Notably, or one example is the reinstatement provision, which lacks the balancing language that you see in other reinstatement provisions in other areas of state law. And that becomes a problem because we don't know whether that applies to somebody's position or whether it applies to their exact schedule pre-leave. Another example is what the meaning of medical appointments for postpartum care is. I was having a discussion with one of the other sponsors yesterday, and I assumed that something like lactation consultants or lactation visits would be covered. And she said, no, she didn't think it would be covered. And our experience was, well, we had those visits in a medical facility with an employee of a medical facility, so that would be. So I think that sort of uncertainty leads to confusion and frustration for both employees and employers. And then very quick, lastly, it's unclear to us what would happen with part-time employees who have multiple employers. So would that employee be able to access this leave bucket under each of those employers? So essentially, would they get this bucket multiple times across each employer? So again, thank you for the opportunity to testify.
Thank you. Any questions? Senator Long.
Thank you, Mr. Chairman. Could you be more clear on the 20 employees? Was it 20 employees you said you had an issue with in section 9?
The Section 9 sets the threshold for applicability at 20 employees, and I was comparing it to other substantial leave regulations like the ACA, or I'm sorry, not substantial leave, substantial employment regulations like the ACA and FMLA that set it at 50.
It said, I'm sorry, 50?
That set it at 50 employees.
Okay. All right, thank you.
Thank you.
So I'm just going back to that line, because it is 20 employees, and I know you said 50 employees, but it looks like when you continue to read in that sentence, the amendment caps it at 25 hours. So as I read it, even if you have 20 employees, they're not going to be gone any more than any more than 25 hours as a result of this. So do you feel that's a compromise? I mean, I read that as a compromise as somebody who is a small business employer. You know, I feel like there was some effort there to see that.
We think that the hour cap is a substantial improvement, certainly over the bill as introduced. We do think that, requiring any type of leave in any specific fashion in state law, particularly once you get well below 50 employees, can cause problems when you're trying to manage multiple employees out on leave at the same time or returning from leave, where you've had to make a number of different scheduling adjustments. So unwinding those scheduling adjustments as employees return from leave gets more complicated with the fewer employees you have, as I'm sure you know, being a small employer.
And then one more thing that you talked about, the concerns with employees that may have multiple jobs, multiple part-time jobs. I mean, how does that negatively affect the employer? I mean, it's great for the employee that may be able to take advantage of that, but how does that negatively affect the employer?
I think it's just unclear whether can they do that, whether they can do that or not. And if you as an employer know that the employee is accessing that leave through their other means of employment, do you still have to offer that? Right.
Sure.
That's the question.
Okay. Yep. Thank you for clarifying that.
Thank you.
Thank you.
Speed testimony, so
I
tried to be real
know. That's you did well. Thank you. Tara Ryan.
Hello, committee. Thank you. My name is Tara Ryan, and I'm here as a mother, as a small business owner here in New Hampshire, and as a leader for the Chamber of Mothers. We are a bipartisan nonprofit organization that advocates for maternal health. I could share countless stories from our community, but I'm going to share my own here today, which starts with a 2+ year battle with infertility. My husband and I struggled to create a family for years. Thankfully, due to the support of Boston IVF here in Bedford, we were able to have our daughter through IVF. And that time that we were struggling through infertility gave us a lot of capacity to talk about how we wanted to parent, how we wanted to raise our child, what kind of family we wanted to bring her into. Part of the conversation was, childcare, right? And I'm a small business owner. We decided that as a family, I could take 5 months of unpaid leave to care for her after she was born. We also talked about, the support that we were going to have, and we were prepared for the sleepless nights, right? We were prepared for the trouble with feeding. We were prepared for the newness of it all. What we were not prepared for was the lack of wraparound care, the peer-to-peer support, the child care struggles. So we got on 5 different daycare wait lists when when I was 7 weeks pregnant. We did not get a full-time daycare spot for my daughter until she was 14 months old. So you can imagine the struggle that our family and so many families go through that then impacts their mental health connected to the lack of childcare in our state. And if I had had peer-to-peer support to talk about that with, if I had had in-home care to support me through that, it would have been such a better experience. So I just can't help but connect the childcare crisis that we are experiencing in our state to our maternal mental health crisis that we are experiencing. And I know that this bill will help address that. And so I'm here on behalf of all of the families who cannot be here because they are working their paid jobs or they are caring for their children, to share my story on behalf of them and to urge you to pass this bill. Thank you.
Great. Thank you. Are there any questions? Thank you very much for coming in.
Thank you.
Representative Kuta.
Thank you, Chairman Rochefort, and to the rest of the Senate Health and Human Services Committee. For the record, I'm Representative Caitlin Kutab. As a mom of four, I think a bill like this is really important. We here in New Hampshire have the highest percentage of 55 plus workers in the country. And it's really been a high priority concern for businesses that we have such an aging population. If we want to attract young families, supporting young families with a bill like this is really crucial. While the majority of employers are understanding a young family, some are not. And this gives a big protection where we don't want to have parents that are choosing between getting fired or taking their child to a necessary well-child exam. So a bill like this absolutely is supportive. I think it's a really strategic thing to do in order to empower New Hampshire families, attract them to our state. Happy to take any questions.
Any questions, Representative? No, thank you. Thank you. I'm sorry I missed you. It was on the last sheet. I would have had you in here earlier.
No, you're all, I really appreciate it. Thank you.
All right, thank you. Let's see. Courtney Tanner.
Good
Dr.
morning.
Cass, correct?
Yes.
Yes.
Good morning. For the record, Courtney Tanner. I'm the Senior Director of Government Relations at Dartmouth Health. And you won't have to hear too much from me today because you do too often. With me today is Dr. Alana Kosh. She's our Chair of OBGYN at Dartmouth Hitchcock Medical Center and for our Southern clinics. I'll let her introduce herself.
So hello, I'm Dr. Alana Cass. I'm the Chair of Obstetrics and Gynecology at Dartmouth Health. And through our birthing unit at Lebanon, as well as our Southern clinics, Dartmouth delivers probably under about 1 in 4 children in the state of New Hampshire. And I want to fully endorse the support for this bill and highlight 3 points. The first of which you've heard a couple of times, but just to provide context with regards to the closures of obstetrics units that we've had in the state of New Hampshire. That represents about 42% of birthing centers and laboring units in the past 25 years, with no new facilities opening up. And so increasingly, this shifts a lot of obstetrics care and postpartum care to our emergency medicine colleagues. This is in ERs. This is the, able-bodied EMS people who take care of all of us across the state. And this bill will provide for enhanced training and collaboration and access to these centers where we have obstetrics care. I think the second point to underscore about the importance of mental health is I would remind you all that substance use overdose is the #1 cause of death for pregnant people in the state of New Hampshire. And what we see too often, I think that mirrors the state, quite frankly, of the world, is that isolation coupled with anxiety and depression, with the prevalence you've heard today by my colleagues, really leaves these women alone and suffering. And this bill would allow for #1, uniform screening for depression in common sense places, the pediatrician's visit when the mother brings in her new baby, in the postpartum office, and allow these people access to care much earlier. And finally, as an employer of our own obstetrics workforce, this is an incredibly important legislation for retention of our workforce so families can stay healthy and we can retain our workforce in the work we do. I'm happy to take any questions.
Great, thank you. Any questions? No, thank you very much. Corinne Benfield.
Any other comment other than the insurance department on the amendment?
Good morning. Chair and honorable members of the Senate Health and Human Services Committee. For the record, my name is Corinne Benfield, and I serve as the Executive Director of Stay Work Play New Hampshire. I just dropped off my letter of support for Senate Bill 246. just to start, our mission is to attract and retain young people here in the Granite State. And on behalf of State Work Plays Board and the community, we are in support of Senate Bill 246. As you've heard from the multitudes of exemplary organizations behind me, this bill is comprised of critical supports for New Hampshire's young people. I could regale you with all of the reasons why we support this bill, but you can read that in my letter. Alternatively, I'd like to actually give over my time to somebody very near and dear to the State Work Play community, our marketing coordinator, who is actually coming off of maternity leave, Courtney Stret, and she has a story to share with you. Hi, good morning, everyone. My name is Courtney, and I just had my first baby on December 21st. He's right back there in the room with us. My son, Cole, is with my husband today. After just over 8 weeks of learning, you might cry, so how to navigate the journey of motherhood as well as this new version of who I am. I found myself feeling an incredible amount of respect and gratitude for every mother who has come before me, and even that feels like a massive understatement. I truly didn't understand the amount of patience and, if I'm being honest, grit that it takes to take care for your new baby, yourself, and your family in these early postpartum days. Even though, of course, you assume a massive life change and anticipate the difficulties of parenthood, you never truly appreciate how much the sleepless nights, the hard crying sessions, and all of the other challenges demand until you are deep in it. Upon my 6-week postpartum checkup, we went through questions regarding my physical well-being, and luckily all was well. It wasn't until the end of my appointment, as my provider was walking out the door when the visit was over, that I was asked in passing, "Oh, right, how are you doing mentally? Are you okay?" Here's the thing, I am okay. Exhausted and different, sure, but overall, I am okay. But what if I wasn't? This is the case for so many mothers, a few of whom I've known that have suffered from postpartum depression. What if they were asked that question in this way or not at all? While I understand how busy providers are, and this is not to fault them, it felt very representative of how postpartum mental care is treated in our country and state currently, as an afterthought, if it's even brought up at all. I am extremely grateful and lucky to have a very supportive husband, along with my parents, who are ever present in my life and able to assist me in taking care of my son. Even with this strong support system, I still feel the impending pressure of my husband returning to work in 3 weeks. I have only been able to return to work part-time at the moment in order to take care of him, and that's with the added help of my mother caring for him partially during the week to make this possible. I am now left wondering how exactly mothers are expected to return to work so soon after giving birth, with added challenges like the high cost of childcare on top of prioritizing their mental health, something that should be the foundation of caring for our little ones. I realize we have a long way to go as a state and a country in improving postpartum care, but shouldn't we start here with mental health checks for mothers? It's step one on a long path to making this journey just that much easier for new parents, but it's certainly a much needed step in the right direction that ultimately trickles down to our society as a whole. If we can do better for our moms, we can do better for our children. Although it's beautiful and rewarding, being a new mother is isolating, it's demanding and exhausting, and you miss who you were before, at least I do, even though you appreciate this whole new and fulfilling life you now have. I'm sure I'm missing other notable experiences for new moms, but if it were possible to have mental health care early on, I can so easily see how this support could make a difference in these postpartum days for myself and other moms in our state. Thank you so much for your time and your consideration of supporting State Bill 246.
Thank you very much for the questions. And I commend you for bringing that baby in today. I know that could be a struggle. They own you. You don't own them, right? That's the way it goes. Thank you, and thank you very much for coming in.
Thank you.
Let's see, Paula Rogers.
Members of the committee. My name is Paula Rogers, and I'm here on behalf of America's Health Insurance Plans, which is a trade association representing insurers in the state. And some of those insurers may testify directly, but I just wanted to give some very general comments. My understanding in talking with member plans is that plans are largely comfortable with the legislation. I think there was some confusion around drafting and some terminology that might be concerning. What was interesting was the fact that the women's health care provision in New Hampshire law in 1997 passed something about delivery, prenatal, postnatal care of the mom. what was missing, and has been missing since 1997, is the mental health component, which is part of this bill. If you look at the bill closely, there are 3 sections that directly affect insurers. And the first one begins as new section 4, that's line 7 on page 2, and it covers maternal depression screening coverage. The second one is on line 14 of page 3, which covers perinatal mental health and substance use treatment. And the third one is at the bottom of that same page at line 37, which is perinatal home visiting services. And where there may be some uncertainty, and it came when I was listening to the testimony this morning, is there was discussion about peer support. And the reason I bring it up is not to say that there's anything against peer support. It's been proven that peer support in many situations is very helpful to an individual who struggles with any range of issues. What concerns me is that some of the expectation that providers may have in the drafting of this bill may bump up against plans who think that they largely cover these services, and people would nod their heads behind me as yes or no. There could be some discussion around that, i.e. on community-based services, do insurance codes answer to a claim that will respond to that kind of service? So I just point that out as one issue that may need some further discussion. Otherwise, I think there is no problem with the bill.
Great, thank you very much. Any questions? Very good, thank you very much.
Thank you.
Bob Dunn.
Good morning, Senator Rochford, members of the committee. It's good to be back in Senate HHS. I'm Bob Dunn. I'm the Director of Public Policy for the Roman Catholic Diocese of Manchester, and I'm here today on behalf of Bishop Peter Olbashi to support this important legislation, as we supported and we're happy to support Momnibus 1.0. The U.S. Conference of Catholic Bishops at the national level has called society to have what they call radical solidarity with mothers and babies and families, especially those who are poor. And to that end, the USCCB has advocated in Congress for legislation that will address maternal health issues, and they've specifically singled out mental health, substance abuse disorder, and postpartum depression. So this bill is very much in line with that. 2 quick points I think I'd like to make about this bill. First, although we're talking about it at the perinatal period, it strikes me that the impacts of this bill, the benefits, the health benefits of this bill will resonate all across the lifespan of the mother and the child. So this has years and years and years of benefits associated with it. And finally, there's no question that this bill is intended to and undoubtedly will save lives. And so I think this legislation can and should be considered to be a pro-life bill. And with that, thank you.
Great, thank you. Any questions? Thank you very much. Brianna Hanel? I'm sorry.
That's okay. Hey, go.
Oh, all right. I wasn't even close. Thank you.
A representative from the American Academy of Pediatrics couldn't make it today, so they gave me a letter. So I'll just,
Okay, thank you. All right. Annie Hopkins.
Good morning, and thank you to the committee for your time today. My name is Annie Hopkins, and I'm here with
two hats on, one being a mother, one being a perinatal healthcare provider. I'm a pelvic floor physical therapist, and I own my own private practice in Portsmouth, New Hampshire. So I'll start with my story of, well, so there's 3 points in this bill that really have struck a chord with me. The first being the independent birthing centers. I conceived my child in 2022 through IVF and had a successful, healthy pregnancy and planned for a home birth. Because of an antiquated New Hampshire state law, once my water broke and I was not in active labor, within 24 hours, I was required to transfer to a hospital, despite not having any medical issues or anything untoward. It's just an antiquated, no longer evidence-based law in this state that required me to transfer to a level of care that I honestly didn't need. And to contrast this, if I lived in Maine, I would have had enough time, I would have had time and to go in labor on my own without any interference there. So I transferred to the hospital. I had a successful birth. And I think someone asked, how can we pre-identify folks with mental health issues? I've struggled with depression my entire life since losing my mom at a young age. So I pre-identified myself. I put my supports in place. I had the benefit of home birth midwifery care, which showed that I had 5 home visits within 6 weeks of giving birth. And I felt great. I was supported because I had put it all in place. But what I didn't see coming was about 4 months postpartum, my mental health took a nosedive. And notably, that's when my own unpaid maternal leave as a self-employed person, I just took unpaid time off to care for my son. When that ended and I started to bear the burden of going back to work, wearing all the hats, doing all the things, my mental health crashed. Postpartum depression, anxiety, rage, panic attacks. I no longer knew who I was. And because despite my history with mental health, it wasn't my normal symptoms. So I didn't know what was happening to me and I didn't have anyone to reach out to and no one was checking on me. I was outside of that first window of care. I was one of those hot potatoes. I was picked up at a pediatric visit with my son. They had me fill out the Edinburgh postnatal depression screening scale. And throughout this time, I'll say, if you had asked me how I was doing, I would say I'm fine. But when I had to put it down on paper, I was objectively not okay. So the pediatrician faxed that to my OBGYN. It's like, your OBGYN will reach out. They did not. I had to, with the support of my husband, I don't know if anyone has struggled with mental health, but it's very hard to focus and make a concerted effort to get care for yourself when you're in the depths of these things. So with my husband's support, with my family's support, I reached out to my PCP and found medication and found a perinatal specific mental health provider. I will also say that, the paid leave just wasn't there, so that was absolutely a stressor, but this bill will support so many mothers, and I will share my professional testimony in writing in respect over the time, but I will in short say that mental health is pelvic health. We cannot separate mind and body, and I see this in my practice with all of the moms that I treat struggling as well, so I urge you to support this bill.
Thank you very much. Thank you. Rebecca, thank you very much. I was going to say Rebecca New Futures, so we get you at that point.
Good morning. I'm Rebecca Wojkowski. I'm the Child and Family Policy Director at New Futures. New Futures is a nonpartisan nonprofit advocacy organization that solves problems through policy change. We are also the New Futures is the Kids Count grantee for the state of New Hampshire, which has been supporting evidence-based, data-informed policy solutions in the area of early childhood, maternal health, and family support. So I'm here today to offer our strong support for SB 46 because it expands access to critical services such as home visiting. And I want to lift up one data point, and I'll be quick about it, is that New Hampshire over the past 8 years has made many inroads to support families on Medicaid and other targeted populations. However, unlike other states, 76% of New Hampshire births are reimbursed through private insurers. So when we think about why we are missing moms, why we don't have a connected system, it's because we don't have and we have not been paying attention to how we support privately insured moms with wraparound care. This bill, building on what we did 2 years ago, addresses some of those issues with identifying and ensuring that moms who are privately insured and their families have access to critical services. And home visiting, you heard, is one of those. Home visiting is a really important service that not a lot of moms can access, even if they want to now. It would allow visits within the home or a designated spot for a certified individual to meet with a family in a 2-generational approach. So assessing babies' health concerns, whether that's failure to thrive or other issues, as well as mom's maternal health. So in some, I have a longer written testimony, but New Future strongly supports Senate Bill 246 and urges the committee to do so as well for the sake of New Hampshire's moms. Thank you.
Great, thank you very much. Any questions? No, thank you.
Great, thanks.
Andrew Hosmer.
Thank you very much, Mr. Chair, members of the committee. My name is Andrew Hosmer. I'm representing Harvard Pilgrim Healthcare, New Hampshire's largest nonprofit health insurer. I will say, although Harvard Pilgrim is neutral on this bill, we certainly applaud the efforts of Senators Riccardi and Apprentice on their work to strengthen maternal health, specifically maternal depression screening for new mothers and increasing access to healthcare services for new mothers. To echo Paula Rogers' comments earlier, our concerns right now have to do primarily with the mandate language associated with it. Many of the services that have been discussed here today certainly are very important, and these are services that are already covered by our plans. But as with any mandate, certainly some specificity is important as we continue to craft the plan, make sure that it meets the needs of our members, and certainly that it's built into the health carrier model for health insurance. So I guess what I'm asking for right now is, again, we're generally supportive of this. We are officially neutral, but we'd like to work with the senators and stakeholders just to clarify some language on mandates, that's all.
Sure. Senator Abard.
Thank you. And thank you, Senator, for your testimony. Have you seen the amendment?
I have not seen the amendment right now, so.
Would you like a copy?
I would like a copy of it, and certainly we can take a look at that, and I'll share it with my client, and then if we can circle back with the senators, I think that would be great.
Thank you.
Thank you, Senator Avard.
Any other questions? No, thank you very much.
Thank you, Senator.
Devin Quinn.
Hi, Chairman, members of the committee. My name is Devin Quinn. I'm the Director of Policy at the New Hampshire Women's Foundation. It has been such a pleasure to support and work with the sponsors of this bill. And I was lucky to work with some of the stakeholder engagement pieces of this. I wanted to speak to the fact that so many hours went into reaching out to so many stakeholders on this bill to make sure this was a bill that could work for everyone. So I just wanted to point out from insurance, as you pointed out, the amendment language really cleans up any concerns we had. We worked with the Department of Insurance, who pointed out a couple of things like making sure there was no language on the individual markets, and that the fiscal note, when it does come out, is going to be very low. I wanted to point out that we did meet with insurance carriers. Not all of them can attend. It's very difficult to do scheduling, but they were really not concerned at the time with those things that, as mentioned, were generally already being covered in plans like maternal depression screenings and home visiting. And also the peer support piece of it is actually just a study at DHHS and doesn't mention anything about how that would be operationalized, just to study it. So I'm happy to answer any other questions about the language on insurance. And then I also, if I have a chance, wanted to talk about the stakeholder engagement piece we did on the pediatric visits. That was 25 hours in the first year of life to go to pediatric visits. We did an enormous amount of outreach to the business community. We met with BIA and got their input. We met with a large group of employers. Then there was a smaller group of HR professionals. And we really said, hey, we want to make sure that parents can bring their kids to pediatric visits. What would work for the business community? We didn't negotiate. We said what would work, and they said 25 hours for the first year of life at 20 employers or more. So they gave us those parameters, and we said absolutely. So if there's any concern about why that might be raised to 30, I don't really understand why. Who are those employers between 20 and 30, and what's that based on? Our basis is what the employers told us. So we went out of our way to balance the impact on carriers, on businesses, and balancing saving the life of mothers and keeping babies healthy. Yeah.
Got a question here from Senator Abar.
Thank you, and thank you for your testimony. Paula mentioned about the potential hiccup with maybe coding, and of course you brought up the peer support. Some plans may support it, some plans might not. Does the amendment take care of all that?
If I'm understanding your question correctly, so the peer support. So if you think about the peer support that we have in other aspects, in substance use, peer support, and I'm not an expert in this area, but my understanding is that there's a lot of different types of contracts that HHS does for types of different peer support. And so we talked to HHS at the beginning of this and said, how could we put peer support into this and start it? And they said, we want to study it first. And we said, okay. And so that might mean that they come out with a report that says, we would like to use a vendor to provide peer support, looking at who else is a vendor for peer support and do a contract with them so as another resource. So honestly, I'm at this point, the recommendations from that report, should the legislature choose to act on them in the future, might not even include carriers.
Thank you. Any further questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. My concern, and I need to be clear on this, is that somebody's not going to expect to be covered and they're not covered. So in your conversations, was there some of that cleaned up that commercial insurances may have thought may not be covered and you specified where it would be?
Yeah, that's a really fair question. And I appreciate the idea of, we are always really careful when we talk about language of these bills that we know we can't cover every single person, for instance, people who don't have health insurance. But also we know the limitations of a state legislation that can impact plans that are regulated at the state level, but the plans that are regulated at the federal level, this wouldn't impact. And so that does change this does everything we can to impact the most amount of moms with the biggest stakeholder support in the state under what we're able to do without a large fiscal note.
Okay, great. Thank you.
Thank you. Any further questions? Oh, thank you very much.
Thank you.
So I've got the last speaker who's, well, you haven't signed up, but I'm going to ask you to come up. DHHS, Courtney Keene, Jenny O'Higgins, Rob Berry.
There's only 2 seats.
I'll pick. There you go. You can grab that wheelie chair there if you.
Just don't lean back.
Good morning.
I'm Jenny O'Higgins. I'm Legislative Liaison for Behavioral Health at DHHS.
I'm Rob Berry. I'm General Counsel to the Division of Medicaid.
I'm Courtney Keene, Interim Bureau Chief for Family Health and Nutrition.
So we are all three here this morning just to provide some information to you all. The department, the DHHS roadmap includes a goal for healthy moms and babies. And so we are very conceptually supportive of all of the components within the Momnibus bill. And we did receive a request for a fiscal note worksheet. And given the volume of those requests, we have not been able to turn it around and complete that prior to the hearing. But today we can speak to that fiscal impact as we work to finalize the worksheet for you all. So really there's an appropriation to the department in here for the perinatal psychiatric consultant line, which would really be coming into the department and back out, but not a need for an additional fiscal impact on our end. And the other section within the bill that concerns DHHS directly is the perinatal peer supports, which is a report, and so not a direct appropriation. So again, does not have a fiscal impact to the department. And then I'll hand it over to Rob on the Medicaid side.
And on the Medicaid side, this is a service we're already providing. We would just be changing who can bill for it. But given that, we expect maybe some increased utilization, but minimal to no fiscal impact.
Thank you, Senator Eber.
Yeah, sorry to be a broken record here, but the department, did you see the amendment?
I've seen an informal version of the amendment. I don't think I've seen the formal version of the amendment. So we do need to go through that a little bit more, just to make sure I know what the formal language was. But I haven't. We weren't in here for most of the hearing.
Thank you.
Thank you.
Senator Bertzel.
Thank you. Earlier testimony, you may not have been here. Someone spoke about the fact that they were concerned that they wouldn't be able to have a C-section because they could only get 4 weeks off. What is the legality? I mean, when I used to work as a benefits counselor for Raytheon, and we required 6 weeks of regular maternity, and for C-section 8 weeks. What is New Hampshire's version, or is there one?
I'm not aware of New Hampshire. So this is not me speaking on behalf of DHHS. This is my lawyer hat I'm putting on. But I don't think New Hampshire has a comparable statute, but I believe the FMLA would apply in that situation. So I can't really speak to those individual circumstances about and whether it's paid or unpaid leave. But I would imagine that you'd be entitled to 12 weeks unpaid per the FMLA.
Follow up? Good. Okay. Any further questions? Very good. Thank you very much. That's the end of our list for folks that have signed up to speak. Is there anyone else that would like to speak on Senate Bill 246? Yes.
Hi, my name is Pam DiNapoli. I'm a registered nurse from Manchester and member of the New Hampshire Nurses Association, and I'm here on behalf of the Nurses Association. I just wanted to real quickly say that the Nursing Association is strongly in favor of this. We think it's probably one of the most important pieces of legislation you have to consider this year, and we're happy to be working with the Women's Health Foundation on advocating for this bill. I just wanted to briefly read you a story that was sent to me by the president of our association relative to her own childbirthing experience. She says, for 5 years, I struggled to have a child, experiencing 3 ectopic pregnancies along the way. In 2011, I finally welcomed my beautiful baby boy, who is now 13. However, those losses took an immense toll on me and my husband, one I didn't fully grasp until after my son Noah was born. Noah arrived via C-section, and at first I was overjoyed. The first night was incredible, but by day 3, something felt off. By the end of the week, I was overwhelmed with panic, tunnel vision, and a deep sense of despair. I struggled in silence, saying little to my healthcare team or even my fellow nurses. As a nurse myself, I felt like I should have been prepared after all. I had planned for this moment over 4 separate times, but nothing prepared me for postpartum depression. The one thing that saved me and my family was the Elliott Postpartum Group, a weekly class led by an incredible nurse. Surrounded by other mothers, some who had already overcome their depression and others like me just beginning their journey, I found the support I desperately needed. Groups like these are rare in New Hampshire, and I was fortunate to have access to one. So she goes on to say that you have the power to change this, and there are parts of the state, as she acknowledges, that don't have the benefit to these important services, and we strongly urge you to pass this bill. Thank you.
Great. Thank you very much. Any questions? Last call for Senate Bill 246. I'm going to close the hearing on Senate Bill 246. Yes. Yes. Good for me. No. Yeah. Correct, not till later. Right, we're gonna do it later. Which one? Okay, yeah. I think it's fine. I think it is too.
You gotta keep on track.
Yeah, yeah. All right, with that, I'm going to open the hearing on Senate Bill 124 relative to continuing care retirement communities. I'll ask the prime sponsor to introduce her bill. Welcome back.
You're having a long day, so I'll try to speak very quickly. Thank you so much, Mr. Chairman and members of the committee. My name is Denise Ricciardi. I represent District 9. Today, I'm here to introduce and provide testimony regarding Senate Bill 124, which addresses the regulatory framework governing continuing care retirement communities, or CCRCs, in our state. Continuing care retirement communities are residential facilities designed specifically for older adults. They offer a range of living options and care services, all within a single location. Typically, these options include independent living for seniors who are able to live autonomously, assisted living for those who require some assistance with daily activities, skilled nursing care for residents who need more intensive medical care. The CCRC model is structured to provide a continuum of care, allowing residents to transition seamlessly between different levels of support as their needs evolve. This flexibility eliminates the need for relocation to another facility, which is appealing to many older adults and their families. It offers stability and peace of mind, knowing that future care requirements can be met in one place. However, it is important to note that CCRCs often require a substantial entrance fee, along with ongoing monthly fees, which can fluctuate based on the chosen type of resident and care plan. While CCRCs are popular among seniors, operating such communities poses significant financial risks. These risks can have serious implications for residents who rely on these facilities for housing and care, particularly those who have invested their life savings to secure their place. Over the past 15 years, the New Hampshire Insurance Department has seen CCRCs face considerable financial challenges. Issues related to funding, actuarial risks, mismanagement, and volatility in the housing market have emerged repeatedly. In each instance, the department has navigated high-stake crises, with the well-being of seniors hanging in the balance. In response to these challenges, the department undertook a comprehensive analysis of the legislative framework governing CCRCs. They've done this over the past 3 years. This analysis aimed to identify proactive measures to address the challenges faced by financially troubled facilities, with the ultimate goal of protecting our vulnerable seniors. The findings of this through review are encapsulated in Senate Bill 124, which we believe will enhance oversight of CCRCs in New Hampshire. This bill seeks to implement an early warning system for financial distress, ensuring the insurance department can act promptly before a crisis escalates, thereby safeguarding the interests of residents. We are here today in partnership with the insurance department and answer any questions you may have regarding this important legislation. Thank you so much for your time and consideration.
Thank you, Senator. Any questions for Senator Ricciardi? No, thank you. And before you start, Commissioner, I am going to remind you we are on a 2-minute timer, so yes. Thank you.
Great. Thank you, Mr. Chairman. I will go as quickly as I possibly can. First and foremost, E.J. Betancourt, Commissioner of the New Hampshire Insurance Department. I'm joined by my colleague, Steve Nottinger. I want to thank Senator Ricciardi for her partnership in this endeavor. So very quickly, why are we requesting additional oversight tools through Senate Bill 124? 3 predominant reasons. The first is that the statute is in dire need of updating. The existing statute is over 30 years old and urgently requires an update to address the evolution, challenges, and changes that have occurred with CCRCs over that period of time. Second is our commitment to consumer protection. Our department's mission is focused on consumer protection, and we take that responsibility very seriously for all consumers, but it is especially critical when the individuals potentially impacted are vulnerable populations such as seniors, and that is precisely the demographic involved in the context of CCRCs. And finally, this comes in response to some serious financial distress that we have seen with some CCRCs. And currently, our statutory framework alerts us to financial distress when it has escalated to a point where the entity is in full-blown crisis. And so it is more of a retroactive approach that we have now that we have found to be insufficient. In the past decade, my department has had to respond to at least 3 CCRCs facing major financial crisis. In the most recent instance, the CCRC had only 10 days of cash on hand. We were managing a significant crisis with that entity. And the consequences of a CCRC going under are frankly catastrophic. Seniors can lose everything, they can find themselves with nowhere to go, and have their entire provider network upended. Again, in that recent example, we had to place the CCRC into receivership, meaning that I, as commissioner, and my department were ultimately responsible for managing and pulling that entity away from the financial cliff. And I will just be candid with you, it was a harrowing experience. We didn't know where these seniors were going to go had this entity gone under. If I may just finish the thought, Mr.
Finish
Chairman.
up, yes, please.
So fortunately, in all 3 instances, including the most recent one, which again was a pretty frightening experience, we were able to facilitate a sale of the distressed CCRC to a new operator, which did provide a positive outcome in the end. What you have here, in essence, is a balance between ensuring that we are not overregulating or being overburdensome to the industry, while also implementing an early warning detection process by which we're able to get out in front of any financial challenges that these entities are facing and not having to manage, in some cases, a very dire situation on the back end, which narrows the options that you have available to bring to bear. So I'll stop there and we can certainly take some questions.
Sure, Senator Ebert.
Thank you, and thank you, Commissioner. How many CRCs are in jeopardy at this moment?
At this moment, Senator, I'm not aware of any that are looking at serious financial challenges. But again, the way the current regulatory structure is set up, we wouldn't know until it had gotten to a point where it was pretty serious.
And one follow-up, if I may, Mr. Chairman, and it's the fiscal note, it seems like it's deja vu all over again. Is there a ballpark that you have in mind of what our fiscal note on this is?
So in terms of what it would cost the department, I don't think that there's any financial impact that I'm aware of. It's just going to change what the team that is currently in place within the department, how they're going to approach the work they're currently doing. I would note that one of the internal changes that we have made and that this legislation will further support is there is a statutory requirement for every CCRC in the state to go through a financial market conduct exam within a 5-year period. We are now in the process of putting a set schedule together so that all of those CCRCs know when we're coming in, what we're going to be looking at. And again, what you have here, I think, is going to impact, obviously, some of that analysis, but we need some help from the legislature to improve our statutory oversight tools, and then we internally are going through the process ourselves. And I would be remiss if I did not say that I'm incredibly grateful to all of the CCRCs who are active participants in the crafting of this bill. There is going to be an additional amendment forthcoming that reflects the continuing work and collaboration that we did with the CCRCs in between the time period of when the bill had to be filed and us appearing here today. I will tell you that all of the CCRCs are structured a little bit differently. There are nuances to all of their operations. And so it's not the perfect fit in all instances for each CCRC, but I would put consensus in agreement in the ballpark of 90 to 95% that the CCRCs are happy with the proposal here. They'll speak for themselves, of course, but it's hard to come up with the perfect piece of legislation in this instance, given those nuances. But we worked really hard to get input, and I think by and large, we were successful in reaching a high degree of consensus around what you see before you.
Thank you. Thank you. Did you have a question? Any further? Senator Long.
Thank you, Mr. Chairman. Just so, I mean, I've read through the bill. What does the amendment address? Is it multiple or is it more specific?
So I'll defer to Steve on that.
The amendment addresses discrete issues throughout the bill. It does not change the tenor of the bill at all.
Okay. All right. Very good. Thank you.
I know there's a short period of time here. I have written comments if that's more helpful to the committee.
Yeah, that's fine. You got 2 minutes.
Oh, I get 2 minutes too?
Right.
Oh, okay. I didn't realize that. I thought, okay. Continuing care retirement communities, known as CCRCs or life plan communities, are long-term care option for older people who want to stay in the same place throughout different phases of the aging process. The members sign up in the beginning and pay an entrance fee of several $100,000 and pay a monthly fee for care. When they die or their unit is sold, they can get a portion of their entrance fee back depending upon the type of contract they have. A CCRC does not have to provide health care as long as it charges an entrance fee of more than $10,000 and provides lodging or meals. The idea being, if hundreds of thousands of dollars are paid up front to access what is only a promise to repay from the CCRC to the resident, then that requires regulation. We don't want a situation where people are paying hundreds of thousands of dollars and they don't know if there's any solvency to the enterprise they're paying. So that's the whole reason for the regulatory framework. And what we've done in the amended statute is we've given ourselves an opportunity to react quickly. We require that the CCRC report quarterly to us on certain financial factors. It should be easy for them to do because they do it anyway. What this does is it gives us the opportunity to act quickly. Before I came to the insurance department, I was a bankruptcy trustee for 30 years. And I can tell you that the most important thing to do when an enterprise is facing risk is to act quickly. The longer you wait, the less money there is. Then the less money there is. Then there's no money. And if there's no money, then you have to do something with the residents. So the focus in the bill on this issue is to make it as quick as possible. We get to know what's going on, and we have tools in the bill to react, including requiring management to form a plan, if the plan's unacceptable, to replace management, all sorts of things like that. On the other hand, if a CCRC is performing exemplary, we leave them alone in this bill. This bill is not a knee-jerk reaction to troubled CCRCs that's going to burden other CCRCs that are performing properly with a huge financial or regulatory obligation. So there's really two themes in the bill. There's this early warning system, as the commissioner pointed out, and there's this idea that if you're performing properly, we are not going to review everything that you do. But if you are falling below the threshold of performance, then we can get involved, and we can do so quickly. And that's the theme of the entire bill. I realize it's 30 or 40 or 50 pages long, but that in a nutshell is what the bill is about.
Great, thank you. Now, just a question I had. It looks like with these CCRCs, there's, in reading the statute, it's clear that, but I just want to understand where the delineation is between your role, Department of Insurance, and DHHS. I mean, it looks like you both have a role here in this.
It's a very interesting question. It took me my first year as commissioner to understand how CCRCs as entities ended up under our purview, to be honest with you. I think the delineation, so far as I understand it, is we oversee the financial aspects of these entities. We oversee the contractual obligations of the entities. The facilities themselves, the care that is going in, that's taking place within those facilities in their various forms and fashions, that is overseen by the Department of Health and Human Services.
Great, thank you.
Any questions?
No, thank you very much.
Thank you, Mr. Chairman.
Thank you.
Andrew Hosmer.
Good morning, Mr. Chair, members of the committee. My name is Andrew Hosmer. Client I'm representing today is River Woods, the River Woods Group. River Woods is a nonprofit which operates a system of an organization which operates a system of nonprofit continuing care communities in New Hampshire. Both River Woods Exeter, River Woods Manchester, and River Woods Durham, collectively known as River Woods. The first facility opened in 1994, currently serves approximately 1,150 residents across these three facilities. First and foremost, I want to say that River Woods is grateful for the Department of Insurance and all the stakeholders for the amount of work that went into this. Certainly, what the Commissioner outlined earlier was certainly a cause for concern throughout the state, and this is a terrific first step forward in trying to bring more accountability and maintain stability for CCRCs across the state. There is one area, a couple of areas that River Woods would like to see addressed, perhaps in an amendment, has primarily to do with what the expectations of an affiliate. An affiliate may come in regards to a CCRC that is in financial distress. The affiliate could be characterized as a white knight that comes in looking to purchase the assets and bring stability and certainly care for the residents of that community long term. So I would just point out briefly, and I do have a written testimony here on behalf of Kevin Goyette, who's the Chief Financial Officer of River Woods. And I think it's important to know that nonprofit senior living care providers like River Woods are bound by their charitable mission to serve current and future residents of the facilities and to anticipate and meet the needs of older adults in the communities that they serve as those needs change over time. Given the increasingly challenging business environment in which New Hampshire CCRCs are operating and their fiduciary obligations as stewards of their mission and charitable assets, CCRCs going forward must often grow, diversify, and affiliate or transfer operations in order to ensure sustainability. So the recommendations very briefly here, which again will share with you, which is the first one is to amend on page 25, lines 35 and 36 to add more clarity to and objectivity to what the commissioner will be doing when looking at potential affiliates. Number two, which is to amend on page 30.
Can you point out where again on page line?
Yeah, I have it written down right now as I have to verify it, but it's page 25, lines 35 and 36. Senator, which indicates, quote, is in the best interest of the current and future residents of the facility and state of New Hampshire. We would seek to amend that to read, the commissioner may refuse to approve such transfers until full disclosure has been made to his or her satisfaction of the terms and conditions of the transfer, and the commissioner has determined that such transfer, one, will be to a qualified provider to whom a certificate of authority will be issued under the statute. Two, will not impair or endanger the financial stability of the CCRC. And three, will not diminish the services or protections, bless you, given the current residents.
We put bless you in there too as well? That was really.
Just a habit.
Nice job.
Right? Well,
and is there.
So in light of the time pressures that you're all under, we are too, I guess we'd like an opportunity to review just a total of 3 items that we would seek that would add more objectivity to the process for affiliates to become involved and act as potential partners to buy the assets of any CCRC that's in distress. And happy to continue working with Department of Insurance and the Commissioner if you like.
And they're nodding yes, so that's good.
Good, I'm glad.
Questions from the committee? Yeah, and just send your ideas to the committee, that'd be great. And now that the chairman's back, you are dismissed.
Thank you, Senator Avard. Thank you, Mr. Chair. Thank you, members.
Lisa's next. Lisa?
Good morning. My name is Lisa Henderson. I'm Executive Director of Leading Age Maine and New Hampshire. We are an association serving mission-driven providers excuse me, of aging services spanning the continuum of residential care from independent senior housing to assisted living and nursing care. And this also includes continuing care retirement communities, CCRCs, sometimes referred to as life plan communities. Leading Age Maine and New Hampshire represents all 14 of the licensed CCRCs in the state, all of which are nonprofit organizations. Today, I'm testifying neither for nor against SB 124. Our association and its members were engaged in an extensive series of meetings with the insurance department in September and October. And the department explained their genesis for this modernization effort, and that's really what I would characterize it as, with goals of protecting consumers and ensuring the financial strength of CCRCs, and those are goals that we share. We did present some of our concerns, areas of some we thought overreach, because what we're trying to protect is the rights of private nonprofit organizations overseen by board of directors that provide strategy guidance, and they're accountable to the broader public to not be impeded in their business activities. It was mentioned about affiliates. I just wanted to note that the change since 1980 of CCRCs existing as standalone versus part of multi-site organizations. It used to be about a 50-50 balance at the origin of this model, and now it's moved to 72% are multi-site organizations like Riverwoods, and only 28% are single sites. So we're going to see a lot more of this activity, and it's for the betterment of organizations, because with larger, more robust organizations that have the administrative back office and the capital behind them, you get attraction of better talent, you get more efficient operations. So I just want to footnote that as a trend to be aware of, because this is what we're seeing, and we want to make sure that the Riverwoods of the world, you also have an opportunity to hear from the CEO of Taylor Community, which was involved in the rescue of Meredith Bay Colony Club, which was one of those troubled communities. And you'll hear how that is strengthening their organization to become larger. I'm happy to answer any questions about the CCRC model roughly. I'm not a CFO, so I would leave some of the details of the financial reporting aspects, but I will just reiterate and final comment here that our members are more than happy to submit to the more regular reporting, which is now set forward to do supply financial reports on a quarterly basis, as was mentioned by the commissioner. This is a normal practice for them, for their lenders, and to uphold the covenants that they operate under. So that is, they're proud of their financial acumen, and that is the majority. I don't want to paint a picture of there being great concerns about the solvency of the network of CCRCs in New Hampshire or across the country. This is a strong model that serves consumers that have planned well for retirement and want to be able to age in place.
Great, thank you. So you say you represent all the CCRCs in New Hampshire. Is the Morrison communities in Wakefield considered a CCRC?
They are not, and the reason for that is they don't take an entrance fee. They have all levels of care in one vicinity, and so we would call that a multi-level community. But because they don't take an entrance fee and they don't have a contract that outlines a promise of care to move to the next level, they would just be considered like a rental model, non-CCRC.
So there's no, for those models, there isn't a regulatory framework like the bill that we're
Not like
debating
this.
today.
They would be subject to the licensure requirements for their assisted living and their nursing care, as are CCRCs for those components. But because it's not a consumer protection issue, I mean, this is like prepaid healthcare in a lot of ways by putting down that significant deposit. That is providing a backstop so that the organizations can deliver on that promise of care no matter how long you live at the community. And they even provide charitable care as a backstop should someone outlive their means.
Great, thank you. Any questions? Thank you very much.
Certainly.
Michael Flaherty. Good morning.
Good morning. How's everybody doing? I'm Michael Flaherty. I'm the president and CEO of Taylor Community. We operate 3 CCRCs in the Lakes, 3 communities under one umbrella in the Lakes region, including one that we recently absorbed who was in financial distress. It has helped our community and it's been able to protect that community, the residents. I'm here speaking in general support of this bill. We had a very thorough, several thorough conversations with the Department of Insurance and a collaborative effort to put this legislation together. And ultimately, I think it does the job, the objective of protecting the residents who invest in these communities, but also protects organizations from themselves when poor management occurs. So it's not a perfect bill, but I don't want to be the enemy. What's the enemy of perfect? This is a good, solid bill that I think achieves its objectives. So I don't know if you have any questions, but.
Great, thank you. Any questions? Thank you very much.
Thank you.
The last speaker I have on the list is Susan Buxton.
How tired is it me?
It's not even noon yet.
Good morning.
Good morning.
Thank you for allowing me to testify this morning. My name is Susan Buxton. I'm the State Long-Term Care Ombudsman. The Office of the Long-Term Care Ombudsman is a required program of states receiving Federal Older Americans Act funds. Our office works to resolve problems related to the health, safety, welfare, and rights of individuals who live in long-term care facilities such as nursing homes, assisted living facilities, and other residential care communities. We do this through education, investigation, mediation, and advocacy. Ombudsman programs promote policies and consumer protections that support the well-being of people living in long-term care settings. As the state's long-term care ombudsman, I'm also a member of the Commission on Aging that studies issues related to aging and makes policy recommendations. So I'm here this morning on behalf of the Office of the Long-Term Care Ombudsman and the New Hampshire State Commission on Aging in support of Senate Bill 124, as it provides additional protections for people investing in continuing care retirement communities. As people consider their later in life needs, a primary concern is affording and managing potential care and living arrangements. It's a complicated question. For some, CCRCs are an attractive alternative to balancing on their own these needs and increasingly costly long-term care insurance. I served as the patient care ombudsman in 2021 for the Chapter 11 bankruptcy of the CCRC in Keene. I experienced firsthand how distressing it was for the residents of that community who made a substantial investment for a future that turned out to not be as guaranteed as they understood it to be. It did turn out well for those residents, I will say that, but this bill, the provisions in this bill, I think will give people additional greater protection under the law, allowing for that greater certainty in their future that they're investing in. I'll be quick. I got just a few more things.
Please.
So I want to point out the things that I think are valuable aspects of the bill, requiring the additional information for their certificate of authority and in the disclosure statements, adding the financial requirements to the annual report, the additional requirement of quarterly financial calculations will allow for early warning of problems, and a requirement for a financial plan if there is unsound financial conditions. There are requirements within this for the claim of residents to be paid ahead of operating expenses if the facility goes into receivership, and the creation of a resident bill of rights and a mechanism to file a complaint with the department alleging a violation of these rights, I think is a significant improvement, providing a foundation for issues that arise. There's a couple of areas that I think need clarification. The first one is under 420D10A. I think it's on page 21, line 17. And this section stipulates that a contract may only be terminated by the provider for just cause. I think just cause needs more clarification as it relates to the different living situations within the CCRC. The living situations of the CCRC that are licensed under RSA 151, there are clear guidance under 151 for that.
And we have your, I don't mean to cut you off.
Yeah.
I hate to do that, but we
Okay.
do have your comments on that.
Okay.
The question I have is, do you have language that would clarify that for us?
I'd be happy to submit something.
If you could do that. I know
Yep.
you also pointed out page 22, line 26 as well, and you give a thorough description there. I appreciate that.
Yeah.
But if you could get us language
Sure.
on those two, that would
And I
help
think-
us. But I mean, it's nice to see out of the 20 plus pages, there's two areas that you've identified.
It's a great bill.
That's good. That's good to know.
Right.
Are there any questions from the committee at this point? No, very good. I apologize to cut you off. We've got a busy day ahead of us. All right. That concludes the sign-in. Is there anyone else that would like to comment on Senate Bill 124? With that, I'm going to close the hearing on Senate Bill 124. I think it feels good. You want to stop it? All right. Oh, great. Thank you. Thank you. With that, if you're ready, Sophie, we're going to open the hearing on Senate Bill 243 relative to the Child Care Scholarship Program. Senator Ricciardi, welcome back. We've saved you a seat.
You'll be tired of hearing me talk by the end of this. Thank you again, Mr. Chairman and members of the committee. Denise Ricciardi, State Senator for District 9. I welcome the opportunity to introduce to you Senate Bill 243, a critical step forward for New Hampshire's families, child care providers, and our economy. I'm proud to sponsor this bill because it addresses key issues in our child care scholarship program, ensuring it works as effectively as possible for those who rely on it the most. The Child Care Scholarship Program is more than financial assistance. It's an investment in the future of our children, the stability of our workforce, and the prosperity of our state. When this program functions well, everyone benefits. Children gain access to quality learning environments that can set them up for success in school and life. Parents can return to the workforce more easily, contributing to our economy. And child care providers gain a stable source of funding, helping sustain an essential yet financially strained sector. However, the program as it stands today includes barriers that make it difficult for families and providers to access these critical benefits. SB 243 offers 4 concrete solutions to cut through the red tape, streamline the process, and support those who need it most. One is presumptive eligibility. Families could receive up to 60 days of funding while their applications are processed, reducing financial strain. Application streamlining. A study will simplify the application process, eliminating unnecessary information requests that deter participation. Prospective payments. Providers would receive payments upfront, encouraging more to join the program. And fourth, simplified reporting. Eliminating detailed hourly attendance reporting will save providers time and resources. Your support for SB 243 would significantly benefit families and child care providers alike. I'd love to discuss this further with you. Collectively, these changes will reduce administrative burdens, enhance access for families, and encourage more providers to participate in the program. Importantly, they also align New Hampshire with federal requirements, allowing us to maximize the impact of state investments by leveraging federal matching funds. SB 243 is more than fixing a system. It's about removing obstacles so that families can thrive, providers can succeed, and our workforce can grow stronger. I believe this bill is a win for parents, a win for providers, and a win for the state's economy. Thank you for your time and consideration of this vital piece of legislation, and I ask you to support SB 243 and look forward to working with all my colleagues to help move this forward.
Great.
If you have any questions.
Thank you. Are there any questions? Thank you very much.
Okay, thank you.
No. Representative Boschman. And just to remind you, Representative, we are having a timer again.
Absolutely. Thank you so much. Thank you for having me here today yet again. I'm here this time my name is Paige Boschman. I represent Hillsborough 3, Nashua Ward 4. Thank you so much for having me. I'm here a little bit more in my capacity as a mother right now. I do have 3 children. Now, I'm lucky because they're out of daycare right now. They're 10, 12, and 6. I can tell you, though, that when they were in daycare just a few short years ago, it was at least around $1,000 per child, which meant with 2 children, I would be on the hook for $2,000 a month. Even as it is right now during the summer, I would have to pay $3,000 a month to have all 3 of my kids in daycare or in camp all day long. I am a part of the Nashua Family Network, which is a parent-led group to address the needs in the community and peer support, as we've talked about. And I also am involved in a lot of organizations that work towards perinatal mental health, perinatal health, and early childhood health. I talk to lots of moms and professionals, And I can say that the number one issue we talk about is childcare. We do talk a lot about the current childcare program, and people talk about the difficulties of the process, how it's a cumbersome, complicated process. They talk about how counting hours can be very difficult. Right now, they need to have a certain amount of hours for full reimbursement. Things come up. I think most of us know how sick people are this year. And so when you have children who are maybe out because they're sick, that can impact those hours significantly. This issue is vital to the financial health of New Hampshire families and the New Hampshire economy. This is one of the top issues that I hear from my constituents in the Nashua area. The bottom line is that parents want to work, but the system has failed them. I urge you to please give these families the support that they need to do what every hardworking Granite Stater wants to do. They simply want to work to support their families. Thank you very
Perfect
much.
timing. You're
I didn't
good
even
at
use
this.
the alarm, the clock this time. Thank you.
Thank you, Representative. Karen Hebert.
I think it's morning still or afternoon. Morning. My name is Karen Hebert. I'm the Director for the Division of Economic Stability at DHHS. I just wanted to point out a couple of things about this bill and some of the language. There is a fiscal impact of this bill to the department with respect to some of the provisions, including system changes and a cost for a study to study the application process and determine what may need to be improved in it. That fiscal impact is $371,000. I also want to point out that with respect to the Child Care Scholarship Presumptive Eligibility Pilot, I would like to propose just including language within the bill regarding the pilot that in the event of a child care scholarship program waitlist, I want to just ensure that the pilot would not commence if we have a waitlist in effect, or would be suspended if the pilot had already been initiated. I also want to point out with respect to the application process study that the date to have an evaluation completed by May 1st of 2026 is not realistic. More likely, November 1st would be a better date to target. Because of the state's standard procurement process, we would need time to procure the services for the study and then conduct the analysis and issue a report. So November 1st is a much more realistic date for that. Last, I wanted to point out that the changes in this particular bill would also require federal approval for changes of our state plan. So I just want to make sure that that is also noted within the language that it is subject to federal approval of changes in our state plan. And I'm happy to answer any questions you may have.
Yes, Senator Avar.
Thank you. And you said the pilot would not commence, and I didn't write that.
Oh, the pilot for presumptive eligibility would start January 1st of 26. But the date I was referring to had to do with the study for the application process. That is on the bottom of page 2, which currently says by May 1st of 26, we would evaluate information. However, November 1st is a much more practical date.
Yes, and one more dumb question.
Yes, go ahead.
This one's the dumb one. Well, we need federal approval. How long would that take?
I don't expect that that would take a long time. They're pretty quick to turn around amendments to our state plan.
Thank you.
And could you get us the language that as far as the pilot, you said pilot would not commence if there's a wait list, I believe is what you
Yes.
said. If you could forward that to the committee,
Absolutely.
that would be helpful. Thank you.
Sure.
Any other questions? Thank you very much.
Great, thank you.
Janet Perkins Howland.
Hello again.
Welcome back.
Hit the button back.
Yes, hit your button. The red button, we need to turn the red microphone on. Should be right, the gray button right in front of you. There you go. Thank you. Perfect. You're going to be an expert at this by the time you leave.
Absolutely. It's Groundhog Day.
Yeah.
My name is Janet Perkins Howland. Thanks for allowing me to speak today. I'm here just as with Mom and the Bus to voice my strong support for this childcare legislation. As an OB in New Hampshire for almost 30 years now, I've seen firsthand how childcare is the number one stressor for young families. And I think that anything like legislation like this that can support our families to address the declining birth rates and our attempts to get young families to move to New Hampshire is a good idea. I remember trying to find daycare for our first, many years ago and calling every day to the daycare until they took us off the wait list. I'm pretty sure they were just sick of me calling, but seriously, that parents I take care of would love to find something very simple, which is safe, affordable daycare. And I've also seen how the lack of accessible daycare keeps talented people out of the workforce. Just a really quick 2 anecdotes. I have a single mom in my practice who had to turn down a promising job opportunity because she couldn't afford the 2-month gap while her childcare was being arranged. And so this bill's provision for 60 days of bridge funding would have made all the difference for that family. And the expanded child care scholarship program would help parents like one of my recent patients who told me that in her family, they pay more for child care than their monthly mortgage. So it's not really worth working as she would like to do. So this isn't just about child care, it's about New Hampshire's economic future. And when we support parents returning to work, we strengthen our entire community. Thank you very much.
Thank you very much. Leanna Lorden.
Good morning. My name is Leanna Lorden, and I'm the Chief Operating Officer at White Birch Center, a nonprofit childcare organization in Henniker. I'm here to testify in support of SB 243, which would streamline the New Hampshire Child Care Scholarship for parents and providers. White Birch Center offers childcare for children ages 6 weeks through 14 years old through our early learning and extended education programs. As a child care center, we do accept the New Hampshire Child Care Scholarship. This program helps families by paying for all or part of their child care bill. SB 243 would be beneficial to not only White Birch Center, but also to the families we serve, as it would create presumptive eligibility and prospective payments. Currently, while a family is in the application process, they're either paying the full child care tuition out of pocket, or the parents are staying at home with the child until the application is approved. Often we outline our tuition policies of families paying in full, but families may go against policy and their balance will accrue. White Birch Center ends up struggling to get families to play catch up. We often go out of our way to find an alternative funding opportunities to support during these transitions. Additionally, since the market rate survey and the increase of eligibility to 85% of state median income, we've doubled our enrollment in the scholarship program. In January 2024, we had 7 families enrolled across our 2 childcare programs. Currently, we have 20 families enrolled and still growing. These changes have kept aging balances at bay, but we're still faced with challenges such as excessive time spent submitting claims, backbilling with delay in linking a child, backtracking accounts receivable when cost shares change unexpectedly. Presumptive eligibility means as a center, we would be getting paid for the care of the child while their application is being processed. It also means the child's parent would not have to worry about childcare costs or missing work while waiting for the application to be processed. This bill would also make the scholarship application much simpler and aims to fast track the application so families would not have to wait as long. With the current New Hampshire Child Care Scholarship Guidelines, we receive scholarship payments after we have already provided childcare. By creating prospective payments, we would receive the scholarship payments ahead of the care being provided, which is more in line with normal business practices and would allow us to operate more smoothly and efficiently. These changes would make a big difference for our business and families that we serve. I urge you to support on Senate Bill 243 to support childcare. Thank you for your time.
Great, thank you. Any questions for Leanna? No, thank you very much. Carlissa Choate.
Good morning.
Good morning. Oh, you turned it off. You gotta, yep, there you go.
Good morning.
Good morning.
My name is Carlissa Cho, and I serve as the Executive Director of Education at the YMCA of Greater Nashua. I am here representing all 8 YMCAs across New Hampshire, all in strong support of SB 243, which addresses the Child Care Scholarship Program. Our 8 YMCAs are among the largest youth-serving organizations in New Hampshire. We provide safe, nurturing, and enriching care to thousands of children through early childhood education, before and after school programs, and summer camps. These programs are vital to both the well-being of children and the stability of working families. They also support the broader economy. The YMCA of Greater Nashua, one branch, our Merrimack branch, we care for over 480 children every single day. Many families, eligible families, are in need. They face barriers when applying for financial assistance, often giving up on the process because of the complexity and because of the red tape. SB 243 would simply simplify the steps, ensuring eligible families can receive help that they need so that they can work. Tracking hours, hourly attendance is another burden. Since 2023, providers are reimbursed based on enrollment and not attendance, yet we're still required to track hours, wasting time that could be better spent on enriching care that we provide. Removing this requirement would free up valuable resources for the children we serve. Upfront payments, as proposed in SB 243, will give childcare providers financial stability, helping us avoid the strain of waiting weeks for reimbursements. Right now, we can wait up to a month for payments, often leaving a gap of $2,000 to $4,000. And for many programs that operate on a razor-thin margin, this is impossible. This causes some programs to opt out of the scholarship program and not want to be a part of it because it doesn't meet their business needs. The presumptive eligibility pilot is a game changer for families and providers. That way, families no longer have to wait for full application approval. That will help families, that will promote more providers to want to be a part of the program. And in conclusion, I just feel like the changes, and we as an organization, the changes will greatly improve childcare, the childcare landscape here in New Hampshire by simplifying processes and ensuring timely support. SB 243 will make childcare more accessible and reliable for families and more sustainable for providers, ultimately strengthening our workforce and the economy. I thank you for your time, and I strongly urge you to support SB 243.
Great, thank you. Are there any questions? Just one question.
Just one question. So Nashua has 480 families every day, or every day?
That's one branch. That's our Merrimack branch. We have a Nashua branch, and we have a camp, and we also have programs off-site. So that's just one branch. You're welcome.
Thank you very much.
You're welcome.
Trina Ingelfinger.
Good morning.
Good
Thank
morning.
you so much, Mr. Chairman, committee. Trina Ingelfinger, and I'm here in support of Senate Bill 243. It will help working families in New Hampshire access the care that they need. I know my time is limited, so I just want to talk a little bit about what New Futures has heard with our partner organizations this fall in listening sessions and interviews with stakeholders. We heard resoundingly that there are significant barriers to accessing the Child Care Scholarship Program. I know others have spoken about how impactful the Child Care Scholarship Program is for children, for parents, for employers. I just want to talk very briefly about how cost-effective the program is. At this point, federal funds cover about 57 cents on the dollar for the programmatic costs of the Child Care Scholarship. And in a report just this week from the New Hampshire Fiscal Policy Institute, it was underscored that every dollar invested in subsidy programs like this yield more than $1 in returns by the end of that year. And that same report also noted how underused the program is. Only 7% of eligible families currently access the program. In terms of the bill's provisions, I just wanted to speak very briefly about presumptive eligibility. I'm guessing you all know someone who's been on a wait list for a childcare slot and how tricky the timing is of balancing getting a childcare spot and returning to the workforce. And I just want to point out that families on the scholarship program also have to deal with the wait time for completing the scholarship application. And the steep costs of paying for childcare during that time can actually deter some families from accessing care and getting back to work. So it's an important bill, and we and our partners strongly urge you to support it. And I have some written testimony as well.
Great, thank you. Are there any questions from the committee? Thank you very much. Let's see, where are we? Lakeisha Gebhard.
Hello, good morning.
Good morning.
My name is LaQuisha Gephardt. I'm here on behalf of myself and my daughter. We actually do live in Bristol, New Hampshire. I moved here, migrated here from Massachusetts for a better life, better opportunities for me and my daughter. One of the hurdles was finding childcare. Childcare that's actually easily and safely accessible to both me and my daughter. She does go to pre-K part-time, but finding childcare and being on a waiting list for over a year and a half put a toll on us. We're still recovering from it, but 2025 is looking promising for us. She has been at this daycare that she currently is at for 6 months, but not without going through hoops. We were on the waiting list, on that list for a year. So in total, I was on 3 waiting lists for 3 separate childcares for a year. So I was unable to work a full-time or a part-time job. I did come up with little ways of finding how to feel sustainable or paying our bills. But for the most part, without the help of the DHS's program, the scholarship program, I was not able to find reliable childcare. So I just want to say that the scholarship program is a need for young families like myself moving here, migrating here from other states, who want a better, safe, and healthy environment for their children and themselves. And I found it here in New Hampshire, but the name of the bill, SB 243, I highly support it as a parent who migrated here looking for a better life. Thank you so much.
Great, thank you very much. The last person I have signed up is Cora Lynn Hoppy.
Thank you, Senators. I appreciate you guys listening and being a part. My name is Coraline Hoppy. I'm the Executive Director over at Rochester Child Care. We currently serve 6 months to 14 years. We have littles of about 130 in our center, and we serve about 250 school-age kids. Currently, we have about 168 kids on our scholarship, which is incredible. Last year was a very hard year for us. We're still recovering from market failure, so I saw losses of about $600,000 and had to completely revamp my business, meaning I have to run childcare like a business. So now I have to take in families, make them pay private rates until they can jump onto scholarship. I tried to apply for scholarship and it was a nightmare. It took about 20 hours of my time within 2 weeks in order to fill out the application and then hope to hear somebody call me back and then try to call that person back afterwards because I'd missed their call because I was working. Oftentimes, my families are then unlinked from scholarship. So my agency then tries to cover that cost, which puts us into the red. So we were dropped from our insurance, our workman's comp insurance, and we had to go into a high-risk pool, increasing my insurance rate about 25%. This was the second time I've been kicked off of insurance. Our liability insurance was the first one. So I'm getting paid at the state minimum wage, and I'm being forced to subsidize that cost with my school age program. I keep it affordable by keeping it at the state minimum, but right now we're barely hanging on. We're still at a loss after the 6 months of $14,000. So if you want a functioning economy with parents who have children in a safe place so they can grow and develop, this has to happen. I can't constantly wait a month waiting for payments to come in because my overhead doesn't wait. The electric bills don't wait. My insurance bill certainly won't wait. So it's important as a business owner that I have access to these funds prior because it's like a subscription cost. We pay our cable company prior to receiving that service. So I need that same sort of payment system. And this will allow me to cover the overhead costs of having 84 employees who take care of almost 400 children. It's incredible. It's a $3.5 million company, and I have profit margins of about 2%, which barely go back into my own company. It usually covers weird overhead costs or updates because of compliance issues or other mandates that come through. So I really need you guys, I need the support. Rochester Child Care is one of the largest centers left on the Seacoast in Rochester. So if we were to shut down, it would shut down the city of Rochester. We help our teachers, our firemen, our police, our state workers. So to lose us would mean you guys wouldn't have much of an economy. Thank you.
Great. Thank you for your testimony. Any questions? Thank you very much. Is there anyone else that would like to speak on Senate Bill 243? I'm going to close the hearing on Senate Bill 243. All right. Well, they said it was a fiscal impact of but not a fiscal. There's a fiscal impact of 370. All right, you all set, Sophie? All right, I'm going to open the hearing on Senate Bill 253, relative to participation in the federal 340B drug pricing program. And I'm going to call Senator Tara Reardon. Tara Reardon. You tell me how you want me to say it.
Tara.
Tara, all right.
Thank
Very
you.
good. Thank you.
Good morning, I think, still, Chairman Rochefort and members of the Health and Human Services Committee. My name is Tara Reardon. I represent Senate District 15, Concord, Bow, and Hopkinton. And I'm here today to introduce Senate Bill 253 relative to participation in the 340B drug program. It's a federal program that lets eligible entities like qualifying hospitals, federally qualified health centers, purchase drugs at a reduced price in order to stretch scarce federal resources and reach more eligible patients. Drug manufacturers are required to participate in order to be reimbursed by Medicare and Medicaid. The 340B statute is clear that drug manufacturers must provide 340B pricing to eligible entities for covered outpatient drugs, regardless of where or how the drug is dispensed, as long as that drug is dispensed to an eligible patient. The specific issue pertaining to the 340B program addressed in this bill deals with contract pharmacies. 340B program eligible entities enter into contracts with community and or specialty pharmacies, CVS, Walgreens, to support those pharmacies in procuring and dispensing for the hospital's patients. The contractual arrangement allows patients to receive their prescriptions and the eligible entity to receive the 340B savings. Contract pharmacies are essential to our to our rural hospitals, many of which do not have their own in-house pharmacies and do not inventory particular drugs, and therefore rely on a network of contracted community and specialty pharmacies to ensure their patients have access to the drugs that they need. So what is this bill trying to solve? The pharmaceutical manufacturing industry continues to implement tactics that restrict the 340B program, including limitations on contract pharmacy utilization. The legislature recognized the need to provide these protections just last session with respect to pharmacy benefit managers and carriers. This bill would make it an unfair trade practice for manufacturers to discriminate against contract pharmacies. Thank you for your attention to this today. I am going to defer any questions to the experts that come behind me.
Great. Thank you, Senator.
Thank you, Mr. Chairman.
Let's see. We're going to go Matthew Hood, Dartmouth Health, with Keith Tomasetti and Kristen Chupka. Well, I may not have got it right.
Hi, Mr. Chair, may I just bring up some colleagues if I can? Mr. Chair.
Yes, bring it on up. Yes, absolutely.
Thank you very much, Mr. Chair, members of the committee. For the record, my name is Matthew Hood. I'm the Vice President of Government Relations at Dartmouth Health. I'm going to borrow a page from my colleague Courtney Tanner earlier this morning and hand it off to my colleagues to talk substantively about the bill. Keith Tomasett, who's our Chief Pharmacy Officer, and Kristen Chupka, who runs our 340B program.
Great. Thank you. And just a reminder, we are under some time constraints here.
We'll keep it quick. Thank you, Mr. Chairman. Thank you, committee. My name is Keith Tomasett, and I'm the Chief Pharmacy Officer at Dartmouth Health. And we would like to express our support for Senate Bill 253. As you may or may not know, Dartmouth Health is a 7-hospital system, 5 hospitals in New Hampshire and 2 in Vermont. We are also a rural health system, and we are reliant on the 340B program savings, which enable our ability to care for patients across such a wide geography, as we said, at least over 2 states. This includes supporting numerous specialty clinics that would be otherwise unable to provide care to needy patients traveling into New Hampshire for care at our academic medical centers and our other centers across the state. Your support for this patient population, as is the intent of the 340B program. It is important to remember that we do not control over where our patients decide to get their meds filled, nor should we. Patients should have the right to choose where they obtain their health care. That said, patients are often incentivized to choose the pharmacies preferred by pharmacy benefits managers and/or manufacturers, which this contract pharmacy bill would still help support gaining that benefit. We have submitted our impact statements that list a number of the things we do with our savings, yet we do want to highlight a few of those as it relates to the 340B savings program. We support the treatment of over 200 hemophilia and other bleeding disorder patients with life-saving and critical therapies. Other benefits to this group include nurse-managed care coordination, community-based education, support for youth and adolescent self-management skills, and mental health support. We also support treatment of over 1,000 patients living with HIV as the only Ryan White grantee holder in the state of New Hampshire. Other benefits with this group include care services in multiple locations with New Hampshire, continued expansion of PrEP support, and funding under the grant Care for Needed Medical Services. And I know I'm at time, but lastly, we support a discount medication program at our pharmacies that can be accessed by patients who have either large deductibles or cannot afford medications post leaving the hospitals. And this program prevents patients from getting readmitted due to the inability to get their medications.
Thank you. Ms. Chupka, I would like to hear from you if you've got prepared testimony.
Hi, thank you. My name is Kristen Chupka. I'm the System Director for 340B at Dartmouth Health. And as Keith mentioned, we have 7 hospitals under our system that are supported by 340B. I've been a pharmacist for over 20 years, and since 2013, I've worked in the 340B space at another health system in the state of Maine. And this by far has been the most rewarding experience of my career, being able to assist patients with their medications, but also the services that we're able to provide. I want to call out New London Hospital in New London. They have two very important services that they would not be able to provide without the 340B benefit, one of which is their urgent care that they opened to be able to provide services for patients who need to be seen urgently that don't really qualify for emergency room visits. And the second is their ambulance service. So if we think about these contract pharmacy restrictions and the inability for New London to be able to receive the 340B benefit for the patients that they are eligible for 340B through the New London Hospital, what are you going to do? Are you going to get rid of urgent care and ambulance services, or are you going to get rid of primary care? Are you going to get rid of providers? You're going to get rid of care management. There's going to have to be something that gives. And so this program is incredibly critical for some of our smaller hospitals in the state of New Hampshire to be able to care for our rural patients in this environment.
Thank you. Any questions? Senator Abart.
Thank you, and thank you for your testimony. So, you know, in New Hampshire, we have charitable gaming. And charitable gaming is required to give a certain amount of money, and we can track where that money goes. Is there a way that we can track how you're actually funding these programs through this 30B? What is it?
I mean, yes. So every impact statement that you'll read will detail out the benefit that we've received and what we have put that into. So there's many more things that Dartmouth Health supports with 340B savings and value across the state that was not mentioned here today. We did not want to belabor the tick and tack of all of the things that we can do. But with this program being attacked by the pharmaceutical manufacturers, I am worried that this will continue to become a burden to the patients of our state.
So follow?
Yeah.
So there is a link that we can go, this is the money that went to this went here.
There is no reportable requirements through HRSA for us to talk about, but I'm certainly happy to meet with any of you to discuss in depth, you know, what we do with that savings to support the patients of New Hampshire.
And final question.
Yes.
And this helps low income and uninsured, how?
Because we're able to support increased services, so mental health, patient medication assistance, care management, all of those things that we do along with the losses we take for uncompensated care, decreased reimbursement rates through the payers, Medicare and Medicaid. So there's a lot to talk through. But yes, this does impact those underserved.
In essence, to follow up, in essence, we're providing through this benefit free and reduced care for patients who, wherever they're coming from across the state. You will see in our submissions one of the specific pharmacy programs that we provide with lower cost drugs. See another question.
Senator Apprentice.
Thank you, Chair Rochford, and thank you all for joining us here today. I think that you may, I forgot your name. Yes, I think we worked together last year.
Yes, we did. Thank you.
Nice to see you again.
Yes.
So you talked about, first of all, I appreciate that you talked about the community benefits versus what are considered the costs at the counter, and got to two places that I love, which is urgent care and emergency medicine. But this is an opportunity for you to talk about some of those impacts that you make outside of there, and free and some reduced care, some uncompensated care, and this is a statewide program. Are there any other impacts that you'd like to highlight at this moment? I'm giving you the floor for a few minutes to do that.
Sure. So
I think it's important for us to hear what those trade-offs are for cost at counter to community benefits, vice versa.
So many of our hospitals participate in community food banks. New London, as highlighted, I'll like to keep some attention on them. They're one of my favorites. They offer diapers, right? You can walk in and grab diapers. I mean, it's the little things sometimes to our communities. One of the other initiatives that we've really put a lot of investment in with the 340B support is to be able to, how do I say this the right way? We want to make sure all patients get care, right? And so just because you're a 340B eligible patient doesn't mean in this state that we can qualify that as a 340B eligible encounter, right? We have to carve out Medicaid. And so what we're aiming to do with the benefit is to continue to support, right, uncompensated care in Medicaid patients and the uninsured who aren't eligible. I think that's the big gap. And so all patients receive the benefit, most importantly, those that need it, right? And so we want to highlight the opioid epidemic and the availability of us to put providers into mental health. The Ryan White program that Keith mentioned, we're the only HIV grant in the state. And so that money supports transportation for those patients. It supports the mental health services for the specific patient population. Let's look at HTC patients, the Hemophilia Treatment Center. There are children, right, who are getting injectables. That medication is millions of dollars a year in some cases for some of these patients. They're not going to be able to afford that. And so being able to support some of these vulnerable patient populations specifically with this program, along with, you know, you and me and my neighbors, is really what I think is the takeaway.
Thank you. Follow up, Senator?
This is actually follow up on something Senator Avard had asked. May I?
Yes, absolutely, yes.
Reports. So I believe if I heard you, your question was, you know, are these reports, because there were questions about transparency, posted anywhere and it's not required, but would you be willing? I mean, is there a way to provide, you know, like a community benefits report related to all of the 340B impacts?
So the Dartmouth Health does put out a community benefit report. Doesn't specifically call out what part of that was supported by 340B, but I think if you read our impact statements, you'll clearly see that just in the uncompensated care alone, the 340B benefit that we receive is not enough to even cover that. Right. And so, you know, knowing that that is a responsibility of us as a nonprofit healthcare provider in the state of New Hampshire, right? That's why we are doing all of the other things that we're doing to be able to support patients. In terms of being able to kind of talk through that, I mean, we're happy to show you, again, detail that you'll be able to read in those impact statements. I do want to really be careful, though, because when we think about, you know, the savings and maybe some of the other things you'll hear today, it really is hospital by hospital. So it's not a one size fits all. I mean, your FQHCs in the state operate very differently from nonprofit healthcare organizations, critical access hospitals, rural referral centers, disproportionate share hospitals. So every one of us is going to use that benefit in a different way.
Thank you.
Actually, Senator Birdsall had a question. She does.
Thank you, Mr. Chair. Thank you for taking my question. So what is the percentage of your 340B savings that's allocated toward patient assist programs versus administrative costs?
I would have to get that back to you specifically. But again, when you see the impact statements, you'll see the amount of uncompensated care and the amount of 340B value that we brought in that particular fiscal year timeframe. And again, happy to do any additional digging if you're curious about specific factors related to how that all kind of carves out.
Follow up.
So can a patient get...
Excuse me. Going around.
I guess. Can a patient get their script filled at any pharmacy? And if so, if it isn't a contract pharmacy, what would be the cost difference?
So technically, a patient should be able to get a prescription filled wherever they want, but that is not always the case. There are sometimes restrictions put in place by the payers or the manufacturers that will require patients to get their medications filled at a certain pharmacy, which may adjust the price of the medication, not necessarily the price to the patient.
Senator,
Can I just answer? Sorry, can I answer the previous question? I believe you'll see, Senator, in the impact statement, the numbers, if I'm recalling correctly, 12% was what you were looking for.
12%?
Senator Avard.
Yeah, so just to take some of the heartburn, potential heartburn, would you be objectionable to requiring community benefits report?
We would not be opposed to some form of reporting, and we would hope to work collaboratively with the state to be able to put together something that works for all covered entities.
Thank you.
Any other questions?
In agreement.
So my experience on this may be dated, so please forgive me, but when I remember when this program came out, and the intention of the program was to improve access of medications to low income, underinsured patients. But what I'm hearing today is you're using the rebates to fund ambulance services and buy diapers and support a food bank. I mean, that's contrary to my understanding of the purpose of the program.
The original intent of the program when it came into fruition in the 90s was to stretch scarce funds to provide overall healthcare benefits across the community. It wasn't specifically related to medications and specific patient populations. It was the opportunity to spread community benefit across the neediest of patients. It wasn't designed to be specifically a medication program.
So again, I'm a little dated with my information. At the time when these 340B programs came out, you had a contracted pharmacy. They were contracted, at the time with a federal community health center, and they came in with separate inventories, and the inventory was separate. I understand that's all been different, and that's all digitalized now at this point. But I remember one program in particular that was explained to me locally where there was a sliding scale. So people that went to the clinic were identified as a qualifying person. They went to the pharmacy. There was a sliding scale. They paid a nominal amount for the medication. They got their medication, and all was good. How does that sliding scale work now if we've got several pharmacies participating? What kind of savings do the individuals in the communities realize if they're going into a Rite Aid, for instance, and they show up and they go to, they're still going to the local community health center? And I know there are other people coming after you that may be able to answer that question. So if you don't have an answer, don't dig a hole.
Yep, no, not planning to. Again, it goes back to the intent of the program to be a benefit to the community in general, whether that be directly to the patient at the counter or patients that are being seen in a hospital that can't afford being seen in the hospital.
Okay, go ahead.
Yeah.
So I thought you
go
were
ahead.
finished. So the patient that goes to Rite Aid may not necessarily be experiencing that benefit there, but somebody in the community will benefit from it.
And it could be that same patient that may need assistance from the hospital at a later time, yes.
Okay. All right, thank you. Any other questions? Thank you very much. I've got Morgan Holleran.
Slush fund.
Good morning, welcome.
Good morning.
Just to remind you, we are on a time limit, but
I'll be as brief as possible, Senators. Thank you for having me here today. My name is Morgan Haller, and I'm Director of State Policy with the Pharmaceutical Research and Manufacturers of America. Pharma is opposed to Senate Bill 253 because it locks in exactly what is broken with the 340B program and would enshrine into state law problems that would ensure increased profits for large hospital systems, pharmacy benefit managers, chain pharmacies, and other third-party actors that have found a way to exploit the program for their own profit benefit. Pharma and its members company, and I want to make this very clear, fully support the original intent of the 340B program. The program is a federal program, which would really need a federal fix. And we support the program that substantially reduces prices for safety net hospitals and clinics to help low-income patients. But the program is systematically broken. It has grown to be the largest program after Medicare Part D. Sales from 340B drugs surged from $12 billion in 2013 to $66 billion in 2023, which is over a 20% year-over-year increase. So what is contributing to this growth? In 2010, as you've heard, HRSA issued guidance, sub-regulatory guidance. So this is not in federal law. This is sub-regulatory guidance that allowed covered entities to have as many contract pharmacy arrangements as they would like. As a result of this, we've seen the numbers skyrocket. In 2010, there were about 2,300. Today, there are over 205,000 contract pharmacy arrangements. 69% of these arrangements are with one of the 3 largest PBMs. So the impact of the growth is really alarming. And recent analysis shows that half of every dollar in contract pharmacy profits goes to 4 major PBMs and their affiliated pharmacies. What is more concerning is we've seen reports out of the Department of Health in Minnesota that found that 10% of safety net federal guarantees, the clinics, may I continue?
Finish up, yeah.
Okay, sorry. They reported negative net revenue due to the payments made to middlemen. The bill does not help patients access their medications. The contract pharmacy status doesn't affect a patient's ability to fill a prescription or the price that they pay. In fact, if an uninsured patient takes their script from a 340B hospital and goes to fill it at their local CVS, it is very likely they're paying the full list price of that drug while the hospital is making up the difference. I also just want to quickly mention, if it's all right with you senators, the impact to employers. Employers lose manufacturer rebates due to 340B pricing because you can't get double discounts. So we know based on studies out of Minnesota and North Carolina that covered entities are marking up 340B drugs, which has resulted in higher health insurance premiums, and payers are often paying 5 to 7% more for claims than they pay for others. A North Carolina State Treasurer report further found that hospitals are charging insurers 5 times their acquisition cost for oncology medications. A recent IQVIA study also pointed out that here in New Hampshire, and these are conservative estimates, that these practices cost employers an estimated $45.7 million in lost rebates and reduce state and local tax revenue by $2.3 million. Thank you for your time, and I would just urge you not to lock in a piece of federal guidance into state law that has a lot of unintended consequences without really understanding the impact. Thank you.
Thank you. And in your testimony, you said you supported the 340B.
I'm opposed, I'm sorry.
No, well, the original intent.
Right.
But it seems to have morphed into something that, goes towards uncompensated care. And was that the original intent of the 340Bs, or was it more narrowly crafted?
The original intent was to stretch scarce resources to help patients. But I would argue that, in New Hampshire here, at least charity care rates at 340B hospitals are 75% below the national average. In total, hospitals in New Hampshire make 6.8 times as much from 340B as they spend on charity care. 340B hospitals in New Hampshire provide less charity care at 1.12% than the national average. So it's just something to keep in mind.
I'm sorry, in New Hampshire?
Mm-hmm.
Only 1%?
Less 1.12%. In charity care.
Instead of 12%?
That's what we have as numbers, yes. And I believe that is in your packet.
All right. Any other questions? Oh, sorry. Talk to me about pharmacy benefit managers and their role in this, if you could.
So through vertical integration, the health insurers of many of the major health insurers own the major PBMs, which then own the major contract pharmacies. So everyone is taking a little piece of the pie here, but I think the alarming statistic is the one out of the Minnesota Department of Health report, which showed that 10% of safety net federal grantees, which are the clinics, reported negative net revenue due to payments to middlemen, and the fact that they're taking more than half of every dollar that in profits go to the 4 major PBMs. I would say that is obviously not the original intent of the program, but they've found a way to manipulate it.
So the PBMs are made whole. The pharmacies theoretically are made whole. We're getting this net public benefit, if you will. But according to your testimony, patients are still paying list price when they go to the pharmacies to get the drugs.
Right. Of the uninsured patients. And then otherwise, if you're insured, it's going through your insurance like normal. You're not seeing a reduction at the counter for those drugs, even though they were given at a substantially reduced rate, upwards of 60%.
So they're processing through the PBM, and the PBM is saying charge retail.
Right. And I just wanted to address something that was said, about the idea of which pharmacies patients can go to. Manufacturers have no input in that whatsoever. The pharmacy benefit is designed by the health plan and the PBM. We don't have any control over where a patient can fill their prescription.
So, and again, I apologize, but I want to get into this a little bit more. So you said there's 205,000 pharmacies participating. I'm assuming they're participating because they have contracts with the PBMs and the PBM.
Right, and that was one of the statistics there. 69% of the arrangements are with contract pharmacies that are owned by the larger PBMs.
Okay. Any other questions? Thank you.
Thank you.
Ken Gordon. Good morning.
Good morning. Thank you for the opportunity to testify on Senate Bill 253 related to 340B drug pricing program and its importance to rural communities like mine. My name is Ken Gordon. I serve as the CEO of Coos County Family Health Services, a federally qualified health center serving Coos County, the North Country. We operate clinics in Colebrook, Berlin, and Gorham, New Hampshire. We provide primary care, dental and behavioral health and substance abuse services to more than 12,000 people at 5 clinics and 2 dental offices. We also provide care for more than 200 residents in county nursing homes in our area. We're a nonprofit organization that was founded almost 50 years ago to solve a particular public health policy problem. And that problem was, how do we assure access to primary care services in one of the most rural and poor areas of the state? For the past 3 decades, the 340B drug program that was established in 1992 by Congress has played a major role in helping us to address this fundamental problem. In essence, the 340B program is an agreement between the federal government and the drug manufacturers that allows companies to sell their medications within the Medicaid program in return for providing safety net medical providers with discounted pricing for these medications. No taxpayer funds are used to support this program. The program has made it possible for us to do 2 things. First and foremost, we're able to provide medications that our patients need at an affordable price. And it has also allowed us to use the savings from the program to support and expand our services to include dental care, transportation to and from medical appointments, specialty diabetes care, and more. In our case, the program has become a major source of revenue for the organization, generating at its peak nearly $3.5 million in gross revenues and net savings of $2.3 million. Can I continue?
Yeah, you can finish up. Yep.
Sure. In the past year, with the implementation of restrictions by the drug manufacturers that limit the number of pharmacies where 340B pricing is available to us, our savings from the program have dropped by more than 1/3, resulting in a loss of net revenue from this program that exceeded more than $600,000 in our last fiscal year. Losses of this magnitude for an organization of our size are not sustainable. I don't think it's hyperbole to say that the existence of primary care in the North Country and in many other areas of the state is threatened if we're unable to find a solution to this problem. Thank you.
Thank you. Any questions on? I had a quick question. It's something you said, this is an agreement between the federal government and Pharma. What is the state's role? I mean, are we sticking our nose into something that's already predetermined between a federal entity and another business? It makes me a little uncomfortable to do that. And I don't know if other states have done that. What's the outcome been?
Yeah, I think 12 states have passed similar legislation as the one you're considering. The legislation has been challenged in court, and I think in almost all of those cases, the state has prevailed to date.
And then my other question for you is, I mean, why do we need this legislation? If you're doing this and you're getting $3.5 million in revenue from Pharma as is, we're providing these services, why do we need the legislation if it's working fine now?
Well, the amount that we've been receiving has dropped dramatically in the last couple of years. So in our case, we lost about $600,000 of those net revenues that we've used to, one, make drugs affordable for those that don't have insurance or don't have the means to pay for it. And secondly, to support our primary care services, our dental services, and the other ancillary services that I mentioned.
As a result of the decline, those services are threatened, you're saying?
Correct.
Okay. Any other questions from the committee? No, thank you very much.
Thank you.
Greg White.
Good morning. Thank you for your time. My name is Greg White. I'm the co-CEO of Lamprey Healthcare. We are also a federally qualified health center serving the communities of Nashua, Newmarket, and Raymond. We also have a number of integrated sites in Nashua and Derry, as well as a mobile health unit. Much like my predecessor, Ken, we participate in the 340B program as a covered entity. We are eligible to do so. We have contracts with numerous pharmacies simply because we do not operate our own pharmacy. We have a service area that spreads from as far west as Wilton all the way to the seacoast. Consequently, we have multiple contracts with multiple stores, as we are required to have by our federal overseers. I won't reiterate the things you've already heard just in the essence of time, but I would point out that how we use these proceeds and the benefits of this program. First and foremost, we have an uninsured program that our patients are able to avail themselves of to actually benefit from the savings from these drug pricing. So with Lamprey, we work with Walgreens and Rite Aid, where we have a discount card program specific to us. We have a data feed that indicates our site, our patients, and our providers so that they know when the patient comes in that they can charge them a dispensing fee and the 340B price. So in many cases, that could be a $300 prescription for $25. Very, very much cost saving for the individual. One of the challenges that we face, backing up, we also use it to plow savings that we generate on margins on insured patients back into our mission, which I believe we've heard earlier is the intent of the program to stretch scarce resources. In Lamprey's case, we've actually had an operating deficit for the last 2 years, so you could make the case that our entire operation has been kept the motor running with proceeds of 340B. One other point. One of the challenges we're facing right now is certain manufacturers have restricted distribution of their medications to one store, which conceivably is fine, except the geography of our patient base spans 75 to 100 miles. Not convenient, particularly where transportation is a problem in many areas of the state. So that's why we are concerned about some of the restrictions we're seeing and why it's important to us to have availability to all of our stores and all of our locations.
Great, thank you. Any questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. Are the feds aware that the deals have gone down? And are they looking to address it? I mean, what I'm hearing is that your savings isn't what it used to be. It's
correct.
Now, are the feds aware of that? And is there something being done at that level?
I think the federal government is aware of it. HRSA is our overseeing agency. The Office of Pharmacy Affairs is the division that oversees this. I think it's been tied up in court in terms of whether or not they have the authority to do so.
Okay, great. Thank you.
Any other questions? Thank you very much.
Thank you, sir.
Christine Stoddard.
I almost said good morning, but I don't think it's morning.
We're not there anymore. Yes.
Thank you. Good afternoon. My name is Christine Stoddard, and I represent Bi-State Primary Care Association. We are the association for New Hampshire and Vermont's community health centers who are covered entities. In New Hampshire, our health centers serve over 100,000 patients. They are legally required to be located in what are known as medically underserved areas, which means there's a lack of clinicians there to treat the people that live in those communities. And they're also required to serve medically underserved populations, so patients who have difficulty accessing services. For example, 3 of our health centers serve predominantly homeless patients. And you've heard a number of ways that this bill would help, but I want to add that homeless patients, they can sometimes be hard for us to reach. The 340B savings that health centers receive pay for a mobile clinic to go out to where patients are to provide the services that they need. And to the point earlier about, why isn't Congress doing anything? We can all guess why, but this is a New Hampshire solution to a New Hampshire problem. Our health centers are losing money on 340B because drug manufacturers are putting restrictions in place as to where their patients can access their medicines from, which reduces the 340B savings that our health centers acquire. This means that for many of our patients, they can't get the care that they need. And it also reduces the savings that the health centers receive. We use that savings from 340B to pay for programs like medication assisted treatment. Where are we going to get the money to pay for MAT if we don't use 340B savings to do so? I understand that this is a federal program, but this is how the legal system works. Congress passes a bill or a statute, and then we can change and put further restrictions or permissions in place. But they really set the floor. We can keep going. Just because it's a federal program doesn't mean that we can't make change. And like Ken said, other states have done so, and they've done so very successfully. And those court cases that have happened, the states have won. So I urge you to consider the impact to the patients. This bill is necessary, Mr. Chair, because without 340B savings, patients can't access care that they need. And I just ask you to consider the alternative. Where would they go? In Ken's case, they're the only primary care provider in the Berlin-Gorham area. And you'll hear from Ed Shanshala soon about how many sites they serve and where their patients access pharmacies.
Great. Thank you. Question, Senator.
Thank you. So previous testimony said that only 1% is going into relief instead of the 12%. And that's concerning. How do we track this?
So sure, those figures I don't represent those entities. I represent community health centers, federally qualified health centers. And I believe the citation was also from Minnesota. We're talking about New Hampshire. These are New Hampshire citizens who are benefiting. In the last year, the federally qualified health centers, their 340B revenue it made up 21% of their revenue. Where would they get that revenue from if not for 340B?
I'll just ask one more.
Yeah, go ahead.
So in the methodology of this, it says this bill prohibits drug manufacturers from denying, restricting, or prohibiting the acquisition or delivery of 30B covered drugs to these covered entities unless required by federal law. I'm nervous about just imposing ourselves into this. Can you help me? Can you dissect that for me? What are they saying here?
It's very common for us to cross-reference federal statute and state statute. We do it often. But what this is saying is, say I am one of Ed Shanshala's patients. If I live in the middle of the North Country and my pharmacy is an hour away, what's happening now is that the drug manufacturers are putting restrictions on the federally qualified health centers saying your patients can only access A, B, and C drug at 1, 2, 3 pharmacy. They can't go to the closest pharmacy to them, so they have to drive further and further away. Imagine your parents living in the North Country needing to get their diabetes medicine in the middle of winter, and a drug manufacturer saying this covered entity cannot sell their drugs to their patients at the closest pharmacy to their patients. So that patient ends up having to drive miles to get medicine that they could have gotten around the corner.
Do you have a follow-up? Go
I
ahead.
kind of do, but what we heard is that the drug, I believe the pharmacies are being increased exponentially to 250,000 people getting involved in this program instead of it decreasing. So that doesn't seem to jive with what you're saying.
I am not denying that there are not problems with this program. We wish that Congress would do something, but in the absence of that, we are asking you to help Granite Staters access care, and that is through this bill, because we don't want to limit where patients can access their necessary medications. We don't want to decrease the revenue of the community health centers because they are serving your constituents. And without them, where would your patients go? Where would your constituents go? There's truly no place else in the North Country but for the FQHCs.
So I've got a question about the access. We heard earlier that the 340B program is contracted with every major PBM in the country. I don't know one pharmacy that doesn't contract with all the PBMs.
I can't, Mr. Chair, I can't speak to what the PBMs are doing. I can only represent what our community health centers use those drugs for. The statute is not perfect, but why can't we fix what we can fix at the state level to ensure access?
So along that line, I mean, some of the stuff that you had, it makes me very nervous getting in between a company and a federal government and a contract. However, but I'm gonna go with with what you said. Why don't we just restrict it to federally qualified community health centers? I mean, if you said we can put restrictions on the program, then everybody, I mean, the most vulnerable are taken care of. We're taking care of, the people that are not having access to this. We're providing revenue,
Sure.
a guaranteed revenue stream. Can we do that?
No, because the federal statute sets the floor, right? So the program has to allow for critical access hospitals and Ryan White programs and federally qualified health centers to participate. You can't narrow who can participate, but you can clarify that patients should be able to access drugs at their nearest pharmacy. And that's what this bill does.
Something that's come up in this testimony today that we've heard, I have no doubt the federal qualified community health centers are using this program and benefiting the community. But what we're hearing, there's other entities that are participating that we've had some questions raised as to really, are they using this the way it is meant to be used? I have no doubt that Coas Family Health, Lamprey Health, Amanuensis Health are using this program for exactly the way it was intended. No doubt in my mind. The problem that I have is there are other entities now participating in this that are, putting, because of their participation, perhaps, it's putting these smaller groups in a bind.
I did not hear one example of a New Hampshire hospital or a New Hampshire health center doing something nefarious.
I didn't hear anything nefarious, but what I'm hearing is it's putting a strain on the system.
The 340B program
Yes.
is. It's helping your constituents access care.
And my constituents, by and large, use federally qualified community health centers. I have no doubt about that.
Yes.
No doubt about that. And if I could take this program and ensure that every single one of those is made whole and protected, I would do that now. And I put an amendment in now. But what I'm hearing is that's not allowed to do that. And, we can't do that. We have to let everybody to participate. And, we're talking, profits. I mean, we heard one person testified that it's, they're using, there's questionable uses of these funds.
I would again say, give us a New Hampshire example of a New Hampshire nonprofit healthcare organization who barely keeps their doors open doing something wrong. We don't have those examples. We're trying to better increase access to care. We're not trying to, and and I should say, these are all nonprofits. They have very, very strict reporting requirements. FQHCs are regulated like no one else. They have HRSA inspections every 3 years. They go over their books. They have 340B drug reporting requirements. They are heavily regulated. Please tell me what covered entity in New Hampshire is breaking the law. We have not heard one story of that. And this program is critical to patients accessing care. And without it, where would they go? And Mr. Chair, we were here the other day talking about uncompensated care. The health center's uncompensated care is almost $15 million. Their 340B savings is the same exact amount of money. If we don't fix 340B, their uncompensated care is going to increase. And where is the state of New Hampshire going to get that funding to keep them whole?
Thank you.
One final question. Have you or anybody in favor of this bill reached out to our federal delegation to fix this problem?
Absolutely. There was actually a bipartisan bill last session that almost made it to the floor, and it just didn't quite get there. But the Congress is very well aware of it. There are bipartisan solutions. We just need them to get on the floor.
Thank you. Any other questions? Senator Apprentice? No, I'm sorry. All right, there. Thank you very much. Tanya Carlton.
Make sure you hit your button.
All right.
Sorry, I distracted.
So we've got Tanya and I'm assuming this is Megan.
Yes.
All right, we're gonna have two for one here. Thank you.
Thank you, Chairman Rochefort and members of the committee. My name is Megan Tish, and I'm a practicing health system pharmacist here in New Hampshire.
And my name is Tanya Carlton. I'm also a practicing pharmacist here in New Hampshire. I'm a health system pharmacist. I've worked over 20 years in the state of New Hampshire for a variety of health systems, and I'm the immediate past president of the New Hampshire Society of Health System Pharmacists.
And we are here testifying today as representatives of the New Hampshire Society of Health System Pharmacists. New Hampshire NHSHP represents pharmacists and technicians working in organized health systems in New Hampshire to advance practice of pharmacy, ensure that New Hampshire is a model of excellence in health system pharmacy. NHSHP supports Senate Bill 253. Access by hospitals and clinics to the discount provided under the provisions of the bill are essential to ensuring that New Hampshire citizens continue to have access to high-quality healthcare by utilizing 340B savings to expand programs and services. The 16 hospitals participating in the 340B program in New Hampshire rely on these savings to provide critical access for patients across the state, not just those who enter the hospital doors, but also those who receive care in the broader community. This program allows the hospitals to stretch limited resources further, reinvesting savings into patient assistance program, chronic disease management, treatment services, and access to specialty medications that might otherwise be unaffordable or for our underinsured or uninsured patients. Protecting contract pharmacy arrangements is critical to maintaining patient access. Many smaller hospitals do not operate their own retail pharmacies or may be unable to stock certain medications due to high cost or payer requirements. Patients may also prefer to fulfill their prescriptions at a trusted local pharmacy or need access to a specialty or mail order pharmacy to receive the medications to treat their conditions. Reduction of the benefits of the 340B program to New Hampshire hospitals would be disastrous given the current environment. The significant increase in drug costs would worsen the economic hardships that all New Hampshire hospitals are facing, but especially to our rural and critical access hospitals that prove so vital to our citizens. We urge the committee to act in this session to protect the well-established program that has been working for the benefit of our New Hampshire citizens for over 30 years. Thank you.
Thank you. Any questions? I've got a question, and if you could, and I may, and there's somebody coming up that may be able to speak to this, but can you tell me what HRSA's role in all of this is?
I can speak a little bit to that. So HRSA does oversee the program, and they do audits to ensure that the health systems that are covered are utilizing the program the way that it was deemed to be utilized.
Okay. All right. We'll leave it at that. Thank you.
And like you said, somebody else may be better to answer.
All right.
than
Hey, you
me.
did well. Thank you very much. Any other questions? Thank you very much. Ben Bradley. Yes.
Good afternoon, Mr. Chairman, members of the committee. For the record, my name is Ben Bradley, and I represent all the state's 26 acute care hospitals and all specialty hospitals. On behalf of the 16 qualified 340B participating hospitals, the New Hampshire Hospital Association supports SB 253, which would take meaningful action to prevent drug manufacturers from exploiting a loophole in the federally authorized program. Congress instituted 340B in 1992 as an effort to help shield hospitals and other healthcare providers from the major increases in drug prices that drug companies have employed year over year. Drug prices are the most rapidly growing expense for hospitals. For the first time in history, the median price of a new drug to market is $300,000, more than 4 times the median household income in the United States. This issue comes down to a few key points. Out-of-state drug manufacturers make billions of dollars off of Medicare and Medicaid. Just ask our Medicaid director how much he's spending on pharmaceuticals. Federal government established the 340B program to require drug companies to provide discounts on their products to stretch scarce federal resources for providers serving qualified communities and qualified patients. The loophole we are seeking to close is across the country, manufacturers are withholding 340B benefits when the qualified provider uses a contracted pharmacy for patient access to medications. This is something that the prime sponsor went over. Many 340B eligible providers do not have their own pharmacy or contract out with a pharmacy for specialty drugs. Up until recently, the manufacturers honored 340B benefits entitled to 340B participants. Now manufacturers are denying those benefits to providers, which impacts their ability to offer care in their communities. This is something that Christine Stoddard talked about and others from federally qualified health centers, demonstrating that their benefits are going down. Washington's inaction to fix this loophole has motivated several states to take actions that ensure qualified healthcare providers and hospitals in their states receive the full intended benefit of the 340B program. Other states are also contemplating 340B legislation this year, and I've spoken extensively with many of my colleagues across the country on this topic, as others have become frustrated with Washington's inaction, including several states' attorneys general standing up to drug manufacturers. 8 states, Kansas, Missouri, Arkansas, Louisiana, Mississippi, Minnesota, West Virginia, and Maryland, have said enough is enough and closed this loophole to ensure their community assets receive the full benefits of the 340B program. This bill would have New Hampshire join those states, ensuring providers and patients get their benefits they're entitled to, and don't allow drug manufacturers to walk away from their intended obligations, making billions off of taxpayer-funded programs. I've included in my testimony, which I'll hand out momentarily, several impact statements which were referred to earlier by others who are testifying that participate from our members who participate in 340B, which outline the important services made possible by their participation in the program. I'm happy to answer questions.
Senator Avard.
Thank you. And getting back to our federal delegation, have you communicated with them and what was their response?
Yes, this continues to be an issue for local providers in New Hampshire eligible to participate in the 340B program. I think it's working its way through the federal process. I think HRSA has outlined several guidelines that help protect, just as we're trying to do here. It's the drug manufacturers who are countering that and not providing the benefit as intended. So that's why we support this bill for New Hampshire to engage and say enough is enough. We want to ensure that this program works as intended, just like those 8 other states have done around the country.
So my question is, follow-up, thank you. What was their response to you in your communications to them? And should we ask them as a committee to light a fire under the seat of their pants to get something done rather than this legislation?
Well, 2 things, Senator. One is their response is we're working on it. We're doing what we can. They understand the issue. HRSA is the agency that oversees this. And then as far as lighting a fire, that's just what I'm trying to do with you, Senator, with members of this committee, to understand that you have an opportunity to do something with this bill. And why wait for Washington's inaction to protect the benefits for providers here in New Hampshire and stand with us rather than out-of-state drug manufacturers who are making billions?
Right. And I'll just follow up with my final question.
You know, one more.
That's it. I'm taking it too. We heard that there's a disparity between the 1% and the 12%. I don't believe it's Minnesota. I believe it's New Hampshire that's falling short with the monies that belong to the people that are indigent with or uninsured. And I'm not sure that we're following up on that. I want accountability to that.
I take issue with the 1%. I think if you look through our impact statements, which we gathered in preparation for this hearing, you will see the considerable investments that our members and others who participate in this program commit to their communities, and not just federally qualified health centers or people in the North Country. Our members across the state serve low-income individuals. We provide it without asking where payment is coming from, and we do it every day, 24/7. So please, if you'd like to look into those impact statements, if you want to talk about further transparency or accountability, we're at the table, and we're glad to speak with you about that. But I take issue with the suggestion that we're not doing enough with these savings.
Senator Apprentice.
Thank you, Chair Rochford. And Ben, thank you for taking my question. You talked about 16 of your members take part in the 340B program.
That's right.
Can I assume that a majority of them, because I've lost track of how many critical access hospitals we have in the state, acting as these, safety nets in the more rural areas. How many of these are critical access?
So Alice Peck Day, Androscoggin, Concord Hospital Franklin, Cottage Hospital, Huggins Hospital, Littleton Hospital, Monadnock Community Hospital, Spear Hospital, Memorial Hospital, New London Hospital, Upper Connecticut Valley Hospital, Valley Regional Hospital, Weeks Medical Center.
Okay.
I have a whole list here for you if you'd like to look it over.
And they're all they're all critical access?
Those are critical access. There are others that are not critical access that participate in the program and do so legally with the obligations that HRSA has outlined for them.
Thank you very much.
Talk to me about HRSA.
Sure.
Tell me about what they are, what they do. I think I know what they are, and I think I know what they do, but I want to hear it from you.
Certainly. HRSA is the Health Resources Service Administration. They are an agency under the Department of Health and Human Services at the federal level. They are the entity that oversees the 340B program. They also provide several measures to ensure the program's integrity, which I'd be glad to provide additional information for you. I did not print it for each member of the committee, but I do have information here that I can leave. It comes directly from their website and outlines the expectations for participants, eligible entities. It also outlines expectations for the manufacturers who are obligated to follow the expectations of the 340B program as a condition of their participation in Medicaid and Medicare.
Are they a rule-making entity, or do they just give guidance for participants?
They can issue rules.
Do they have rules on this issue? Or are they just guidances?
I believe they do.
Okay, all right. If you could leave that would be great. The other question I have, I mean, you mentioned Littleton. I reached out to Littleton Hospital 2 months ago, and I said, what are your major issues, coming up? And I haven't heard anything from them. So I just have to assume they have no issue with this.
They do, and that's why I represent them, is to bring material that you can review, including their impact statement, which they provided to us in response to our preparation for this hearing.
Great. Now, of these critical access hospitals that you mentioned, how many have in-house outpatient pharmacies?
Could you ask the question again?
Yeah, of the critical access hospitals that you mentioned, how many of them, well, probably a better way to state this, how many are lacking, in-house outpatient pharmacies?
I don't know the answer to that, but I could try to gather it for you.
Any other questions for Ben? No, thank you very much.
Thanks.
That is the end of my list. I know Ed Shanshala, you were mentioned by name, so whether you want to come up or not, you're coming.
Ever since grade school is used to be left out, it's okay. It's all right. I grew up Irish Catholic. I thought it was my fault. Anyways, my name's Ed Shaw. I'm between you and lunch, unfortunately, and I'll try to keep it brief. I'm the CEO of Amanuset Community Health Services. We have 5 care delivery sites across 26 towns, 30,000 residents. We see 1 in 3 of your friends, family, and neighbors.
Can you speak up?
I sure can. Yeah, it's a oft asked question.
Yeah.
Thanks, David. So we're in Littleton, New Hampshire. We have sites in Warren, Woodsville, Littleton, Franconia, and Whitefield, 26 towns, 30,000 residents. We are a federally qualified health center. And we participate in the 340B program. And we take the program integrity seriously. We have been through a HRSA OM Office of Pharmacy Management, which is really the actual legal entity within HRSA who does the audits. They maintain the OPACE database that you can check and you can find us. Our sites and our contract pharmacies are all there in full transparency. So we take seriously that we don't duplicate discount. And by that, with Henry Littman, you get a rebate on Medicaid. And so if it's a Medicaid patient, we stand down because that would be duplicative discount. And I go to jail for that. We also don't divert in that if it's not our patient of us as a covered entity, then that patient's prescription is not eligible to be refilled through the 340B drug pricing program. So those are 2 areas of compliance we take seriously. I've been through a Office of Pharmacy Affairs audit. When in doubt, we leave the money on the table. We don't get cute with it. So I take it seriously on the program side. When I look at our pharmacies, we do have patients who are sliding fee scale eligible, and being restricted to a pharmacy, especially for those patients, I'm caught in a conundrum. There's pharmacies in Plymouth and Woodsville. There are none in Warren. There's pharmacies in Littleton and none in Whitefield. So which one do I pick? It feels a little bit like Sophie's choice for the patient access side. When it comes to the savings, we take that as equally seriously about, may I continue?
Yes,
Oh,
go
thank
ahead.
you. It's
You're the last one, so
It's
you
fine.
get to.
So we reinvest those, we use a ProAct card is what we use for our sliding fee scale eligible patients so that they can go to a pharmacy. It's very respectful. Nobody knows what it is and they get their medications in an affordable manner. We reinvest it in vouchers for eligible patients for dentistry, $1,500 a voucher. I'm sure you realize $1,500 doesn't go far with dentistry. Then we invested in our patient navigators and our community health workers. These work with our patients on those determinants of health. They need transportation to Dartmouth. They're struggling finding food security. They don't understand the marketplace to try to find health insurance. So those are the places that we reinvest those dollars. So I look at it, when I drive home today, I'm going to stop and get gasoline, and Subaru lets me buy gasoline from everybody. It doesn't restrict me to Irving. So from a free trade perspective, please hold me accountable for fraud and abuse. I take program integrity seriously. And please do not restrict my ability to do my business with the contract pharmacy that I think is most appropriate for our patients. So I'll rest my testimony at that, and any questions, I'll do my best to answer them.
So
Thank you.
about 10 years ago, I stopped down to 25 Mount Eustis Road and had a long talk with the proprietor of that establishment. And he explained to me how the 340B was working locally. And, it was very spelled out. It seemed to be very, very easy, very functional approach. What we've heard today is the program has changed dramatically over the last 10 years and, maybe grown into something that may or may not be the intention. I don't know. I know how it works locally. I know how the system works in Littleton. I know how it works in Berlin. But what I'm hearing is, it may not we may be dealing with some unintended consequences here, or at least some scale issues that maybe we didn't have 10 years ago.
I would agree on a couple perspectives. I think that an area of agreement would be the pharmacy benefit managers, as an example. Due to PBM's adverse contracting, I had to shutter our pharmacy to the point of I got the wink, wink, nod, nod special pharmacy contract because I was 340B. And some of those savings went to the PBM, and where it goes after that is up to the PBM where it went. So that forced us out of business. And I actually worked possibly with you and the pharmacy board to ensure that when we closed our pharmacy and LRH opened their Meds to Beds program that I helped co-design, nobody lost a job. So we have Genoa Pharmacy in there now as a third party. It's not mine, doesn't have to be mine, provides access to patients. So the PBMs, I think, perhaps are a non-value added, inserted themselves. It's something we will probably agree on. When it comes to the growth of the program, I would look at, from a program integrity perspective, compliance, that the monies are going to go where they should be going. I think we all, as covered entities, should be able to articulate that in an accounting way. We go through an OMBA 133 audit, so we take the accounting very seriously. We're a low-risk auditee. We've never had an issue. You should ask me, where did I spend the money? And I should be able to show you this is where the money went. Having been a compliance officer, there are bad actors. It's one of the reasons I wear a black suit, because I was the one who we had that conversation behind closed doors about that. Those people do need to be held accountable, and I'm fully supportive of that. And how we identify bad actors is an interesting question. How we hold them accountable, I think, is important. How that gets funded as far as that accountability, because OPA is underfunded. I've floated that there would be a blind trust of stakeholders who would put money in to cover those audits. Blind trusts are important for, good transparency purposes. But there's a few people. So if I don't understand how my contract pharmacies 1, 3, 4, 5, having them or not having them demonstrates that I'm a bad actor or a good actor. Allow me to contract with who I want to. Please hold me accountable. I have no intention to divert. I have no intention to duplicate discount. I do take exception being dragged in categorically, preemptively, as if I'm a bad actor. I take umbrage with.
Yeah.
So please come and audit me, check my books, ask me where I'm spending the money. Absolutely. Totally agree. No problems whatsoever. I'll always come to the table and co-design that.
I know you will. Questions?
One question, and it'll be my last. And thank you for stepping up.
Thanks.
In previous testimony, they were talking about how that there are about 5 or 6 other states that have actually adopted this. But in order for them to go through with this, they had most, was the key word of them, won in court. Does this bring us to court and the feds get involved and their nose gets bent out of shape if we adopt this type of a policy?
Could you ask the last piece of it? I missed the feds piece. I'm sorry, Senator.
So if we pass this, are we
Yep.
going to be engaged in a court process with the federal government? Because their nose is getting bent out of shape. Because in previous testimony, they said 5 other states or 6 other states got involved and they won in court, at least most of them did. So that brings in the question, are we going to end up in court?
And I think when I look at the court, I could never promise you wouldn't end up in court. That would be disingenuous of me. I would be surprised if you were in court facing the federal government. I wouldn't be surprised that you might be in court facing the pharmaceutical industry. I think for me, it's an issue of free trade. So I'm going to agree with the pharmaceutical industry. There has to be honest brokers. There have to be structures of accountability. Got it. Totally agree with that. I don't see how restricting the trade to contract pharmacies addresses the fraud issue. That's the disconnect for me. And I sense is as a covered entity, as an FQHC, they know, like from the original legislation that perhaps is expanded. I feel like I've been pulled into I accidentally backed into an alley and turned around and found myself in a dogfight. I'm like, this isn't my dogfight. How did I get here? So I think for me, it really comes down to free trade. Hold me accountable and let me work. How I pick my contract pharmacies is based on a migratory biologist watching where the patients flow. There are places we will not contract with. It doesn't make sense. It doesn't make good business sense. There's too few patients. You will also find that we will have some pharmacies that are not in our area. And a fair question is, Ed, I don't understand. Why do you have a pharmacy in Florida? That's a central fill model. A local pharmacy was not able to fill because of pharmacy, they don't have enough pharmacists. They central fill, they drop ship. Because I asked the question, like, why are we contracting with a pharmacy, pick your commercial pharmacy in Florida? Because they're using a central fill model. But I would agree that there's too many hands. And the money's going not to the patient because of PBMs and other people who said, oh, wait a second, I got an opportunity here. It'd probably be one of the areas I'd sit with Pharma and go, I will sit on your side of the table and we will go after the PBMs any day.
Right.
They're bad actors.
Yeah, great, thank you. Any other questions? Thank you very much.
Thank you for letting me infringe on your lunch.
I did have something, one more thing. I had a question for Morgan Holler, and I wrote a note and somebody whispered in my ear, and I didn't finish the note because somebody was saying, you gotta make sure you end on time for lunch. So I do have a question for you, Morgan, if you could come back.
Yes, of course.
You said something about 6 to 8 times on 340B, and then I lost the note.
One sec.
I think it was a markup.
It was. Let me find it. Oh, hospitals in New Hampshire make 6.8 times as much from 340B as they spend on charity care. That was the stat. And if I can have a minute just to clarify something that keeps being said, ongoing litigation has been ongoing. There's only been one case that has gone all the way. In fact, in West Virginia, they actually enjoined the law from going into effect. So, there is active litigation still going on around the country on this issue. And there's only one state that actually has gone through the whole process and gone to the Supreme Court.
Sure. I'm gonna go back to what I originally said, because that's what I called you for.
Sorry, Senator.
So we've heard from 2 entities, I mean, just to be general, that are participating in this, hospitals and federally qualified community health centers. The statistic you presented where hospitals make 6 to 8 times on 340B than they spend on charity care. Would you contend that that is probably not true for federally qualified community health centers given their mission?
I can't speak to that just because I don't have that data in front of me, but our data is specific to the hospitals. I think, we can all agree that the work that the FQHCs and the clinics are doing is invaluable work. And just like he said, there are just some bad actors that are covered entities that are just taking advantage of the program.
Yeah, okay. Thank you very much.
Of course.
If anyone else would like to speak on Senate Bill 253 before I close the hearing? Closing the hearing on 253. And we are going to be in recess. How long do we need for lunch? What's that?
15 minutes to wrap.
Okay. If we get back here at 1, I have to introduce something at 1:20 in education. Unless Grant can do it for me.
How long are you gonna?
All right.
How
What's
long are
that?
you gonna break for?
I don't know, 30 minutes.
Oh,
Yeah.
I just need to.
Yeah. All right. So we're going to break for 30 minutes. So, well, let's say 35 minutes. We'll be back here at 1:30. Is that enough? It's 40 minutes. Oh, I always run my clock fast. Let's come back at 1:15. 1:15. So we're going to break for lunch. We'll be back at 1:15. All right, we're gonna,
Yeah, we can't.
all right, yeah, we gotta wait. Good afternoon. Welcome back after an abbreviated lunch period. We're gonna come out of recess. If I have a motion to go into exec session,
So moved.
I have a second. All those in favor say aye.
Aye.
All right. Let's start at the beginning. Senate Bill 17. This is relative to cost sharing calculations.
Each bill.
Okay.
Thank you very much.
Oh, just in time.
Thank you, ma'am.
Is it talking machinery?
Thank you.
Sorry.
Oh, yeah. So we're in executive session.
Oh.
Yeah,
so
we've
moved.
got Senate Bill 17. You got Senate Bill 17.
So this was, we
Do you want a motion? Do you want to take a motion? I'll take a motion.
move to approve, move on to pass on Senate Bill
So you
17.
got a motion. Do I have a second?
Second.
All those in favor say aye.
Aye.
All right.
So I have amendment 20.
Pardon me?
Just to move it.
Oh, yes, you're right. We have an ought to pass. Yes, you're right. So
Somebody's
we
got
want
to
to,
introduce an amendment.
we just voted on the bill.
I moved on to pass.
So actually, we want to reconsider.
Okay.
Can we reconsider that? All right. I move reconsideration of Senate Bill 1, or Senate Bill 17.
Second.
All those in favor say aye.
Aye.
All right. Make a motion not to pass.
I did.
I know, but we voted on
Hold
it.
it for the amendment. So
Yes.
Do it again. Do it
It's been a
again.
long day.
I
And it's
move-
only 1:30.
My head's already foggy.
I know.
I move on to pass on Senate Bill 17.
And we have a second.
And I will second that.
All right. And we won't vote yet. All right.
Okay. So I'm introducing Amendment 2025-0424S.
Second.
And this is a part of Representative Huntsville from last year, and with some input from Mike Rollo. So, and it's just basically, it limits the capability to just those drugs that are, have no other coverage, like no other biologic, no other alternative, no other generic, and it's for the high impact conditions.
Yeah, it's discussion.
I'm good. I'm just reading.
If I have the amendment. Oh,
You just got it.
all right.
Just want to read. I just want to read through it one more time.
Looking at.
All right. Want to make sure it wasn't changed.
17 other things.
And
So-
Senator Ennis is aware of this bill?
Yes, I asked him about the changes
Yeah, okay.
before I made them.
Here it is.
All right.
Oh,
So-
we wanted to make sure that was.
We have a motion and a second on the amendment. Is there any further discussion before we call the vote? All those in favor on the amendment, say aye.
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 Opposed, say nay.
Move on to pass as amended.
So we've got,
Do we need a
I
second?
don't think we
Yeah,
do.
you do.
Second.
So we got Senator Avard moves on to pass as amended, second by Senator Bertzel. Any further discussion? All those in favor say aye.
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 Opposed, say nay.
Consent.
We got a motion to consent. The second,
Second.
Senator Apprentice, raise your hand first. All those in favor say aye.
Aye.
Opposed, nay. It's on consent. Senator Bertzel, do you want to take it out?
Sure.
All right. Senate Bill 36.
Let's see, I have an amendment to that. Did you have the? Yeah, we have a copy of the amendment. This is the reporting of abortion statistics, and we tried to model it towards. You have a copy?
Yes, I do.
Yeah, you do.
Yep.
So we took out some of the identifiers so that you can't trace it to one particular individual. Keeping the privacy is a very important part of it. You know, Planned Parenthood came in, you know, they said they weren't against the bill, but the department was concerned about certain privacies, and so we wanted to make sure that those were protected. That's all. You can read through it. But and instead of it being a $10,000 fine, we put it at 100 if it's willfully neglected. So if it's done willfully. So wait a second. I move out to pass on.
I was going to ask you if you, yes, we've got a motion ought to pass on Senate Bill 36. So I have a second.
Second.
I
Senator,
move amendment 0391S. Is there a second?
Second. Just trying to get myself in order.
wait a second.
0391.
I have 0470S.
Okay, that one. Oh, yeah, that's right. There was a grammatic, that's right.
All right, so there's a motion to move 0470S. Do I have a second?
Second.
You moved it.
That's right.
Second.
Second. Any further discussion on this amendment?
Just-
Senator Apprentice.
Thank you, Senator Rushford, and Senator Avard, thank you for working with, I believe, a group of, you worked with the stakeholders that came forward, and I think that we've, come leaps and bounds on the privacy here. I just wanted to ask one question about E, method used to perform an abortion. So here's, I don't know if it's a concern, but I just want to point it out. Would we potentially be sweeping, pulling into this group women that have had a miscarriage and they have to have, a procedure to, a D&C to complete it? Does that get swept into this?
I don't know, to be
Kate,
frank
do you know?
with you, honestly.
No,
I tried to model it after the Massachusetts legislative language, so.
Yeah, but I think really it's leaps and bounds. I just wanted to make sure that we weren't sweeping that in, but we might not be because
I believe the intent of some of the changes were specifically to ensure that miscarriages were not included.
thank you. That's all I need to know. Speak up.
Well, there's the microphone so people can hear us.
I can't hear you.
Oh, okay. In theory, yes, that was addressed and will not include miscarriages. But I can double check with the stakeholders and you can't hear me.
It's good.
Okay. And if there's an issue, we can address it in finance, but I believe that was addressed specifically.
Is it going to finance?
Yes, it has an FN.
Leaps and bounds, sorry.
Any further discussion?
No, it does not.
Is that? So we've got it on the amendment, we've got it on,
Line bill. We asked for, did we get the FN back yet?
Huh?
Did we get the FN back yet? Because we directed the LBA at that, sorry, I'm speaking out of order.
no,
Chairman.
go right ahead. No.
Okay, so we, at the hearing, we asked the LBA, I went and made a motion, asked the LBA to do. Okay, so it's gonna come to finance.
Gonna go to
Federal
finance, yeah.
That's right, that's the bill that was not given an FN. Supposed to have an FN, so it is going to finance. Okay.
That's what I thought, but Senator Long had a
Do we need
question. I
to
wanted
make
to make.
do we need to make a motion to send it to finance?
No, I'll get
It will go,
there.
okay, all right, very good. So amendment 0470, any further discussion? So on the amendment, all those in favor say aye.
Aye.
Opposed, say no.
I move ought to pass as amended.
Second.
Any further discussion? All those in favor say aye.
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 Opposed?
Consent.
Consent, I'll second that. All those in favor say aye.
Aye.
Aye. Opposed? Yeah, 5-0, yeah.
Yes.
Like Hawaii 5-0.
So
Welcome, Daniel.
Senator Avard, do you want to take that one out?
Sure.
All
Thank
right.
you.
So 118 we'll be hearing later, 120.
I wonder if I can find it. It's in that file.
Exactly. I can't find 149.
What? I am.
Senator Avard.
You doing 120 next?
120, yes.
Oh, Barb.
Oh, yeah.
Do we have it?
I have a motion on 120.
Aye.
Yep, oh yeah, I'm sorry, Sophie.
On which one? Oh,
Wait, it's already voted on.
yeah.
bill is this?
So I'll make a motion to,
Whenever
whenever you're ready.
Make sure she's ready.
So I'll make a motion to ought to pass.
Second.
All right, so the motion and a second on Senate Bill 120. Okay. And I sent out an amendment on February 13th, but I made it, I'd like to add a line to that. Which are a couple lines to that, a couple,
Is this 0340F?
So.
0418S is what I sent out on.
Second.
Slow down, Kat.
Yeah, slow
Well, I'm
down.
trying to get it passed. You can't talk about it unless you make a motion.
I thought we did it. Oh,
No.
you're at the amendment, correct, sorry. Oops.
So what I'd like to consider is that amendment, but this has a couple changes in it.
I
From
would
the amendment.
recommend, if, since this is changing, the amendment, I would recommend just one big committee amendment.
Yeah.
That's reflected.
Okay. Yeah, that would be great.
Okay. So Sophie's handing out the kind of like Word document, but I'm gonna work off of your amendment to make it easier. So working off of 418S, on the first page, line 10, we'll be adding this piece in red from the first page of the Word document. So after clinical decisions in, actually, at the end of line 5, sorry, apologies. It's gonna say, the most appropriate test may include both information that is actionable and some information that cannot be immediately used in the formulation of a clinical decision. And this has been reviewed by Cancer Society and also HHS, and they're happy with it. The next change is, and it's on page 2 of this Word document, the red there, that then is on the amendment, line 22. So that's where that kind of keys in. So it's when the test provides clinical utility and is demonstrated instead of supported by the following medical and scientific evidence, including but not limited to any of the following. So that's where that keys in there. Then the next change is on the third page of the Word document, which keys into the second page of the amendment on line 4. Again, changing supported to demonstrated and adding including but not limited to any of the following at the end. And then there is another change requested by the carriers that the Cancer Society is also fine with, that is not on either, but that I can explain, which is
where it says in two places in the bill, 72 hours for non-urgent requests or within 24 hours for urgent requests. They've asked it to be changed to within 14 days for non-urgent requests or within 72 hours for urgent requests in two places. And that was a request of the carriers that the Cancer Society is fine with, and that's on line 14, page 2, and line 8, page 3. And that's it.
So we need a move on the committee amendment?
Yep.
So moved.
So we've got a motion on the committee amendment. I'll second that.
Okay. That was helpful, thank you.
Any further discussion on the committee amendment? So call the vote on the committee amendment. All those in favor say aye.
Aye.
Opposed say nay.
So do we move the amendment now?
Yeah.
Yeah. Right. So the next motion would be, I move the committee. What she said.
Which would be 0418, correct?
Yes.
Okay. So we got a motion.
Senator Prentice seconded it.
Senator Prentice seconded it. So on the committee amendment 0418, any further discussion?
The committee amendment 0418 with the
Oh, yeah,
changes that I said.
Correct, yes, with the
Yeah,
changes.
which Sophie has.
Yep. Yep. Are you keeping up with this? All right. All right, very good. Any further discussion? All those in favor say aye.
Aye.
Opposed? So that's the amendment.
I move on to pass as amended.
Second.
Any further discussion? All those in favor say aye.
Aye.
Opposed? Move consent.
Second.
All those in favor say aye.
Aye.
Opposed? And Senator Birdsall has volunteered to take it out. Let's see, Senate Bill 123. This is ear acupuncture as a treatment for substance misuse under the state Medicaid plan. Do I have a motion?
I was gonna make a motion not to pass.
A motion ought to pass by Senator Prentice. Do I have a second?
Second for discussion purposes.
All right, we've got Senator Birdsall seconded.
I wasn't here when I heard this.
All right, so for discussion purposes,
We ask Henry to come up.
yeah, Henry, would you mind stepping up and?
It's like his partner in crime.
All right.
Sidekick. Hey, Rob.
For the record, Henry Lipman, State Medicaid Director.
Oh, Rob Berry, General Counsel of the Division Medicaid.
So I've talked to a couple of the carriers and they believe that they cover this. What would be the cost, do we think, to Medicaid?
Let me pull that up. I sent you guys an email on it last week, but
My recollection's correct, it's about 2.4 million total funds.
I will. Well, we did some more changes.
We did an update.
Yeah.
3 million.
All right. So how I figured it out is given that it would start in January of 26, the first year, so half that fiscal year, I figured 1.2 million in general funds. And then for the second fiscal year, FY27, I had 2.4 in general funds. And then about a half match for the federal portion.
1.2 and 1.4?
Correct.
No.
1.2 and 2.4.
Oh, I'm sorry. I misunderstood you.
Right, 3 million.
I know, why does it go up the second year so high?
Is that the full year?
6 months versus 12
got
months.
it. Okay.
Okay, well, yeah. Wow.
Did you say it was a half a match?
About, yeah.
Is this the number you're giving us with the match?
So that number reflects half, assuming a half federal match.
Okay, great.
So it does include the match.
That number does not, that's just a general fund number I gave you.
That's
So,
what New Hampshire would have to.
so double it to get the full cost of the program for each year.
So for the purposes of discussion.
Yeah.
Happy to.
Senator?
Thank you, Chair Rochford. So, policy, finance, right? And I feel as a policy that every opportunity we can bring to those who are suffering from substance use disorder to try to, to help them with their recovery, which we heard numerous testimonies. We've got some articles on this. I think that there is merit to this tool being made available. How and if it gets funded, I think becomes a discussion for finance. There might be at a certain point some, taste for, holding things and not sending them to finance because poor finance is getting overloaded with all these. But I just don't want to overlook that I think that this is good, that I think that this is a tool that we could deploy for a population that is in need. And it's, it's been a stated, shared, basically goal of all of ours to try to, work on the substance use disorder problem in New Hampshire. So that's all I'm going to say.
Mr. Chairman.
Senator?
Was there an issue with the stated RSA 167? I have a question mark next to that. I don't know if somebody,
167?
yeah, RSA 167, was there an issue with that? Or is this the correct,
I don't remember an issue being there with the RSA.
Okay.
Oh, I think there was a question about whether there was enough direction within the statute to give the department enough authority to. I think that might be why you have the question, but that's pure speculation.
okay.
So where are we?
So we've got a motion and a second. Any further discussion? Call the vote. All those in favor say aye.
Aye.
Opposed? A motion for consent?
Sure. So moved.
Second.
Senator Birdsell will second that. All those in favor say aye.
Aye.
Opposed?
Ought to pass. It'll go to finance.
And Apprentice made the first motion.
Yep.
So you want to take it out?
Yeah, Senator Prentice, would you take that out?
Yes, I would. I will.
Okay, I'm gonna skip ahead to Senate Bill 246.
$246.
246, we heard that this morning. First bill this morning.
Oh,
Yes.
I'll move on to.
So I've got a motion ought to pass.
So.
Oh, you ready? 246? I'm sorry. All right, I've got a motion 246 ought to pass by Senator Birdsell, seconded by Senator Avard. We have an amendment in front of us, 0478S.
Second.
So, all right, I move that and Senator Prentice seconded that. Any further discussion? Let's call the vote on the amendment. All those in favor say aye.
Aye.
Opposed? So the the motion now is,
Move on to pass as amended.
ought to pass as amended.
Second.
Senator Prentice seconds that. Any further discussion? All those in favor say aye.
Aye.
Opposed?
Consent.
Motion to consent. I'll second that.
Second? Nope.
Oh, I beat you to it.
Yep.
Oh, sweet.
The vote on consent, all those in favor say aye.
Aye.
Opposed? No. I mean, no, there's no opposition. No. So,
Senator Prentice is on the main.
yes, Senator Prentice, will you take that out, please?
Yes.
All right. Yes, amendment was 0478S. Yep. All right. So Senate Bill 132, that's the prosthetics. There is an amendment coming to that. So I'm gonna, you do have that? Could you, let's. So I would take a motion on Senate Bill 132 if we're ready for that. Senator Apprentice?
Yeah, I'll make a motion for 132 ought to pass. Do we want to, yeah, do we have a copy of the?
Second.
So I have a motion, ought to pass by Senator Apprentice, a second by Senator Avard. All right. And we've got an amendment that has come out. I'm just going to give you all time to look that over.
All right, and I'd be happy to talk.
Yeah.
So I'm going to move, Chair, Amendment 2025-0481S.
Okay.
Second.
And we got a second by Senator Avard.
Okay, and if I may, I'll speak to this.
Yeah.
So this, actually for Senator, no offense to Senators Rochford and Long, but for Senator Birdsall and Avery, this may look somewhat familiar. Because when we did the prosthetics, activity-specific prosthetics for children, okay, there was an insurance mandate review. It came forward, we worked with got that from the Department of Insurance, came forward, we worked with the insurers and the stakeholders from the Amputee Coalition and agreed on basically what's, almost mirror language in here. So it says each insurer, they will cover one activity-specific prosthetic every 5 years if you're over the age of 19. So this is specific to the 19-year-old group, and that medically necessary prosthetic devices shall not be subject to any annual limits. And it complies with all other terms and conditions of the policy. So basically what it's doing is limiting, you can't have multiple activity-specific prosthetics. You pick your lane, like if you're gonna ski, that's like one of the most popular ones, or you're gonna run. And if you need an update in 5 years, it's available to you in 5 years, and there's always the medical necessity piece. So that's what it is, and I urge my colleagues to support this on behalf of those who've been affected by limb loss. I think it's important.
Any further discussion?
So the child is through 19 years old?
I did it up, Senator Rochford?
Yes.
So, yes, it's up to 19 years, and we together, so that if they were just about their 18th birthday when they were filing to get this covered, they couldn't say, well, now you're 19 years old.
Yeah.
So it brought an extra year into it so that there was no question. So that's why it's 19.
Yep.
Any further discussion? So I'm going to call the vote on amendment 0481S. All those in favor say aye.
Aye.
Opposed?
I move ought to pass as amended.
Second.
So ought to pass as amendment. Senator Avard, second from Senator Birdsall. Any further discussion? All those in favor say aye.
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 Opposed?
Consent?
Second that. All those in favor say aye.
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 Senator Apprentice, would you take this out? This seems to be your, yeah.
Yes, I would be happy to. Thank you.
Okay. Oops. Senate Bill 136. Do I have a motion?
Motion ITL.
Hold on.
A motion ITL, do I have a second? no second.
Well,
Well, I'll second it for discussion purposes. How does that sound? All right, so we got a motion ITL on the table for discussion. Any discussion on Senate Bill 136?
Was there supposed to be an amendment?
Is it? Just a committee to change mental, just to add mental. Okay.
Yeah, when it was introduced, she said that there was just a mistake. Then there's supposed to be the word mental in front of where it says healthcare providers. I believe it's in 2 or 3 places in the amendment. So if you were to pass the bill, you would just need that small change.
Got it. And that would make a major change to the fiscal note.
Yeah, the fiscal note attached to the bill is for all healthcare providers, and it was just supposed to be mental health care providers. So it significantly reduced the cost.
Sorry, Chairman, it reduces the cost? Okay, thank you. So by focusing on that one, okay.
But we don't know exactly
It's
by
in
how
the
much.
So it would be finance that would,
Well,
Can we hold it and get the fiscal note?
we could. Would they have it?
I can withdraw my motion if that helps.
We can, do you want to sit on this for 2 weeks?
yeah, I'd
All
prefer
right,
to.
I'm going to withdraw the motion. I'll withdraw the second. So we will hold on this for 2 weeks. Senate Bill 244. Do we have an amendment? Has that come back yet? Kate, from,
What is 244?
that was the, really
A what?
focused on the rural healthcare. And it was a Medicaid reimbursement increase.
That was 34 million.
I don't have it in my,
And then for the
I don't
first year,
either.
34 million for the second.
Yeah, well, I've done some work on this with Senator Rosenwald and have an amendment for it. And it
Oh,
would
okay.
dramatically change the cost. Her and I discussed it. Tell me if I'm speaking out of school. But her and I talked about, what her priorities were in the bill. And we were able to bring that down from about a $60 million price tag to about, what was it, $4 million price tag.
Wow.
And you have the amendment?
The amendment is being drafted by OLS, but it's very simple, so you could do it as a committee amendment if you want, because I have the sections. It's just striking
Or is it
a bunch of sections.
I'd rather wait and get the amendment and
Yeah.
read it. I don't know.
Really? Okay.
I would rather see the amendment in my.
Okay.
Yeah, because I mean, you say it's simple. I was. It's a big bill, and I'd rather see it.
Yeah, it's
So-
fine, because once it goes, you have that week, so I think it makes sense. It's complicated. If anyone has questions, you can obviously,
Yep, and if we
Has
could
to
get
be
it
once
next
the
week,
amendment
we could
comes out.
circulate it amongst the committee.
as soon as I get it, I will send it to the
That would be
committee.
The
good.
price tag was just a little bit higher.
Yeah, so we were able to get it.
And then 3% on top.
Yeah.
Every year.
Well, we've got it. I think I've got it. We've got it. Pretty nice. Yeah, I was.
For today, so it wasn't good.
Okay. 245, Senator Apprentice, you said that's coming.
Yeah, I've asked, I'm preparing an amendment to connect the clean claims section with the appropriate statute in New Hampshire. And I'm removing the $100 copay limit for now. And I think the language is clear on prohibits balance billing, but I'm putting an extra few words in. So
Sure.
I'll be back for next time we meet. We'll be ready to go. Thank you.
And we, just for my notes, we held off on the ear acupuncture, correct? 123? Or did we
Yes.
pass that?
Pass that.
We passed it.
We passed it. Okay, all right.
Remember anymore.
I just want to make sure I made a note of that. And then,
But I'm gonna need that.
let's see. Oh, I missed this one. 127, Office
Bingo.
of Public Guardian.
Bingo.
Bingo?
I move on to pass. As is.
So Senator Abard has moved ought to pass on Senate Bill 127. That's the appropriation to the Office of Public Guardian. Do I have a second?
I thought there was going to be an amendment, no?
I think we've got a committee amendment here.
Oh, okay.
So I'll second it so we can get into the amendment.
All right. So this is we got an auto pass. We got Senator Abard motion, Senator Apprentice second. The motion is ought to pass.
I don't support the committee amendment.
Okay, you don't support the committee. Do we want to vote on the committee amendment and then discuss it, or should we discuss it? Okay. So what I am going to propose with the committee amendment is that we keep the appropriation. I think that the program is valuable. I think we heard testimony to the value of the program. HHS came in and said they prioritized the need in the budget. That was not met in the budget. But what this bill would do, what the amendment would do, is would keep the appropriation at the prioritized need, but it would cut everything ahead of that. So it's going to cut sections 1, 2, and 3. And the reason why I did this is because there were some concerns brought up in the hearing that opened up the role of the opened up the Adult Protective Services statute beyond the scope of what a public guardian is. Now, Senator, we heard testimony from you, and I think it was good testimony where people need help. They need help. They need help getting to doctor's appointments, going grocery shopping, taking care of personal needs. In talking with folks around this issue, I think that the verbiage in this bill would go far beyond that. And I'm afraid that we'd be opening a can of worms if we did that. So that's why I propose this amendment as is. So we keep the money there. We recognize the need. That will give them the money for the extra slots, but it doesn't expand the scope of the guardianship. So that's the amendment
I'll move.
that I would be proposing as a committee amendment.
I'll move the committee amendment.
So, got a motion, are you seconding
I
that?
want to talk about the committee amendment.
Okay.
Do we want
You want to move, so we've got a motion to move it, you want to second it and
to?
talk about it?
I'll second for the purposes of discussion.
Right.
So here's what, Senator Rochefort, I want to thank you for your work on this, because that conflict, I think it was Brian Clark, I think you brought it up during the testimony about the Adult Protective Services. I think it was important to resolve that. So one of the big reasons, that we're have been working on this is an initiative to get basically patients out of hospitals that are in them because they don't have services and they have nowhere to go. So that is why I have been largely supporting this. By putting this amendment through, it creates the extra slots that we were looking for. But the question is, does that resolve the issue at the hospitals?
It doesn't.
It doesn't, okay.
No, and then you have people that are stuck in limbo at the hospitals, and then they're not being compensated for it, and so we can't get them out. This basically extends that ability for the public guardian to help these people out. She's got her hand up.
Oh, sorry, no.
No, go ahead.
Get out. So I don't understand why it doesn't help. I don't know if we have a minute to ask somebody from one of the hospitals that's been involved in preparing this. I appreciate the work, Senator Rochefort. I want to make this happen, but I want to make sure that we're getting those folks out. And as I understood it, preserve the appropriation, and then they can do the policy work and create those extra slots. But how come it doesn't get the people out of the hospital? That's all I want to know.
And frankly, if I may, when the department came in, they basically T-boned this bill because the people they were working with, they never brought any of the stuff. It was very much at the last minute. And they basically T-boned this bill with their comments. And to this, nobody reached out to me. And I think what we're trying to do is alleviate some of the pressures that are on the hospitals, make sure that the people that are by themselves have care. And this bill may augment their responsibilities, but it is helping those people that are trapped. That's the whole idea behind this. And if we go with this, well, you get the appropriation and maybe it passes the Senate Finance. And if not, then the policy dies as well as the finance part of it. So my concern is that this basically T-bones this bill. I didn't even know anything about this. So
who helped you write it? Do you want to have them come up to DHHS?
Yeah, we had discussed it. Kate and I had discussed it. Or DHHS was there when we discussed this. It was a general discussion about a number of bills.
I personally think that this amendment basically guts the bill. Yeah, maybe provide money, but it doesn't solve the fact that people get trapped in, and you heard the hospitals come in and testify on behalf of this, and that it frees up beds. It frees up beds and it gives the public guardians the ability to help out with that. Keep in mind, there is a bad actor that I've not forgotten about. I know I've gotten a lot of emails on that, and I'm going to continue to look into that. But I think this amendment screws up this bill royally.
I mean, the concern that I had was the gentleman that, I think it was Mr. Clark, I believe. I mean, I just don't want an unintended consequence of opening up I get what you're trying to do, and that's where I thought that we could get there by getting the slots without having, and I 100% see people need help, 100%. I mean, these basic things.
I don't know who that person is, and I didn't understand the thing that he was trying to get across. And I frankly thought he was just T-boning the bill. And personally, I'm surprised he didn't come to me. Should have. He didn't. They didn't. They didn't reach out. There was no concern. It was a last-minute thing, and not sure what their agenda is, but I think this bill basically helps the public guardians get their job done and help free up the people that need it the most. I really appreciate the work on the amendment. Wish I knew about it, but I don't. And I think it guts my bill, and I'd just like to pass it as it is. And then we can rehash all this in the House if necessary.
I'll do. I mean, I will withdraw the motion for the amendment. But I'd like to have. You said you didn't speak to him. He didn't speak to you. Could you guys get together in 2 weeks and figure that out?
I'd rather not. I'd rather pass the bill.
That's not fair.
It's not fair to me what they did.
I
It's not
think you
fair
should
to-
at least have a conversation.
It's not fair to the people that are stuck in limbo in the hospitals. It's not fair to them. There are people that are stuck.
Well, I think you need to at least consider talking to them so that we can get to a yes.
Senator Apprentice.
Thank you, Chair Rochford, and everyone for your input on this. And Senator Avard, I hear you, and you've been one of the people who has, as a senior senator to me, and especially on HHS, over the last couple of years being here, has helped me to get to go by, collaborating and further stakeholder conversations. Like that's been a really important way that we've done our business, and you've been one of the people that's helped me with this, especially when I was I'm still new, but I'm new on this committee. So I hear you and your frustration, and this will be the third year, even though this isn't my bill, but I have collaborated with stakeholder groups, and Senator Carson and I worked on a bill. Like, we tried different ways to do this. So I'm right next to you. But I don't think there's I know it's frustrating, but in the spirit of the way that, you've modeled your behavior and we've all learned from each other, let's have one more conversation, get the folks that you're concerned didn't come to you, and let's make sure we get this done the right way. In the end, I want to do what you want to do, but let's just think, you're surprised over the amendment and where we're going. I think we can stop that, withdraw it, have a conversation, see if we can get, and that's what I want to suggest to you. And I thank you for everything.
I'm easy.
Yeah, I'll withdraw the amendment. I mean, everything you have said, I agree with, but I don't want to open up can of worms where now we've got people that have authority over people in hospitals that otherwise wouldn't. for and have more authority than just simply helping them get out of the hospital.
I do believe the public guardians take care of them after. That's okay.
All right, well, I would, can we sit on this for 2 weeks?
Absolutely.
All right, so I'll withdraw my motion and we'll sit on this for 2 weeks.
But during those 2 weeks, let's, I mean, I'd be happy to work with you, Senator Raybard, to continue the discussion with anybody you want to bring to the table. Let's get this over the finish line. I'm there.
So are you around the next 2 weeks?
I should be.
All right.
Yep.
Let's maybe bring in some of those folks and hammer this out.
Okay.
All right.
Great.
Let's see. That one was done. Senate Bill 255. 240.
What? 249.
Would you say 255?
I don't have
249.
Yeah.
Yeah, that's today. So I have.
Oh, yeah, that's mine. No, I don't have it. Oh, got it.
255, establishing and developing crisis stabilization services.
Are we ready to go on this, or do we need? Oh, big amendment. Okay. I mean, I want to go. Senator Rushford, did you draft the amendment?
Yes, I worked with Kate to draft the amendment.
So if we, yes, motion, we can
Yep.
talk about this.
I move on to pass on the bill, 255.
Do I have a second? We have a second. Senator Birdsell seconded it. So this is the 988 suicide hotline, which is ending this summer, as I recall, or ending soon. Initially, this is funded, as I believe, from ARPA funds, which are coming to an end. There was a section here that set up the 988 license plate. And the committee amendment that I would propose is just eliminating that part of this bill.
It wasn't workable from what I understand as
Right.
well.
Yep, but it would keep the rest of the bill essentially as is.
Yeah, I had my commission to study PTSD on Friday, and they were adamant that they wanted to keep the 988 because they put a lot of, they've used it a lot. And if you look at the number of veterans that have used it, it's really a promotion that we need to continue.
And actually, we got some information on that. I don't know if you all have received it. In New Hampshire, the 988 line has assisted individuals over 46,000 times. And of that 46,000, 3,200 plus have been veterans. So it's a valuable system, and I would propose to keep it as is, removing the license plate section and just keeping everything the same. Yes.
Yep. So the committee amendment that you had me draft, it removes the license plate piece, but then it also includes the language that we were sent from DHHS that was an agreement between HHS, Department of Safety, New Futures, and NAMI. So that extra part, the striking piece, that's the license plate. The rest of it are like technical changes. That was an agreement between all those people, and Jenny from HHS is here if you have any questions on that part of it.
All right.
Are you talking about the top portion?
The bottom portion.
The top
bottom.
portion is the license plate part, the part that says
Okay.
strike, that's just taking out the license plate pieces. And the rest of it is replacing a couple of sections with like technical changes that was worked on by HHS, Department of Safety, New Futures, and NAMI that we were sent that you added in.
Yep.
And they're here if you have any questions.
Good.
So I would move the amendment, the committee amendment.
A second.
And a second, any further discussion? All those in favor say aye.
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 Opposed? So we've got the amendment, committee amendment adopted. I move ought to pass as amended.
Second.
All those in favor say aye.
Aye.
Opposed?
Consent.
Senator Bertzel moves
Second.
consent. Senator Abar seconds. All those in favor say aye.
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 Opposed? Sorry, Abar, that's your bill. You want to take it out?
Sure.
All right.
It's gonna go to finance.
Yep.
I am not.
Senate Bill 256. That's the white bagging and brown bagging bill. I have a potential committee amendment. I don't know, we can discuss this some, but I can speak to that amendment. Do I have a motion on 256? Did a motion ought to pass at a second? I'll second that for, okay.
This is in your bag. I'm not,
Just the Rochefort.
That's it.
yeah.
That's it.
I think we're moving from taking out white bagging and moving only to brown bagging.
Yes.
He's walking. Oh.
This isn't, I don't think this is what I was looking for.
Okay.
Hmm.
But I can actually summarize it easier, I think, than I can. Yeah, well, so I think, so essentially what I'd like to take out is lines 18 through 32 on page 1
On the amendment or?
on the bill. I mean, yes, the amendment, amendment 0361. So we need to adopt that amendment. We voted on the bill. We need to vote to adopt the,
So you got two amendments here, right?
yeah, this is the one I want to speak to,
The McGowan.
McGowan. We just took a vote on the bill itself.
Yeah, in order, so
Yeah.
you have to move.
So now we have to
amendment
move the amendment. Okay, all right. 0361.
Can you hold it? I think I'll get this right. There's still concerns.
Okay, let's just discuss it. Can we discuss it? Just for the sake of discussion, if you have 0361 in front of you, I think that we heard in testimony and there's two practices that are going on right now in the state of New Hampshire. One is brown bagging and one is white bagging. Brown bagging is where an insurance company ships a drug to a patient, and the patient then brings it to the hospital or the infusion center to be infused. So that's brown bagging. White bagging is where the pharmacy, usually an insurance-owned pharmacy or insurance contracted pharmacy, ships the drug to the hospital, and the hospital has to take possession of it and hang on to it, and it's still administered in the hospital setting.
They eat the cost if it's not used.
Correct. So the brown bagging, of course, has a big safety issue, in my opinion, and is clearly problematic. The problem the problem that I have with 0361 is it codifies the practice of white bagging. So it essentially gives a seal of approval to white bagging, even though it's, it gives criteria to that. I don't know if we're at that point yet. The testimony that we heard was really in opposition to both practices, I think. There was opposition to that. There's testimony, though, for white bagging that I think can support the practice. I mean, you save money in doing that. So there's the white, I think, for me, the brown bagging issue is an easy issue to say we need to prohibit that because there's safety issues. There's who knows how the drugs are going to be stored. The white bagging issue, I think both sides have valid points to it, and I think that needs more discussion and needs more work on how to do that functionally. I don't think we should give the seal of approval on that practice until we address all of the concerns that are going along with that. And I think there are a number of concerns that have not been addressed with that.
On the white bagging part of it, though, is there a way that the hospitals can be compensated for storage and possibly destruction of the material if somebody wouldn't show up, or if it's the wrong dosage?
And I think those are some of the questions I think that need to be answered. So I think the amendment that I was going, oh, sorry.
So finish.
So the amendment that I think where I was going to go at this point is take the baby step of prohibiting brown bagging and continue to work on white bagging and come back next year and or re-refer it and work on it in the fall, because I think both sides bring valid points. I mean, it's the cost difference between the drugs are remarkable, but at the same time, the hospitals are essentially being asked or told to do somebody else's work for them without getting reimbursed.
So, if I may, I think that, just my opinion, I'm completely with you on the brown bagging side. Perspective. I think the white bagging, as you said, so not to belabor the point, there's still work to be done.
Yeah.
And one of the lessons I've learned is re-refer as a tool, not to do this, but to keep doing this.
Yep.
And so if you're committed to doing that, I mean, that's up.
And that was an option. Yeah.
Then I'd be happy to make a motion to refer. And I want to appreciate the work that Senator McGue has done on this, because I think he's brought forward a really valid safety discussion, and being able to work on this is important. But I think we need to do work on the white bagging side.
Yeah, I agree. Because both sides have points, and they're real points.
Yep. That was going to be my next thought, was re-refer so we can do some more work on it. But she already made the motion, so I'll second it.
All right. So do we need to withdraw?
Yes.
We didn't have a motion on the table on the floor, did we?
Yeah, we moved on.
We're so good.
All right. All right. You were getting ready, right? You were getting ready for it. All right. So I've got a motion to re-refer by Senator Apprentice, a second by Senator Abard. All those in favor say aye.
Aye.
Aye. Opposed? Just re-referred.
And we can thank Senator McGue for bringing this to our attention.
Yes.
I think it's good work. Who's going to take it out?
An apprentice.
I'll take it out.
I mean, I can take it out.
Oh,
I mean, I'll take it out. I don't know.
Consent.
We got a motion for consent.
Second.
Senator Bertzel seconds. All those in favor say aye.
Aye. Who's taking it out?
I'm taking it out.
Okay.
All right. Did we miss anything?
Well, we have a couple more of mine, but I don't know. I want to go.
Which ones?
I want to pass them as is, so.
Which ones?
Well,
Which one you got?
just name it.
I don't know which one, I don't know which ones.
Well,
I don't know numbers.
I like 125, I like 135, and I like 127. Those are really good ones. But
Guys, remember, we still have two other bills.
Oh, yeah, to hear.
I think significant progress.
Carolyn made changes yesterday, and they're coming with some
I just want to let everything fire on this side. I know. Okay. All right. I'll listen.
Well, it may come.
Okay.
All right. All right.
You want to do 128?
128, relatives to children mental health services for persons 18 years of age and
I
younger.
move ought to pass.
We got a motion ought to pass. Do I have a second? You have a second. Discussion.
My bill.
Your
I, actually, we'll have a conversation tomorrow morning, so maybe I shouldn't.
You want to wait on it?
Yeah, let's wait on it.
So,
Withdraw my motion.
You know, huh? Oh, that's true. It is going to finance.
Put my motion back.
I'll second. So I do know that the governor has put this into her budget. And my hope is to at least get it to finance, and we'll see what finance has to do with it. And I will have the conversation tomorrow.
all right. So the motion ought to pass on Senate Bill 128. Is there any further discussion? One of the things that did come up in the hearing, and I know I discussed it with you, Senator, is that a lot of these services are supposedly covered already under private insurance. And why they're not being billed, I don't know, but I will trust that you'll ferret that out in finance.
Will.
All right, any further discussion? All those in favor say aye.
Aye.
Opposed?
Consent.
Senator Abart moves consent. I'll second that. All those in favor say aye.
Aye.
Opposed? No. Senator Bertzel, you want to take that out?
Yeah. Okay.
All right.
Are we ready to move out of executive session?
Yeah.
I think
I know.
we're ready.
We're pushing.
Do we have anything else that, 45? That was it. Okay, very good.
No,
All right.
there's a couple. The 124 continuing care, which we heard today, child care scholarship.
Oh, you want to move on those?
No.
No?
I'm just
All right.
saying.
All right.
How about the 30B? How about the 340B bill?
You can do that. What's,
What number is that? I move ITL.
So 253.
I'll second.
We got a motion ITL. We have a second. Any further discussion? I would make a comment. I think that the federally qualified community health centers are probably not the ones drawing the scrutiny that we heard today. We heard a lot of testimony, a lot of numbers were floated around. I think the federally qualified health centers are they're doing things right, and the money that they're supposed to be getting on this is going to where it's going where it's supposed to go. I have a lot of reservation about putting the state in between a federal contract with the feds and Pharma. We heard that most often when these things happen, it's happened in 12 states, and if I heard the numbers right, 8 of them have been litigated and lost, and only one has made it through. I don't think it's good policy to willingly and knowingly go into a situation where we're going to be sued. And especially, there's some issues about transparency that were brought up.
And I know that that in testimony was brought up, Senator, about uncompensated care, that some of the money is going towards that. That was their own testimony, and I don't think that's right. And the temptation for it to use that is, if you're in a tight squeeze, So I don't know. I think, and another thing that really troubled me is the fact that, yes, there were some courts that are still being litigated, and we'll get enthralled with more litigation if we put our hands in this. And Senator Bradley said, that's something that we don't want to get involved with. And I think we followed that on one previous bill. I think we should continue on that vein, that we don't engage ourselves in a battle that's we know is going to end up in court.
Yeah.
So that's why I'm ITLing it right now.
And I would go one step further and also saying, I would be happy to pen a letter for a federal delegation to draw the attention to the fact that that needs to be addressed, and they need to fix that. So, Senator.
Chair Rochford and my colleagues. So here's a place where I can't support the ITL, and I'll tell you why. And so I actually worked on this in another form last year. But one of I heard over and over again today the way that New Hampshire, programs that are participating in New Hampshire, use the savings and apply it in their communities and to underserved populations, which is important to me. And a number of them, they're in my district, but I think they're in all of our districts. And federally qualified health centers, super important point, but we also have 16 hospitals, and I believe, if I'm remembering, all or close to all of them are critical access hospitals, which are in the more rural areas that are under that program, because critical access is the only way they can keep their doors open, and they take advantage of this for their patients. So I wish there was a different outcome on this. So I'm going to vote against the ITL, but I wanted to explain why. It's in support of the critical access hospitals, the underserved populations, and having worked on a different version of this last year, like that's at the floor, I'm comfortable with what they do. I understand the concern about litigation. I think that at times hasn't stopped us before, but I will respect everyone's position on it.
I appreciate that, and I just think if they're using it right now, and nothing's going to change on that part. I know that money's not coming in the way it should in certain areas, but I think we could really find ourselves in a quagmire if we go forward with this. If the other states are still fighting it, we don't need another lawsuit on our hands. I know that it's working as is, probably not at its optimum. Maybe there's another way we can do it, but I don't want to interfere with getting in a fight with the feds. I just don't.
No, that's okay. Can I say one more thing?
Yes, absolutely.
I know this is a productive but long day. The only other thing that was brought up, and I think it was you, Senator, who talked about, the concerns about transparency and where, we got a series of impact statements. I think if we look at this going forward in some way, and I know the hospitals, I worked in a not-for-profit hospital here in New Hampshire, and we had our community health benefits report that we, put out routine. I think it's yearly you have to do it. So I think that we should take a step or encourage that type of reporting is very clearly distinguished there for all of us and for the public. And I think that might tamp this down a little bit as we go forward. Thank you.
Yeah.
And speaking of, I can appreciate what you say about the critical access hospitals, and I really, my community is affected by this and benefits from this program. But I think that the program, as I illustrated in some of my questioning with the last speaker, this is not the program that, in my opinion, it was designed for. What's kind of morphed into, and I think that they, PBMs have have had a cause of this. I think that there are entities that are using it. We heard this say, support food bank and diapers. I don't believe that that's was the intent of the program, A, and B, it's a federal program that should be fought on a federal level. And, that's really, it's tough. I understand, but I don't think, again, giving our stamp of approval for activities that are, in my opinion, based on testimony we heard, questionable, is appropriate today. So, yeah, thank you. So the motion is ITL. All those in favor say aye.
Aye.
Opposed?
Opposed.
So you got 3-2.
I'll take it out.
Senator Avard's gonna take it out.
Second.
So all those in favor say aye.
Aye.
All right, we're back.
Go back.
We're back out of exec, out of recess. Let's go.
Can I do a quick bathroom?
Yes, go ahead. Yep. All right.
249.
Oh, right. We're ready. He doesn't want to watch the computer. All right, I gotta turn your mic off. John Williams, I would just stay back if I were you. Thank you.
We're going to open the hearing on Senate Bill 118 relative to personal needs allowance of residents in nursing homes. Senator Birdsall, you introduce your bill.
Thank you. Welcome, Sonia. Fresh face. For the record, my name is Regina Birdsall, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. I'm here as the prime sponsor of Senate Bill 118. As I said, I am the prime sponsor of 118, this is being made at the request of the Department of Health and Human Services. This bill seeks to amend RSA 167:27-A, Roman numeral 2, to adjust the personal needs allowance to reflect Social Security increases on an annual basis versus the current 5-year adjustment in current state law. Members are here to discuss Senate Bill 118, so I won't go on with it. But I also have a non-germane amendment that they had also requested to be placed on that one. And would you like me to present the amendment?
If that's procedurally, you'll have to teach me on this. A separate hearing. Okay, we're going to have a separate hearing on that afterwards.
All right.
Yes, thank you.
Well, with that, I will terminate my testimony and have the department come up and discuss.
Great, thank you.
Thank you.
So I have John Williams, Wendy Altman, and Brian Clark, but it said not speaking, but I'm assuming you're here to speak. So we're going to let you speak.
Chairman Rochford and members of the Senate Health and Human Services Committee, for the record, my name is John Williams. I'm the Director of Legislative Affairs for the Department of Health and Human Services. The other members that you had mentioned, Wendy Altman is our administrator for our Bureau for Aging and Adult Services, and also you are familiar with Attorney Clark, who also supports them from a legal perspective. This bill is straightforward, and I'm at risk of just knocking on whatever wooden object I can find. What it does essentially is taking the personal needs allowances that residents at long-term care facilities can receive, and then making those personal need allowances adjustable based upon the Social Security Administration adjustments, not on a 5-year basis under current law, but on an annual basis. That I think that Senator Birdsall, as our prime sponsor, completely testified about the substance of what this bill is about, and I have nothing further to say unless there's questions for the department. I want to thank her for her strong support of the department on this very important initiative.
All right, very good. Any questions? With that, do we close the hearing on Senate Bill 118 and then have us? Okay, good idea. Got a motion to move into exec.
Wait.
You closed it.
No. Yeah, we have to have a hearing.
We have a non-germane amendment.
Okay.
So let's close the hearing on 118.
Yep. You want to hear the non-germane
And then
amendment?
we'll open the hearing on the non-germane amendment to Senate Bill 118.
I like to move things along, you know what I'm saying?
I know, I like that.
Better
Okay.
be good.
Okay, so we're open the hearing on the non-germane amendment. We have Senator Birdsall to introduce her non-germane amendment.
Thank you, Mr. Chair. Again, for the record, my name is Regina Birdsall, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And I'm here to present Amendment 2025-0295S. And this is, again, made by the request of the New Hampshire Department of Health and Human Services. And this provides a one-time $160,000 appropriation to the department for the purposes of making certain leave accrual payments to temporary classified positions and any applicable bonus or retention payments prorated to the time worked in state service as part of the staff transition at Hampstead Hospital and Residential Treatment Facility. Additionally, the amendment establishes a capped fund for the purposes of supporting contractually required capital investments at Hampstead Hospital and residential treatment facility. Members of the department are here to speak on the amendment, but I will say that they had asked me to present this because obviously Hampstead Hospital is in Hampstead. And part of this bill I know is to allow the members that were transitioned, and you can correct me if I'm wrong, the members that were transitioned from the temporary state employees over to Dartmouth Hitchcock providers at Hampstead Hospital. While they were state employees, they were authorized sign-on bonuses, but they couldn't receive them once they became Dartmouth Hitchcock. So we're trying to prorate it so that they can get a portion of their sign-on bonuses.
Thank you.
All
Any
right.
questions for Senator Bertzel? Thank you very much. So, John Williams and Deputy Commissioner Marissa Hen.
Great. Good afternoon, Chairman Rochefort and members of the committee, Marissa Hen, Deputy Commissioner, and happy to speak to the context for the bill if that would be helpful.
I think, if there's questions, I think Senator Bertzel she was
great.
pretty comprehensive in what
You
she
got it.
asked, and she
She
kind of gave us the overview of what it does and why it's a non-germane amendment. And but if there's any questions of the committee, I'll open it up to questions. All right, with that, I'll close the hearing on the non-germane amendment.
Motion to move in exec.
Motion to move into executive session. We have a second. All right. Senator Abard.
Motion to move OTP on 118 FN.
I'll second that.
Thank you.
Yeah, you go so fast.
Yeah. And then there's an amendment.
Do we do the amendment? Yeah, okay.
Motion to, what's the amendment number again?
0295.
So moved.
And I'll second that. Any discussion on the amendment? All those in favor say aye.
Aye.
Opposed?
Motion
Passes.
to move out to pass as amended.
Pass and second by Senator Bertzel. All those in favor say aye.
Aye.
Opposed? Consent?
Consent.
I thought I heard you say that.
It's on my mind.
Yeah. We have a second from Senator Bertzel, I think.
Yes.
All those in favor say aye.
Aye.
Senator Bertzel, being your bill, would you like to take this out? All right.
Motion to move out of exec.
Second, we have a second. All those in favor say aye.
Aye.
Aye. All right. Almost there. Senate Bill 249 will be next.
This is a biggie.
Yeah.
You can't exec this today.
All right, open the hearing on Senate Bill 249. Senator Bertzel, your bill.
Thank you, Mr. Chair. Thank you, committee, for hearing Senate Bill 249. I am the prime sponsor. And for the record, my name is Regina Bertzel, State Senator for District 19, encompassing the towns of Derry, Hampstead, and Windham. Just a little bit of history. This is uncompensated care and Medicaid fund. This is the Met Dish issue, which we've been struggling with since Committee of Conferences last year. And just to give a little bit of history, what is MET? MET stands for Medicaid Enhancement Tax. And I want to thank our attorney, Kate, for giving me this info because it kind of gives it kind of a simplistic. The MET is a 5.4% assessment upon the net patient services revenue of certain hospitals for each hospital's fiscal year ending during the calendar year in which the taxable period begins. Met revenues in 2024 totaled $319.2 million. A non-binding estimate of Met revenue for fiscal year 25 is due to DRA from the hospitals by January 15th, 2025. Who pays the Met? The assessment is paid by general hospitals required to be licensed under RSA 151 that provide inpatient and outpatient hospital services. The assessment is not paid by government facilities or rehabilitation hospitals by statute. Now, what is DISH? DISH stands for disproportionate share hospital payments. These payments are for hospitals' uncompensated care made by the Department of Health and Human Services to hospitals that do not meet the definition of critical access hospitals, but provide essential access to hospital services. DISH payments are determined via amendment to the New Hampshire Medicaid state plan each year. And the Met revenue is deposited into an uncompensated care and Medicaid fund, which is used by DHHS to generate a federal match on hospital payments. The federal match rate for DISH payments is 50% and is up to 90% for rates-directed payments. Now, how do Met and DISH work together? Hospitals are required to pay the 5.4% on the net patient services revenue. The tax is collected, and then a total fund, state and federal, equivalent percentage, historically 91%, but currently 80%, is paid to the hospitals via enhanced inpatient rates, directed payments, and DISH payments. I can go on. I'm sure the hospitals are here. They'll be talking a little bit about it. But leave it to say that during the committee of conferences last year, the Met-DISH agreement had expired, and we were trying to put something together. I know Senator Bradley at the time had tried to put something together, and the governor chose not to accept that. So the governor brought forth a percentage of, instead of the 91%, brought it down to 80%, and that's where we are right now. So my bill just mirrors what is in the governor's budget right now, and for me, it's kind of a starting place for where we have to start. Again, I know that the hospitals are going to be talking to the governor's office in the next week to 2 weeks.
Great. Thank you. Any questions? Thank you very much.
Okay.
Steve Annan.
Steve.
Good. Thank you.
Good afternoon. For the record, my name is Steve Annan. I am the president of the New Hampshire Hospital Association, and I'm here representing all 26 of our community hospitals who pay the Medicaid enhancement tax that Senator Birdsall just outlined. I'm going to ask the chair's indulgence. I know we like to move testimony along pretty quickly, and I will do so as quickly as I can. But this is a very complex issue with significant implications for hospitals as well as the state. So I'll just beg for a little bit of indulgence.
We've gotten this far. I will let you indulge.
All right. You have my testimony, and I'll ask that it be admitted to the record. Again, I won't read through all of my testimony, but I will reference a number of things from it. So New Hampshire's Medicaid program is a shared commitment among hospitals, other providers, and state to ensure access to high-quality care for our most vulnerable citizens. Ensures that patients are able to get the right care at the right place at the right time. It's important to remember that for hospitals and other providers that provide services to Medicaid patients, we lose money doing so. And this committee and every one of you knows very, very well, in the last state budget, You made historic investments in Medicaid rate increases to help offset the losses that providers see. Hospitals chose not to accept those rate increases so that others, behavioral health, substance use, long-term care, home and community-based services, home care providers, could receive larger increases so that they could serve more patients out in their community. So again, you understand the challenge of the Medicaid program, and we appreciate that. We appreciate Senator Bertzel's introduction of Senate Bill 249 as a starting point for this conversation. As she noted, and as we have said before, unfortunately, we don't believe it is the ending point because this has significant implications and losses for hospitals across the state and significant losses from the prior agreement. So I want to do just a little bit of how did we get here. Senator Bertzel kind of talked a little bit about what MET and DISH are, but MET and DISH began back in the early 1990s. The state was facing a significant financial crunch, and other states were using a new mechanism to draw down additional federal dollars to support their Medicaid program. Those mechanisms were using provider assessments. So assessing provider hospitals, there are 19 different classes, and hospitals would pay that assessment. The federal government would match that and use that for the Medicaid program. Hospitals agreed to do that with the objective of obviously not harming themselves in doing so. And for almost 2 decades, that's exactly how the program worked until federal rules and regulations changed, and New Hampshire had to modify its program in the 2011 plan year. At that time, we finally had hospitals that were paying more in their MET assessment than they were receiving back in benefits. But it really became a crisis in the 2012-2013 budget when all hospitals were assessed the MET, but only the 13 critical access hospitals received a DISH payment. At that time, there were a couple of different lawsuits that began challenging the constitutionality of the MET. Hospitals obviously provide inpatient services. There aren't others that do that, but there are many others that provide outpatient services, yet they don't pay the MET. And 2 Superior Court judges found the MET to be unconstitutional. As Judge Manjones noted, that there was no distinction between hospital and non-hospital providers, and therefore no reason to not be applying the MET to both. And therefore, the MET was found to be unconstitutional. After both of those decisions, the state and hospitals sat down and worked together to continue a partnership that allowed us to continue to pay those MET payments in return for fair and reasonable returns. That's really important for state budget writers, it's important for hospitals, and frankly, it's important for Medicaid patients to ensure that they're able to get the care that they need when and where they need it. And, we've maintained those settlement agreements over the last decade in partnership in a way that I think has been really, really helpful. It's really important that we get this resolved prior to the April 15th deadline that hospitals will be paying their Medicaid enhancement tax. And as Senator Bertzel indicated, they sent non-binding estimates to the Department of Revenue Administration in January that said they would be sending in $348 million in Medicaid enhancement tax revenue in April, which, when matched, is more than double. So over $700 million for the state's Medicaid program is funded through this mechanism, and unfortunately could be at risk. And as we've looked at this model, the 80% model, prior we used to get 91%. At 81%, hospitals across the state will receive $70 million less. Now, in total, it's about a $40 million cut. But for many of our hospitals, mostly our larger hospitals, they will see a $70 million reduction in funding coming to them, which in essence is really a $70 million tax increase on them, while the state will be receiving an additional $67 million over and above the prior agreement. Hospital leaders are here today, and they will come up and they will talk about what the impact of this is on them and their ability to continue to serve the patients and communities who depend on them. Hospitals continue to struggle financially. Last year, hospitals had a negative 0.4% operating margin, or not-for-profit hospitals, that is, and those challenges continue. Last week, we just reported about the increased demand for care, essentially at 100% capacity last week because of the flu and other respiratory viruses that are hitting New Hampshire and the country very, very hard right now. Ongoing workforce challenges, the inability to discharge patients to appropriate settings that you all have talked about today. Those challenges are very, very real. And all of that will no doubt cause hospital leaders to have to look at all of the things that they're able to do in their communities if they're forced to accept these kinds of Medicaid reductions going forward. There is a better way, Mr. Chairman, members of the committee. We believe that we can build upon the partnership that has existed and do so in a way that is a win-win-win. A win for the state, a win for the hospitals, and most importantly, a win for our Medicaid patients. What this does is it builds upon the framework that exists today. As Senator Birdsall noted, the state assesses 5.4% of hospitals' net patient services revenue, and that money is received, and that money is used to receive federal matching dollars from Washington. Federal government will allow states to make those assessments up to 6%. Hospitals would be willing to do that as long as those payments that come back continue to be fair and reasonable. We believe that using the existing framework that Senator Birdsall talked about, that the Medicaid program has already started using these dollars to invest in increased rates, invest in directed payments, as well as dish payments. We believe we can build upon that model and do so in a way that supports our hospitals and supports the state. There are reasons why we want to move to directed payments. Many states around the country are already doing this, and it's a way that we can actually, it's an add-on payment for a Medicaid service. It's based upon utilization, and that service generates an enhanced match for New Hampshire. Right now, our federal medical assistance percentage is 50%. Because of our participation in Medicaid expansion, as well as the CHIP program, when we make those payments, we receive an enhanced federal match, meaning more federal funds are coming to New Hampshire to support our Medicaid program. Based upon the model that we have seen, that we have done, we believe the state will generate an additional $104 million annually to support the Medicaid program. And those dollars could be used to support essential Medicaid services such as behavioral health, substance use services, community health centers, and others. It would also provide additional resources for hospitals to help support them in the work that they do, and again, providing a reliable and predictable revenue stream for them. But be certain, this is not a windfall for hospitals. There will still be hospitals that will pay more in their assessment than they get back in benefits. And I want to say, hospitals across the state have worked very, very hard and collaboratively to find a solution that works for everyone, even if it means they may still be on the short end, because they understand the importance of what this means for everyone and what it means for the state's Medicaid program. And again, our goal is to find a way to resolve that in a very, very constructive way. So in my testimony, there is a one-pager that you have that I'd like to just walk through very, very briefly. And it looks at the two different, what we have in current law and what our proposal would mean, and what the net impact is against what, not only the payment, but against the prior agreement. So if you look at that first line under current law, the assessment rate is 5.4%. 80% would go to the hospitals, 20% to the state, plus 100% of the match on all of that would come back to the state. The net impact for hospitals in New Hampshire would be essentially $70 million loss. That's $40 million worse than the last agreement. If you move over to the right, the net impact for the state, they would be receiving $416 million in total revenue, and that's almost $68 million more than the prior agreement. If you look at the second line under our proposal, the assessment rate at 6%, we can talk about how we would distribute all of that. But I think the most important thing to understand is the net impact for all hospitals would be slightly positive. But as I said, there will still be hospitals that end up in the red as a result of that transaction. But again, overall, we're positive. And the difference from the prior agreement would be $36 million more. Again, for the state, the net impact would be almost $452 million in total revenue and almost $104 million in revenue beyond the prior agreement. So, Mr. Chairman, I'm going to end where I started, which is we appreciate the opportunity to sit down and work with you to find a solution that is a win-win-win. That is our goal. It has been our intention all along, and it is certainly a much better approach than tremendous uncertainty and controversy that we would like to avoid. But again, this is an important matter that needs to be resolved, and we need to have certainty as we move into the spring and that April 15th payment.
Great.
Happy to answer questions.
Thank you. Thank you for your testimony. You made it very clear. So currently, if we go with what we have right now, we're looking at 67 million going back to the state. But if we do the direct payment system, we're looking at 9% or 5.4% goes back to the state. Is there right?
So I think it's important to understand that the current model, the 80% model, does envision using directed payments for the state. That's partly how the state generates the additional $67 million. Under the proposal that we have laid out, what we would say is, so for the first 5.4% of the net revenue that is raised, 91% would come back to the hospital, as has traditionally been done. 9% would go to the state, and the match on all of that would go to the state of New Hampshire. What we're saying is, since hospitals are willing to pay that additional assessment, that the amount above 5.4% that is generated through the assessment plus the match would come back to support the hospitals. And by doing that, we're able to minimize the losses to the greatest extent possible and maximize the reimbursement for the federal government, which, as Senator Birdsall noted, was one of the priorities and principles that we were working with Senator Bradley on last spring to try and find a reasonable solution to this matter.
Yes. So there's a net gain for the state as well, right?
Absolutely. There's 103, almost 104 million net gain for the state of New Hampshire on an annual basis.
And one final, if I may, Mr. Bruce, how difficult is this process changing this over?
Difficult? Well, we've already started that process. The state has already submitted the appropriate materials, and Henry Lippman can sort of add to that for the rate increases that have already been put in place, as well as directed payments. So this really isn't a lot different than what's already been done. There's just more funding available to support all of that.
I'm not sure why we're not doing it.
I'm sorry?
I was talking out loud. I'm sorry. Just thinking out loud.
Thank you.
Question, Senator Birdsall.
Thank you for coming in. Have you had a conversation with the governor's office at this point?
We've spoke to the governor several weeks ago and looking to engage that conversation very, very soon. And so hope to do that in the next several days or weeks.
Okay, thank you.
Any further questions? Thank you very much.
So I'm guessing, where do we go from here? I mean, do we go forward with this bill, or do we have an amendment, or you have some language change, or?
We would definitely need an amendment to that bill to affect the changes that we've outlined, and we'd be happy to work with you to help provide that language if you would like us to do so.
Question?
So the governor.
Well, and not so much a question as a comment that I think we need to hear from the governor's office, and it's really up between the governor's office and the hospital association to try and get an agreement, and then we can amend my bill to whatever they agree to.
So March 5th. We've got to have this bill out of here March 5th. We'll hold on to it until then, but if we can get some dialogue going, or if you're meeting with them in the next several days, that would make our job a lot easier.
I would love to make your job easier, but at the end of the day, what we need to do is find a solution that is in the best interests of the state, Medicaid program, hospitals, and frankly, our patients. That's our obligation, and that's what we want us to do.
Very good. Any questions? Any further questions?
Thank you.
No, thank you very much.
Thank you.
You provided some good information to us. Thank you. John Jerzyk.
It's because it's nice. But it's in services rendered.
Good afternoon. Thank you.
Oh, there we go. All right, my name is John Jerzyk. I'm the president of St. Joseph Hospital in Nashua. In full disclosure, I also serve as the secretary treasurer for the New Hampshire Hospital Association. So I want to thank you for the opportunity to speak on Senate Bill 249 on behalf of both St. Joseph Hospital and NHHA. Today, I want to talk about, if the language is not amended, what that impact is to just one hospital, and that being St. Joe's. And that is, as written, this bill would jeopardize the financial health of hospitals like ours, which provide critical care to some of the most vulnerable patients in the state's second largest city. As a hospital that delivers both inpatient and outpatient services, we often shoulder the burden of uncompensated care for individuals who lack insurance or cannot afford necessary treatments. While Senate Bill 249 ensures that hospitals like ours will continue to receive Medicaid payments, it falls short in ensuring that access to services are not interrupted. The bill allocates 80% of funds collected under RSA 84A to hospitals starting in 2026, and that is an 11 percentage point drop in funding compared to last year. I would argue that even at the 91% current funding level, hospitals in this state will struggle to fund key programs that have been part of their mission despite negative or razor-thin margins. At present, the state has several rural areas that are maternity deserts and struggling to build capacity in behavioral health and substance use treatments. We, the hospitals of this state, are your community assets. We treat all patients regardless of their ability to pay and maintain their care, even when the barriers to discharge prevent them from moving to the next and most appropriate level of care. So service lines, as we refer to in the industry, are specialty services like inpatient psychiatry. Specifically, St. Joe's operates a geriatric psychiatry unit, one of 4 in the state. Maternity care and outpatient pediatrics generates losses in the millions for most hospitals. For St. Joseph Hospital, those three service lines generate a combined loss of $8 million annually. Additionally, all of our community work in the mobile health clinic, which serves underserved populations, homeless populations in the greater Nashua area, we do not support that to really, there isn't enough revenue generated for that program, so we support that largely through donors and donations. As written, SB 249 will create a loss of $6 million for St. Joseph Hospital. That is $1.75 million more than under the prior agreement with the state, and jeopardizes the viability of those 3 programs I mentioned. Those programs touch over 12,600 unique patients in the greater Nashua area who will now be at risk because we're unable to continue those services because of declining revenues. Our hospital is not unique with this impact, as we are one of 9 hospitals out of 26 in the state of New Hampshire that posted an operating loss in 2023. Additionally, the bill would not maximize federal matching funds, ensuring that our state secures the highest possible level of support. And with the greater allocation of hospital net revenue to support the Medicaid program, both the state and its hospitals will benefit through increased federal match. The financial viability of key services will not be greatly impacted, and the state resources are protected with the increased match. I plead with you in stating that the bill needs to go further and not leave millions of dollars of federal matching funds on the table. I urge the committee to modify Senate Bill 249 to safeguard hospital services and protect access to care for all New Hampshire residents. That is my testimony. I'll take any questions.
Thank you very much. So I'm assuming that you're familiar with this chart that we received?
Yes.
And that's, are you supportive of that, obviously?
Yes.
And that would be the formula that you would agree with?
Agreed.
Yes. Thank you, Senator.
And thank you for your testimony, for driving all the way up here. It is a dumb question, so bear with me.
There's no dumb question.
Oh, yes, there is. I'll prove it. The assessment rate is how is that collected? How is the assessment collected?
How is the
Yeah, there's a 5.4% assessment rate. We're going to bump it up to 6%. How is the assessment collected?
That is usually paid on April 15th by each of the hospital.
That's it. That was the question.
Okay. Any other questions?
Any other questions? Thank you.
Thank you very much.
Holly McCormick. Thank you very much. Welcome.
Thank you. Good afternoon, Mr. Chairman and members of the committee. My name is Holly McCormick, and I'm a registered nurse as well as the President and Chief Executive Officer of Cottage Hospital. Cottage Hospital is a critical access hospital located in Woodsville, New Hampshire. It was founded in October of 1903, providing care to our community for more than 120 years now. Our hospital service area includes more than 25 towns. We provide many services to our communities in our hospital and multi-specialty rural health clinic. These services include emergency care, primary care, inpatient care, surgical services, orthopedics, endocrinology, podiatry, urology, laboratory services, and radiological services. In addition, Cottage is the only hospital with a trauma designation in the North Country. Cottage is also the only critical access hospital with a 10-bed geriatric psychiatric distinct part unit in the state. And this specialty unit has provided care to residents from 110 of New Hampshire's 221 towns. Since the pandemic, Cottage has experienced a steady increase in volume. Unfortunately, our expenses continue to outpace the increases in volume and revenue. And to remain competitive and recruit and retain competent staff, Cottage Hospital had to increase staff wages significantly. Our salary budget is 28% higher than it was in 2019. And despite these increases, recruitment and retention continue to be a struggle, necessitating travel and locum staff. From 2016 to 2019, Cottage Hospital spent an average of about $800,000 a year on travel staff. From 2020 to 2023, the average spend on travel staff per year was about $3 million, and in 2024, the spend was $4 million. This exponential increase in just one category of expense that has had a dramatic increase. Drug costs have also increased by 25.6% from 2019 to 2023, and overall hospital supplies have increased by 42%. The result of the increases have been a negative operating margin for Cottage Hospital. In a traditional business model, these increases would be passed along to the consumer, and there's an erroneous belief that hospitals are a lucrative business, and that simply is not true. In healthcare, we cannot follow the path of traditional for-profit business. We must be here to provide care to all in our community, regardless of their ability to pay. Cottage Hospital opposes the current amendment to the state's Medicaid enhancement tax. Under this reduction, hospitals will be harmed, and the healthcare system in New Hampshire is already stressed and cracking. The amended changes would take millions away from the state's hospitals, and I fear that some will not survive. The loss of our hospital, or any other in New Hampshire, will result in harm to the citizens. The impact on access to care will be magnified. Patients seeking emergency services, primary care, behavioral health, or any other specialty will experience a detrimental impact. Decreased access leads to prolonged waits, delays in care, and overall harm. In a time when we strive to impact and improve healthcare equity, we will achieve the opposite. As an independent critical access hospital, Cottage is not part of a system. However, this does not mean we provide care in a vacuum. The hospital system in New Hampshire works collaboratively. For example, when a patient arrives in our emergency department having a heart attack, or a STEMI as we call it, there's precious little time to provide the life-saving care that is required, which is a procedure called a cardiac catheterization. According to the American Heart Association, this procedure is most successful when performed within 120 minutes of first medical contact. Most critical access hospitals cannot provide the life-saving procedure, necessitating a transfer to one of the state's 13 larger PPS hospitals. Losing even one of these hospitals would gravely affect their survival of patients experiencing STEMI. A heart attack is just one example of a patient diagnosis that frequently requires a higher level of care than a critical access hospital can provide. It's not unusual for patients requiring a higher level of care to board in our emergency departments for 6 to 8 hours as we try to find an appropriate bed. It's also not uncommon to expand the search to the Boston area due to New Hampshire hospitals being at capacity. As Mr. Anand stated in his testimony, this flu and respiratory season has resulted in hospitals being at 100% capacity. Cottage Hospital has another unique attribute, our 10-bed acute geriatric psychiatric care unit. This unit is the only 10-bed distinct part unit dedicated to serving the older population in the state offered by a critical access hospital. The Ray of Hope, named in 2016 to honor former Executive Council Ray Burton, serves our primary service area and the entire state of New Hampshire. We have helped approximately 1,000 patients since the unit opened in October of 2016. New Hampshire needs these 10 psychiatric beds. Due to provider shortages in behavioral health, the unit struggled to recruit a psychiatrist to oversee the unit. And through a partnership with Dartmouth Hitchcock Medical Center, we secured the services of a psychiatrist to provide the oversight. In turn, the Ray of Hope at Cottage provides a setting for students to experience a unit dedicated to geriatric psychiatric care. These are just a couple of examples of the symbiotic relationship between New Hampshire's critical access and the larger PPS hospitals. There are more examples of sharing of resources and provider staff. At Cottage, we also rely on agreements with Dartmouth Hitchcock Medical Center for services such as pathology, reference lab, and radiology. The changes to MetDish, as they currently stand, would make finding a path forward difficult, if not impossible, for many of the state's 26 hospitals. And I shudder to think of the implications for our patients and communities if a hospital or clinic services are lost. The system in New Hampshire is a delicate balance where all of the hospitals collaborate and contribute to achieving the goal of providing high reliability care in these challenging times. In addition to patient care, Cottage Hospital also provides over $2 million yearly in community benefits. We support students in our local high schools, provide training opportunities for students from River Valley, Riverbend, Plymouth State University, University of New England, and White Mountain Community College. Cottage Hospital has formed a licensed nursing assistant training program, and we have now graduated more than 40 LNAs. We are one of the largest employers in our community with 317 employees. The same is true for many of the other hospitals in New Hampshire. The changes to MetDish as directed at 80% will seriously affect our ability to continue as a cornerstone for our communities and the way healthcare is delivered in New Hampshire. I urge you to oppose the current Met Dish directive and work collaboratively with hospitals to develop a win-win solution that will benefit the state, our healthcare system, our hospitals, and health of our citizens. Thank you for the opportunity to testify.
Thank you very much. I was wondering if you could explain to the committee a little bit how Cottage Hospital is affected a little differently than other hospitals, being a border hospital.
Yes, so being a border hospital, we still, when we pay our assessment, the Medicaid enhancement tax, we are taxed on our total revenue. And so that amount is the amount that we are completely taxed upon. But we do serve residents in New Hampshire and in Vermont. But that total net patient service revenue, which contains Vermont citizens, is an amount that we're taxed upon.
So you get your tax for everything, but you only get back for your New Hampshire patients.
Yes.
Yes, thank you. Any questions? Thank you very much. Matthew Hood.
Hello again, Mr.
Welcome
Chair,
back. It's been
members
a
of the
long
committee.
day.
For the record, my name is Matthew Hood, Vice President of Government Relations at Dartmouth Health. I do know it's been a long day, so I will try to keep my remarks concise, but I did want to, at least at the beginning, reiterate what I think you heard earlier today, which is Dartmouth Health is kind of the umbrella structure for a 7-hospital system. It includes the Academic Medical Center in Lebanon, Mary Hitchcock Memorial Hospital, plus the clinics in Nashua, Manchester, and Concord, as well as the Cancer Center and the Children's Hospital. But it also includes hospitals, Cheshire Medical Center, a Medicare-dependent hospital, and 3 critical access hospitals, Alice Peck Day, Valley Regional Hospital, and New London Hospital. I'm here today to speak to I realize this is a starting point, Senator, but the implications of starting at 80% for Mary Hitchcock Memorial Hospital are roughly $25,000 difference between what we pay in MET and what we would receive in disproportionate share hospital payments. Alternatively, almost $26 million in the difference in what we would receive in disproportionate share hospital payments tomorrow versus what we received under the previous agreements. Those are fairly significant amounts to absorb. And in fact, what I would be here and argue is that we can't simply absorb those costs. You can't absorb those seamlessly. You've heard wonderful testimony about some of the programs that people are fearing or would be at jeopardy as a result of the cuts of the implications of this size. And I could spend a lot of time talking about some of the services that we, Mary Hitchcock Memorial Hospital and Dartmouth Health, provide as partners with the state of New Hampshire and other partners. Substance use disorder services, we operate 2 doorways among our members, providing clinical services at New Hampshire Hospital and recently Hampstead Hospital for mental health services, et cetera. But what I wanted to focus on today was the rurality, the rural nature of some of the concerns that I have for service diminishment and retrenchment if this model were to move forward. We've spent a significant amount of time and energy investing in telehealth services, including specialty services in telehealth, to provide access to the rural population that we serve. We also partner, as you heard just now, with other providers in terms of mitigating the risks of maternity and OB deserts. And finally, we have established remote clinical sites. So if you were to ask, what might you do in the face of this type of reduction, we would have no choice but to scale back some of the investments that we make with our community partners. Would we look at retracting on a distant site so that people they'd still get care, but they'd have to drive further to get to the care where we have centralized locations. That is true, or that would be a potential. They're not a clinical category, rural people who need to drive further distances, but they're an at-risk population. And so what I would just beseech you to recognize the threats and challenges that exist with maintaining the access levels that we've established today. Thank you.
Thank you. Any questions? Senator Apprentice.
Thank you, Chair Rochford. And Matthew, thank you for taking my question, and good to see you outside of the Upper Valley. So just thinking about the big picture, I mean, so you would have to basically recalibrate. And what is that going to cost you both, in terms of dollars, but in terms of the way that you that Dartmouth Health operates? All
Yeah.
the certain, like thinking about the services that you deliver, I mean, where do you take the hit?
Yeah, I appreciate the question, Senator. Because it reminds me of something that I wanted to indicate, which is, sometimes you're asked, if you can't absorb these, why can't you absorb these costs, find efficiencies, et cetera. I would want to make sure to note that in fiscal year 22, we actually facing financial challenges, we implemented a performance improvement plan to find $120 million in savings for expenses. And it's not a question of being more efficient at this juncture. It's not a question of margin. I mean, our margin, you've heard what the margins of hospitals are. Ours for fiscal 24 was 1.75%. And as of 6 months through 2025, we're at 2.8%, though I will suggest that we expect that margin to diminish significantly with some of the work that we're doing as a mission important project at Hampstead Hospital and others. So we'd have to ask some of those difficult questions that I suggested about our footprint in rural areas and how much we can partner with and support our stakeholders in the community and region.
Fair enough, thank you.
Any other questions? Oh, thank you very much.
Okay, thank you.
I have Jessica Crowley, who signed up but crossed off. I didn't know if she was here and wanted to talk. Anyone else that would like to speak on Senate Bill 249? With that, I'm going to close the hearing. We're done.
Motion to excuse us.
Motion to adjourn. So, yes, we're adjourned. We'll see you all in 2 weeks.